Good morning, everyone. Warm greetings. We welcome all our dignitaries, speakers, and our dear delegates. We welcome you all to the day two of the 6th World Dental Sciences and Oral Health Conference organized by CynoDent, International and Indian Society of Dentistry in collaboration with Kalinga Institute of Dental Sciences, KIIT University Bhubaneswar, University of Toronto, and University of Genoa. Theme of the conference is bringing in the future of dentistry now and beyond. 25th and 26th February, we had pre-conference courses and online scientific presentations. 27th, we have started with our keynote lectures and award nights and cultural program in the evening. Today on 28th, we are having our keynote lectures following by valedictory function. I would like to invite Dr. Abhishek Dubey on the stage for his lecture. Hello, hello. Hello. Good morning, respected sir, and to all the other members present. So my topic today is impressions in complete denture. It's one of the most simplest but one of the most important topics that we need to know. Dentistry, one of the major factor that plays a vital role in the success of your processes is an impression. If you have a good impression, whether it is a complete denture or a removable partial denture or a fixed denture, so if you have a good impression, you can make a good process out of it. So let's see what all we can cover today. This is my current movie, if you can say, that in my dental college and hospital, Rishikesh, Dehradun. I'm a lecturer here. I've done my post graduation from this college, and as it's always said, that you should never forget the hands that raised you. So he is my guide, my guru, Dr. Professor Himanshu Erin sir. He is the one. So what all would be seeing in this journey that we have of 45 minutes or so? We'll see the introduction part, the definitions, history, classifications, some of the recent advances that I can tell you, the clinical implications. So what exactly are impressions? Okay, what do we understand by the term impression? So let's find out what we dealing today. A beautiful smile is a great impression, but it's the great impression that makes a beautiful smile. Okay, obviously, whenever you meet a person, your smile is the first thing that the person notices. Okay, so obviously, a great, beautiful smile is a great impression. But until unless you have a great impression, you cannot make a beautiful smile. That is from a dentist point of view. So let's see what impressions in dentistry are. Impressions you can deal with in a very broad way. Okay, impressions can be of a complete denture, of a removable partial denture, of a fixed processes, whether it's a crown, a single unit crown, or a bridge, or you can do a full mouth rehab, or it is an implant. Okay, so let's see for that. What exactly are we dealing with today? First and foremost, whenever you have a topic, okay, whether it's impressions, jaw relations, or trying whatever it is, let's try and define it, what we are trying to achieve there. So as Hartwell states, an impression is a imprint or a negative likeness of a teeth or edentulous areas made in plastic materials which become hardened or set while in contact with the tissue. So first and foremost, remember the part that impression will always be negative replica. Okay. Whenever there is a thing that you need to take an impression of, what the impression that you get is a negative thing. When you pour a cast or anything out of it, that would be the positive replica out of that. So as another definition that Devan states is that an impression is a perpetual preservation of what already exists and not the meticulous replacement of what is missing. So there's a very beautiful theory that Devan states that as a dentist, okay, don't just look into the rehabilitation part or what is the replacement part in simple terms. Okay? Try and preserve what is left. Whether you can do a conservative approach, you can do a periodontal therapy, XYZ, but try and preserve what is remaining. So this is what we call as our Bible, that is your glossary of prosthodontic terms. It's very important for us. It keeps updating. So the latest that we have in April, that is a dental impression, is a negative likeness made for the purpose of diagnosis, treatment planning, or fabrication of a custom impression preload. That is, what is the reason of making an impression? Whether you want to diagnose the case,
You want to treatment plan it, or you want to make a this custom tray out of it for a complete denture patient. Impressions in complete denture. There's an impression, negative registration of the. These words are very important for a complete denture point of view. Entire denture bearing, stabilizing, and border seal area. Okay, the entire extent till where your denture is going to be present. The stabilizing areas, if you want to clearly know about it, you should go through your anatomical landmarks. The primary stress bearing, secondary stress bearing, relief areas. Okay. So now we come to the needs. What makes an impression material an impression material? Can you call a composite an impression material? No, it has different properties. Okay, you can't call GIC an impression material. It is used for something else. So what is it that makes a material to be used as an impression material? So first and foremost, the manipulation should be easy and viscous enough to contain in a tray. जब भी आप impression लोगे, you need that material to be viscous enough, okay, to be hold on onto the tray so that you can place it in the patient form. Fluid enough to flow in the oral tissue and set within the setting time of less than 7 minutes. Okay, though it should be viscous, but it should be fluid enough so that it goes into the tissues and gives you a good record out of it. Adequate tear strength. ऐसा नहीं हो ना कि when you are removing the impression tears off. So what's the use of making that? Okay, so it should be adequate tear strength, dimensionally stable after setting. Okay, 15 minutes is what we call as an ideal time between an alginate impression to take an impression and pouring of the impression. So it should be dimensionally stable after it is done and biocompatible, and the most effective from a Indian point of view, it should be cost effective. अगर आप 1000 रुपए का impression material लोगे, so how are you going to charge your patient? Okay, it should be cost effective, not very heavy on your pocket, so that you can use it properly. Now comes the classification. Now that you've heard so much, these are the definitions, these are the ideal requirements. How will you classify an impression material? What are the basis of classification of that? So based on the amount of pressure applied. Okay, when you're taking an impression, you are applying some pressure on it. Okay, so based on that, there is mucostatic, mucocompressive, and selective pressure. Okay, very important from your second year BDS to your final year. Every time any other person in your Viva will ask you what are the basic impression techniques. So mucocompressive, mucostatic, minimal pressure technique. There is one more, selective pressure. Okay, so there are 4 things: mucostatic, mucocompressive, minimal pressure, and selective pressure. But 3 are the major techniques that we use. The minimal pressure technique, okay, the major disadvantage was that there was no benchmark or a standardization कि इतना ही pressure लगेगा तो it is minimal pressure technique. Because if I am taking a impression, if I am applying 10 lbs of pressure, someone might be applying 15 lbs, someone might be applying 5. So there is no standardization of that. That is why we don't talk much about that. But these 3 are the basic techniques of an impression making: mucostatic, mucocompressive, and selective pressure. So first, let's talk about the mucostatic one. When you talk about mucostatic, you understand muco means comes, okay, mucosa, static means it's at rest, there's no pressure applied. Okay, so in that case, you need to use a material like an impression plaster, zinc oxide, eugenol, or for an easier application, alginate. These materials, when you use them, they will not apply pressure. But the complication that you get to see when you take a mucostatic impression, okay, of a complete denture patient, that means you're recording the tissues at a state of rest. So when if you fabricate a complete denture in this technique, okay, when you're using the complete denture, when you put pressure on that, the denture will dislodge. Clear? Okay? You are recording it in a static thing. Okay, so that means there is no pressure. So when the patient masticates, when the patient starts to chew on it, the denture is not fabricated for that. So it will obviously dislodge. So the patient will come to your clinic stating, "Doctor साहब, ये जबड़ा बैठ नहीं रहा है, हिल रहा है, गिर गया." ठीक है? So to overcome that, let's apply some pressure. So it comes to mucocompressive technique. Now mucocompressive technique, what it does, it will apply pressure on your mucosa. Okay, you have to use a material that which applies pressure, like your impression compound or your putty. Okay, elastomeric impressions for that thing. So when you use these materials, these are viscous enough. Okay, they will apply pressure to your mucosa so that you record them. Now what happens is you have recorded those tissues in a compressed state, right? So if you fabricate a complete denture in that state, okay, even if you don't want to, the tissues will always be compressed. So जब use करेंगे, it is useful. When the patient is masticating, it is useful. But when the patient is at rest, okay, the gums need rest, obviously. Okay, if you go to calculate, there is hardly like 12 to 15 minutes in the entire day that your teeth are in contact. That is just during mastication. नहीं तो there's freeway space that you call 2 to 4 mm of freeway space. The teeth are not always touching. That means they are not always exerting pressure on your mucosa. In context to a natural dentition, okay, अगर if you compare a complete denture patient and natural dentition में क्या होगा? Each teeth, okay, it acts as an individual unit, right? If you put force on that, the teeth will compress in the periodontal ligament. Okay, so it will act as an individual unit. Whereas if you take the same thing, okay, if you take the same thing in a complete denture patient, the entire complete denture is a single unit. So if there is pressure exerted in one place, the entire denture bearing area is under pressure. Okay, so if you fabricate a prosthesis with mucocompressive technique, the entire denture bearing area will be compressed, leading to bone resorption. Okay, so if you want to read something about that, please read from your voucher. Okay, the wrinkler also, there's a very good chapter called as residual ridge resorption. Okay, it's a beautiful chapter. Atwood and Tallgreen have worked for like 25 years of their life for it. Okay, they've done the entire study for that. Please go through that. So अब we are confused. हमें प्रेशर लगाना है कि हमें प्रेशर नहीं लगाना है? प्रेशर लगा रहे तो सर बोल रहे हैं कि कैसा हो रिजॉर्प्शन हो जाएगा. प्रेशर नहीं लगा रहे तो पेशेंट बोलेगा कि डेंचर बैठ ही नहीं रहा. तो हम करें क्या? Right? So we'll find a common ground. We come to something called as selective pressure technique. अब selective pressure में क्या होता है? See, to just simplify it, ठीक है? यूनिवर्सिटी एग्जाम्स होते सबके ना, लास्ट में फाइनल ईयर के जो फाइनल ईयर या थर्ड ईयर जो भी यू गिव अ यूनिवर्सिटी एग्जाम, फाइनल एग्जाम का जब डेट्स आता है ना, तो हर स्टूडेंट रिएक्ट्स डिफरेंटली टू इट. जो वो पढ़ाकू वाले होते हैं ना, तो दे आर लाइक चलो एग्जाम आ गया, इट्स डन, विल बी हैप्पी. जो हम जैसे बैक बेंचर्स होते हैं, हमारी तो उठ जाती, नींद उठ जाती है कि अब एग्जाम्स आ गए, अब तो पढ़ना पड़ेगा, राइट? सो it's a different part. Everyone reacts differently to that pressure. The same thing happens in your oral mucosa as well. There are areas which are capable of bearing stress, that are called as your denture bearing areas. There are areas that need to be relieved. They cannot tolerate pressure. Okay, that are relief areas, and there are areas which can be both of them somewhat. So they are secondary stress bearing areas. Okay. So you need to know your anatomy well to understand that which are the stress bearing areas and which are the relief areas. For example, अगर आपका incisive foramen है, incisive foramen पे आपने अगर pressure डाला, it causes paresthesia to the patient. Okay, you cannot put pressure on a mandibular tori. You have to always excise it or remove it. ठीक है? Undercuts है, so you have to see which type of undercut is it. Is it a unilateral undercut or a bilateral undercut? Undercut मतलब समझता है ना? Who doesn't know what is an undercut? Anyone? Any deviation from your path of insertion is an undercut. In simple terms, ठीक है? अगर something has to go straight, okay, and there is a deviation from it, that part is an undercut. So if you have a unilateral undercut, मतलब सिर्फ एक जगह है, so it's favorable for you, okay, because it will give you more retention. It will help you in the locking thing, okay. If you have a bilateral undercut, it's unfavorable. So what you do, you either remove both of them, okay, or you remove one of it and keep the other one. By reason, anyone can tell me why bilateral undercuts are unfavorable? I say wild guess. Anyone? No idea? Okay, see. What happens is, if there is deviation, okay, if you have bilateral undercuts, so to engage both of the undercuts, you need to have a path of insertion. Okay, path of insertion is the way the processes will be placed. So you need to have a path of insertion which will help you engage both of the undercuts. So it becomes more than one path of insertion. Okay, maybe it has to go straight and then tilt. Maybe it has to tilt and then occupy that. Okay, so when there are more than one path of insertion, displacement becomes easy. More the number of path of insertion, okay, less is your retention. एकदम simple term. जितना ज़्यादा तरीके से आप उस प्रोसेस को बिठा सकते हो, it is more easier for it to displace. Okay. Now, based on the chemical composition of the materials that we have, you can have a non-elastic materials, synthetic elastomer, hydrochlorics. All this you must have gone through in your second year BDS during your dental material sciences. Based on the dentition that you are occupying, or for an edentulous area. For an edentulous, there is primary impression and there is secondary impression. For an primary impression, you use impression compound, alginate, impression clusters, and for secondary, you use zinc oxide, eugenol, and elastomer. Now the question arises is, why are we doing that? हमने एक बार primary impression ले लिया ना, cast बन गई. So why are we going to take a secondary impression also? So you need to know that primary impression, when you take from an impression compound, it's always an overextended impression. First thing, it's always an overextended. Second thing, it will always be mucocompressive. Impression compound use किया ना हमने, so it will always be mucocompressive. So कौन सा technique हमें use करना है denture बनाने के लिए? Selective pressure, right? So for that, you will fabricate your cast. You will apply your spacer. There are different types of spacers. Okay, you need to choose according to the clinical situation whether you want a partial spacer, you want a full coverage spacer. Okay, in that basis, you choose your spacer, then make your custom tray out of it. Okay, and then you do the border molding. Has anyone ever thought that we have always been told अपना pre-clinics में कि your borders of your custom tray should be 2 mm short? Why? Any guess? Why is it only 2 mm short? Why not 4 mm short or 5 mm short? Why? So why only 2 mm? Logical है ना? अगर किसी ने बोला है कि 2 mm short होना चाहिए कस्टम से, तो क्यों 2 mm short होना चाहिए? Interns, anyone? Any guess? So you can be wrong. But the what? Guess sir. Why only 2 mm short? See, I'll tell you. What happens is when you make it 2 mm short, okay, what material are you using for your border molding? Green stick, right? It has more fluidity, but strength है उसमें नहीं, right? It is more flowable so that you can record the deep parts and you can do a good border molding. आप जब movements करो muscles के, it is much better recorded. So it cannot withstand 2 to 3 mm से ज़्यादा height. If you give it more, okay, if your borders are like you trim it more for 4 mm or something, it cannot withstand that. जब क्योंकि आप उस पे layering करोगे फिर, it will not be recorded in a single layer. You will have to do at least 2 to 3 layers to occupy that. So when you do that, it will follow. It will not give you a good record. That is why all your teachers say that it should be just 2 mm short of the sulcus. Clear? कोई doubt अभी? Sure. Based on the manipulation, how do you manipulate your material, impression material? Okay, you're kneading it, you're doing a circular motion, you're doing a vigorous mixing. Kneading, may we all know, impression compound, fatigue, consistency, elastomer. Circular motion is a zinc oxide eugenol paste, and vigorous is your alginate. This is understandable now. Kneading matlab you need to knead your impression compound. You take a hot water, a gauze piece you put, and you knead your impression compound. Okay. Circular motions में and vigorous mixing. Your alginate, you cannot knead your alginate. Can you? No, na? Okay. So you need to vigorously mix it. based on the technique, whether it's a open mouth or a closed mouth technique. Based on the tray that you have, it can either be a stock tray or a custom tray. Stock trays are which you already have, your perforated, non-perforated. Okay, custom tray is what you specifically make for that patient. एक patient का custom tray हम दूसरे में नहीं use कर सकते, right? So custom tray is what you specifically make, and it can be used just for the bottom molding of that patient. Based on the purpose of impression, diagnostic impression. What does the name suggest? You will be taking an impression which will help you to diagnose the case. Okay. Primary impression, just like in complete dentures. Okay. And secondary impression. Primary impression, secondary impression. Primary impression, when you take with the impression compound and you fabricate a custom tray, you do a water molding. Okay. You take a wash impression on that. So that impression, final impression. Okay. You get better, accurate details which cannot be reproduced in the impression compound. That is why you do a water molding, so that you get better retention of that complete denture. What is the diagnostic impression? The negative replica of the oral tissues used to prepare a diagnostic cast, you can use for study purposes. Once, see, it's not always that you will get an ideal case. जो आप कर रहे हो अपनी pre-clinics में, okay, it is not necessary that you will always get that kind of case in your clinics. Once you start with your clinic, every patient that you treat is different. Okay, you cannot give penicillin to the just for one thing to everyone. Can you? There will be people who will be allergic to penicillin. Okay, so different people need different kind of approach for a treatment. So at times you will just by looking into the oral cavity, it would be difficult for you to diagnose the case. Or what type of undercut is it? What treatment plan should I go for? Do I need a pre-prosthetic surgery or not? Okay, there are too many things like the mouth preparation. Do I need to do it or not? How do I tell the patient here, ये denture बैठेगा नहीं बैठेगा? What is your problem? What can be done from our end? Okay, so you in those cases, it's very important if you are confused with even single percent. Okay, may or may not. If you get that question, okay, always make a diagnostic impression. It's always easy for you, and it is always easy to educate the patient. Okay? So and so is your problem. That is why we have such and such complications. Okay. Primary impression is made for the purpose of diagnosis or construction of a tray. There should be at least 5 mm clearance between the stock tray and the ridge, so that your alginate flows and you can do good movements out of it and get proper depth of the vestibule. The tray should extend over the havelar notch and the tuberosity, and in mandibular it should cover the retromolar pad area. And the tray can be extended using a molding wax. There are times, this is very important here, there are times in your clinics when you have a patient who has a smaller jaw. You have your U2 and U3 trays, right? Sometimes you can just place a U2 tray. U3 can, you just cannot place the U3 tray. Okay, but the U2 tray is short. So what you will do, you will use a modeling wax to just extend that tray a little, so that you record the areas properly. Now, what are the objectives? Why are we doing it? We know the definition now. We now know the need of an impression material. Okay, we have classified them. Now let's see what are the objectives of the impression making. Retention. Okay. Retention by far the most important part in a complete denture. To make a balanced denture, you make very aesthetic dentures, wax up, carving, root carving, सब कर दो. अगर वो denture उस patient के मुंह में रुकेगा ही नहीं, so what's the use? Right? So it's very important, the retention part. Aesthetics. Okay. It should look beautiful. Your impression should look like it's being made by someone who knows what he's doing. Okay. Stability and support. There's one thing that is missing in this, which I can tell you is preservation of the remaining tooth structure or the tissues. Okay. So there are basically 5 objectives of impression making, which you need to very well know. Okay, retention, stability, support, the three major parts, aesthetics and preservation. Now, what are the factors that will affect your retention? Okay. Anatomical factors, physiological factors, physical factors, muscular, mechanical. These सब आपको book में you'll read. I'll just tell you something which should give you a hint कि क्या होगा. Okay. Anatomical factors. Just understand if the area is more, okay, the more part of the area that you cover, easier it will be for the retention part, right? जितना ज़्यादा area रहेगा retention उतना अच्छा. Simple. So maxilla में it's almost like 24 mm, okay, 24 mm square, and for mandible it is 14. It keeps differing from the authors. Now it is, I guess, 14.5 and 24.5 something around. Okay. So maxilla will be more retentive compared to your mandible. Anyone who is doing dentures will agree with me. Maxilla तो सर आराम से बैठ जाता है. It's the mandible that causes the problem. Because mandible में already you have the area is less, plus you have tongue. It will obviously dislodge your dentures. Okay. Physiological factors, it's your saliva, which plays a very important role. Okay. During diagnosis, in your, if you ever go to a DCNA, Dental Clinics of North America case history, okay, just go to it. You have different types, classification of saliva, whether it's a thick, thin, soapy, what kind of saliva it is. Physical factors, muscular, that is your adhesion, cohesion, interfacial surface tension, and atmospheric pressure and spherical seal. Adhesion is between two like, cohesion is two unlike molecules. Like में your saliva, ठीक है? Cohesion is your denture and saliva का retention part. Stability. What are the factors that will affect your stability? Teeth arrangement and contour of the polished surface. Always remember when you're doing teeth arrangement, okay, you try and do it in the neutral zone. Okay. You all know what neutral zone is? Anyone who knows what is the neutral zone? Yes. Perfect. Okay. So your tongue is exerting an outward force. Okay. Your cheeks are exerting an inward force. So there's a zone in which both these nullify. That is called the neutral zone. So whenever you do your teeth arrangement in a neutral zone, it will always help in support of the prosthesis. If you go this or this side of the neutral zone, there will always be issues. Okay. So whenever you're trying to do your teeth arrangement, please try and do it in a neutral zone. Contour of the polished surfaces, always try and have a good polished surface of your denture. Occlusal plane. Occlusal plane, it helps you determine the teeth arrangement level. For your anterior, it is the interpupillary line. For your posterior, it is the ala tragus line. Okay. For your lowers, it is up to the retromolar pad area. Quality of your impression. Better your impression, better is your prosthesis. So always, and one thing I would like to tell you is, people usually say कि primary impression ठीक ठाक है, second impression में हम कर लेंगे. Don't do that. The more time you spend on a primary impression, taking a good primary impression, the less time you spend on your secondary. So always try and get a good primary impression. If you have good retention and stability in your primary impression, I guarantee you, you will get a good retention in your secondary impression. So you will keep doing your border moldings ki yahan se kam hai, and eventually there will be some of the other jobs. Quality of the soft tissue covering the ridge. So always examine the soft tissue that you're going to make your denture on. Okay. For ideal conditions, for normal situation, it should be firm, okay, attached to your alveolar bone and everything. But there are times when it's flabby. So at times you need to redefine your entire procedure. If you're taking a custom tray, if you're making a custom tray, you have to go window technique, okay, so that you can relieve that area and take it in a Saffola fan technique, if I'm not wrong. So you cut a window of that flabby area, you remove that, you do your entire bottom molding, take your final impression, but just वो जो flabby area है, to take it with a light body so that it is not distorted. Vertical height of the residual ridge. As I said, whenever you get time, please read about residual ridge resorption. There's a classification, 6 classes of the residual ridge, class 1 to class 6. The height of your residual ridge plays a very important role in retention. Okay, anything if you have a greater height, it's easier to hold. When you come on the tip, it's very difficult. So you need to explain the patient that even if you do the best possible work for him, it's the height of the ridge that is of concern. ऐसा नहीं हो कि you give unrealistic expectations to the patient. अरे उसने आपका denture नहीं बनाया, I'll make a denture that fits for you. एकदम perfectly fit हो जाएगा. And when you go and check, there's no ridge. The ridge is completely resolved. So don't do that. Make sure you tell your patient and keep him or her well aware of the condition that exists. Suppose the denture base should cover as much of denture bearing area as possible and confine the occlusal forces to the stress bearing and relieving the non-stress bearing areas. If that's what I've told you first also, that first of all it should cover the entire denture bearing area. जहाँ तक extension होता है, you should cover the entire part till your PPS. Don't overextend it, नहीं तो patient को gag होने लगेगा. And you should put your forces, the occlusal forces should be in your stress bearing areas. अगर non stress bearing या relief areas में आपने pressure डाला, cuspid eminence में bone loss होगा. Lingual frenum को अगर आपने relief नहीं किया, the patient will always tell you कि as I lift the tongue, it comes out. Okay. Aesthetics, the thickness of the flange. Okay, so this is very important that many a times what happens, if a patient is freshly extracted patient, the thickness of the flange is a little less. But if it is a patient who's wearing denture for a long period of time, so try and keep the flange a little thick. It gives a fullness appearance for the both maxilla and the mandible. So it helps in the aesthetics as well. So that is all your conventional part. The textbooks maybe you've been reading throughout our lives. Your mucostatic, mucocompressive, selective pressure, everything. Now, as we are moving towards digitalization, I'll just give you a review of the digital dentistry that we have. We'll first see what is much better. Is it the conventional impression or the digital impression? So, what are the advantages that we have? Reduce patient discomfort. You might be having a lot of time, old age patients. I'm strictly sticking to the complete denture. The old age patients, you place your tray just to check your tray, and the patient starts to gag. Okay, and there might be reduced mouth opening in some patients because of OSMF or XYZ condition. So when instead of going for a conventional, if you go for a digital impression, the discomfort to the patient is reduced considerably. Time. We're living in an era where time is money. So the less time you spend with the patient on your impression, more he saves on it. Easier retakes. अगर आप impression compound का सोचो, you are taking a primary impression. If your staff says नहीं, not extended, okay, you need to do it properly. फिर से आओ, वो पूरा impression निकालो, फिर से पानी गर्म करो, फिर से knead करो, load करो, और फिर impression. So it becomes a little tedious. Whereas in digital, if it's not, you can easily retake that impression. You just have to scan it. And save logistic and material cost. Once you take an impression, you have to obviously go उसका cast for करो and all that thing. So it saves logistic and the materials that are needed for. These are some of the companies that have the Can, Italo, PM, Serac. Serac is a very good brand that we use most of these. These are the intraoral scanners that we have. The intraoral scanners are used to create a 3D image of teeth by eliminating the need for traditional impression material. I'll tell you, there are chances that we even make complete dentures in a day. Okay, you just scan it, do a virtual teeth arrangement. Okay, there are virtual articulators as well. So every topic in a complete denture can be spoken separately on its own for us. For complete this jaw relations, articulators, they all are huge topics to cover. This is how you do a teeth arrangement part. There are various techniques in your digital impression techniques, which can be in-office impression systems. You can use your chair-side impressions. I did Serac, which use that, or you can use a in-office CAD CAM, that is Serac. Serac system is what we use mostly. So, coming to the prosthodontics point of view, prosthodontics means you can use your intraoral scanners for your removable, fixed, or maxillofacial prosthesis. I'm telling you, it plays wonders in a maxillofacial prosthesis. Okay. Removable and fixed is still fine, but for a maxillofacial case, there are very high chances that you have a foroantral fistula, or you have just the floor removed of the orbit, or you have the maxilla, so just partial maxilla is gone. So you can't. There are times when you just can't take an impression. So scanning helps a lot. Complete dentures, partial dentures. Uses, as I told you, for your impression compounds, you can use for a primary impression, and your border molding green sticks can be used. These are the impression pastes that you use for your secondary or relining. You can even use for your single step border molding. Your green stick is a sectional or multiple step border molding, whereas you can use a putty for your single step border molding technique. For secondary impressions. So with that, we come to a conclusion of modifications and new innovations in impression materials are the need to excel accuracy in impression. Accurate impressions give us excellent prognosis of your treatment. So as I always tell you, the number of time or the more number of time you spend on your impression, the less time you will spend in denture insertion and your post-op. Okay. This is what all have been gone through to help you with knowledge. You never get a second chance to create a good first impression. Once you're done with your primary impression, you're done. Okay, so you never get to do it again. Then you'll have to work on your secondary impression. Thank you so much.
Thank you, sir, for the wonderful lecture, and it was a pleasure for all of us to have you on stage. Now, before moving forward to the next speaker, I would like to extend yet again warm greetings to all the ones present here, all our dignitaries, speakers, and our dear delegates. A new morning, a new welcome, but the same drill. Today is another day for the 6th World Dental Sciences and Oral Health Conference, organized by CynoDent International and Indian Society of Dentistry in collaboration with Kalinga Institute of Dental Sciences, KIIT University, Bhubaneswar. In order to help our fraternity and contribute in our genre to bring in the future and beyond, today, that is on the 28th, we are having our keynote lecture, which will be followed by the valedictory function at the end. Without taking much of the time, I would like to invite the next speaker of the day. The next speaker is Dr. Preetam Mohanty. A brief introduction for Sir is that he's PG and PhD guide in the Department of Orthodontics, Kalinga Institute of Dental Science, KIIT University, Bhubaneswar. He has done international fellowship in craniofacial orthodontics from Chang Kung University, Taiwan, and he has a range of positions that he has backed, as he is the EC member, Indian Orthodontic Society, Associate Editor, JCOIOS, Section Editor, JIOS, Section Editor, iOS Times, Faculty, iOS Endorsed National Training Program in Cleft and Craniofacial Orthodontics, AIMS, New Delhi, since 2019. Not only this, he has received 20 national and international patent grants. He has been recently featured in India Book of Awards for maximum patents, that is 9, filled in one single day. First of all, congratulations, sir, and let's welcome sir with a huge round of applause.
Thank you for your kind introduction. First, I would like to extend my gratitude to the CynoDent organizer and assistant director, Dr. Jugaditya and Dr. Dhiren, for giving me this opportunity to present my topic on patent and patenting. So today we will going to discuss regarding the patent and patenting. The first most important thing is that first you have to collect the new ideas everywhere to overcome the obstacles, change concept, to optimize strategy, and most importantly break the rule to explore new paths of patent track. First, you should know what is invention and what is innovations. So, invention is usually a thing, which an innovation is usually an invention that causes change in behavior or interaction of an user. So, basically, innovation is that to create a new value. You may invent a new thing, but if it is a no use, that is not considered is a innovations. Okay. So I am giving a two example of a that is which is not in use, but it is patented. That is body connected bike. Here you can see. This is a body connected bike, and here is the animated track foot wear soles. This got patent in US, but not in use. So it will be considered as an invention, not innovations. This is a nice article on the proceedings on the national seminars it is published in, and it is a scientific and technological development in Indian heritage, from where you can find out how our ancestors are knowledgeable and invented lot of things, from this magnetic watch, compasses to utensil, zero and binary numbers, Ayurveda, rulers, soga, everything is given by our ancestors. So our ancestors is more intelligent and more keen towards the innovation than the present is. So what is the lacking behind now? So here this is the current data. This data is from the GII 2020, and India features in the 48th position in the global. So what is IP, intellectual property? Intellectual property refers to creation of mind, everything from works of art of invention, computer programs to trademarks and other commercial science. So these are all intellectual property. So what are the types? So these are the 5 types: copyrights, trademarks, trade secrets, GI tags, and patents. So for your better understanding, I am giving an example of a pen. From here you can understand that what is the trademark, copyright, or patent. So I am giving an example of this is a pericardial pen. Here you can say this is the written part with the logo. This will come under the trademark. When you are going to apply, you will get the TM mark, and after the grant, you will get this R with the circle, that is registered trademark. Okay, this pen having a artistic features overlay, so this is will be considered as a copyright. Okay, and here this is a Parker ink, and that this is a particular ink, and this will become under the trade secret. Okay. Now come with this pen. Pen can be a slender one, a broader one, shorter and longer. This will this design part it will come as a design patent. If you are adding the functionality, then it will become as a utility patent. So design along with function, that will come under utility patent. And this is a GI tag. Here we are giving the example of Itigopa village in Andhra Pradesh, where the traditional wooden toys are tagged with geographical indication, GI tag. So these are all examples of types of intellectual property. So first come to the copyrights. What is copyright? So it is a right to not copy original idea expressed by the creator or author, and by applying the copyright you will get the 60 years of protection. And what it includes, it includes the literary part, musical part, artistic, dramatic, recording, even a book, a movie. This is a classical 10 steps of the Michael Jackson. That's also a copyrighted. And song, cultures, these are all will come under the copyright. Okay, and this computer programming also will come under the copyrights. Even the website content, there is Indian Orphanage Society website. There is the dancer, you can see is the copyright by the iOS, Indian Orphanage Society. So these are all will come under the copyrights. Now come to the trademarks or trade secrets. So trademark is any word, name or symbol or their combination that let us identify the goods made by any individual, company or organization. Here we are given an example of the Coca-Cola. Here you can see this is only the word or this is the combination of the name and word, Mercedes-Benz, and even the color combinations will come under the trademark. These two types, conventional and non-conventional. Under the conventional, there are the words, color combinations, label, logo, packaging, and shape of goods. When non-conventional, there is the sandmark or dynamic. Smell test in some countries, but not in India. And trade secret is basically any confidential information which provide an exclusive competitive edge. And best example is the cash secret. So geographical identification is a primarily an indications which identify the agriculture, natural or manufactured products, that is handicrafts, industrial goods, foodstuffs originated from a definite geographical territory. The best example is Kashmiri saffron, Sazili trees, Orissa paintings. These are all geographical identification. The patents are three types: design patent, utility patent, and flag patent. So in India, we get the only design patent and utility patent. And design patent, you will get the 15 years of protection, and utility, you will get the 20 years. So where you are going to apply? There is the 4 jurisdictions. That is. This is Chennai branch, then Mumbai, then New Delhi, and Kolkata. So in these 4 branches, you can apply your patent in India. The stages from filing to grant of the patent. So before filing, one need to go for the novelty check. So these are the sites from where you can. These are the sites from where you can check your novelty. So these are the examples of 3 websites. So suppose this is a Google patent. If you are thinking of something new, first you have to go to these sites and you have to put your what you are thinking to do the invention. So first you need to check whether the author already filed or not. So suppose you can put suppose endodontic pliers. You just put here. So here you can see there is a lot of patents already. You can go the details here regarding the endodontic pliers. So here it is showing there is 10 pages. Go down, pull down. So here you can see there is 1972 patents in relation to the endodontic pliers. That means there may be a word they are using endodontics or pliers or combinations, synonyms. So regardingly, you have to check to thoroughly what you are thinking. Okay, so just give you some examples. Just give you some examples. Anybody? Anything? We'll check here. So nobody wants to do it. Innovation? Anything. Periotape. Let's put down periotape.
MTEM.
There are four innovations regarding the periodontal. Okay. So if there is what you are thinking already exists, then you can go through the its file. Okay, just click on file. Like you will get the abstract, image, or details. You can download the PDF here. Here you can download the PDF. Please click here. So this is a US patent. Here you can see this is a patent number, and they got a grant in 2019. Here all the details are given. So if your idea is similar to this idea, by saying you can modify your idea. Without modifying or without going for the novelty check, if you are going to file, then definitely after 2 to 3 years it will get rejected. So no use of filing before novelty check. So like that you have to go through all the files. Go back. My presentation. So I just gave an example of one novelty search website. Like that you can do the search in global Asian portrait, US Patent and Trademark Office official website. This is FPO free patent online. Then next slide. This is INPAS, Indian Patent Advanced Subsystem, where you can find out whether your ideas got patented or registered before or not. Okay. So this is the website of official Indian Patent Office, INPAS. So these are the all three websites from where you can check your novelty. So after you are checking the novelty, then you are going to file your patent in specific areas. So in which category you are going to file? Okay. So this is A for is human necessities, A61 is the medical or veterinary science or hygiene, A61C is for the dentistry. And under this category there is subheadings. Here you can see. So you can find out your device or your invention is going to fit for which categories. Okay, this is the CPC classification you can get from the WIPO IP portal. This is also free. So this is the patent filing procedure in Indian scenario. First you have to go for the filing. So first is the novelty check, then filing, and filing it will get the publishing 1 to 2 months. Before it is taking the longer time, that is 18 months, but now it is you will get easily after 1 to 2 months. So if you have all the data with you, then you go for the final patent filing. If you don't have the data, just go for the provisional filing so that you will get the 12 months of the gross period, so that you can develop your data and you go for the filing, final filing. So this is after publication, it will go for the pre-grant opposition. If anybody wants to oppose, they can oppose. Otherwise, it will you can request for the examination. And issue the first examination report they will issue. It will take another 1 to 2 years. And depends upon the examination report, you have to respond. The filing response. Then they will check whether your response is authentic or not. If it is authentic, then they will grant you. Okay. If it is not, they won't find the authentic, they can refuse or they can reject. After the grant notified, then the post-grant operation also be possible. That that officers I either have to refuse or you have to grant. So this is the final process. So these are the tips to stop companies from ripping off your innovations. First thing, patent before you publish. The opportunity for authentic patent can be lost by publication of underlying research. No information on an invention should be made available to the public in any way, anywhere in the world prior to a patent application being filed. So what those includes publication in grant applications, Publication in journals either as articles or letters, oral presentation like seminars and conferences, information posted on notice boards on the internet, thesis, email, social media, any type of education, and confidential disclosure to many people. So try to license your product idea in some form of intellectual property. In India, it will take almost 3 to 4 years to get a grant. So by the time you can go for the copyright, it will get within a year, so that your idea is somehow protected. And patent, if you are protecting, it will get a 15 years if it is a design patent, and if it is a utility patent, you will get 20 years. But by filing the copyright, you will get 60 years of protection. So you should license your product idea in some form of intellectual properties. Understand the landscape of IP for your product prior to the filing. You should know your product landscape. Okay, and be highly selective about whom you approach about working together. Then approach crowdfunding cautiously. NDA has to be signed. Non-disclosure agreement has to be signed. It's very important. Okay, understand all the procedures beforehand. Don't ask your investors to find out the source of manufacturing technique. If they will find out, then they will take the advantage of that. Okay, so document every phone call and meeting with next steps. Then, if this is last is very important, this is a highly great attorney to help you with your IP. Okay, it is just like many of approach me that we can file ourselves. Online, it is online available, we can file. It is just like that you are taking medicine without consulting with your doctors. Okay, so better to hire a great attorney to help you out on this procedure. So where we stand. This is the patent landscape analysis of patents in dentistry over 100 years. And we have seen that there is 3,29,266 patents in relation to dentals. And this is the patent documents by the jurisdictions. Here you can see the United States having the 1,49,340 patents, followed by WIPO, that is around 50,000, then followed by European patents, 41,000, where India is we stand at 111 patents. This is grant. So this is the patent document by type, which type, and the patent application is here is around 1,80,000. Then this is the granted patent is around 1,10,000. This is the type of documents. This is the patent documents over the time. Here you can see there is a half peak after 2000. Here you can see, and it is got deep down in the year of 2020, maybe because of COVID era. This is patent documents by publisher filed and granted dates. This is the sharp date you can observe in the year of the 2020. So these are the top applicants. So you can see this is the three innovative properties companies they have filed. They got the grant at 4,687 patent, followed by Colgate family. Then GC Dental, they are the top applicants. And these are the top owners. Here you can see 3M innovative properties, they are having the 1,871 patents, followed by Align Technology. Then IGOClear, Align Technology for the Invisalign. They are doing the maximum in the orthodontics, 1,334 patents. These are the top 10 owners. And what is the difference between the owners and applicants? The applicants are actually the assignees who is given the assignment to do the what on the patent, and by the whose name it is going to be applied, that is the applicants or the owners. These are the top inventors. Mr. Ruben Steven has the highest number of patents in his name, that is around 630 patents, followed by Principal Michael. These are the top 10 inventors in relation to dentistry. So this is the CPC classification codes. As we discussed earlier, the maximum filed patent here you can say is 20,373 patents in this code. So what is that? This is the preparation for the care of the teeth, of the oral cavity or dentures, toothpaste and mouth cleansers. So in this category, there is the maximum patent filed in relation to the dentistry. So this is a competitive intelligence analysis and data mining of the patents in orthodontics over 100 years. Here in orthodontics, we found that there is a 32,759 patents till now. So this is the top SINs. The first one is Sleep Innovatives, followed by Allied Technology, then Onco Operations, then Orametrics, then Advanced Orthodontics. These are the top 5 SINs. These are the top owners. Sleep Innovative, followed by Allied, then Onco. The top current geographical countries where United States having the 15,088 patent in relation to orthodontics, where India having the 8 in relation to the orthodontics. Here you can see the trend. It is sharply increased after the 2000, the same pattern we observed in the dentistry, and here is the sharp increase in the 2020. So this analysis done, so this is known as the white space analysis, is done to identify the areas in orthodontics with the less R&D activities. So if there is a less R&D activities, so you're not supposed to go for the filing because it will be difficult for you to get it commercialized. Okay. So here is the top 5 trendings. This is A61C7500, that is the orthodontic and mechanical related category. Then A61C714 is the orthodontic brackets. Then 28 is arches, 08 is mouthpiece kind of return or positioner. Then 12 is the bracket archer combination accessories. This is the top 5 trending. Now it's going on, and less trending is orthodontic computer assisted systems, resins, preparations for oral care in relation to orthodontics, and handheld aperture and expander. These are the less trending. So this graph shows this analysis between the competitor and the authorities with respect to the relevant technology mentioned in the invention disclosure. And this analysis is done to find out the competitors' activities and progress in technology with respect to the country, which would be helpful for the inventors to approach. This is the important line. It is helpful for the inventor to approach and commercialize this technology to the owner. So here this bar you can see, this is on the right hand that indicates the scale or the measures, and the bar on the right hand side comes of the yellow, shaded yellow, medium yellow, and dark yellow. As you can see on the map here, you can see this the Cuneo, George and Dickey are the close competitors, and Wycon is in the competency with respect to the orthodontic research and development activities. So these are some of my work in R&D. Here, here we have granted the supplementary testing tools, repositioning of the springs for the ectopic canine. It's the versatile spring. With the springs, you can protract or retract the anterior posterior segments. This is the herbal combination of controlled diabetes, and this is the toothbrush with herbal dentifrice. This is the gram positive sensitivity points and negative specific points. This is the before the operation. You can put the point to check whether there is sterile or not the canal is. So there is come under the two segments. One is positive and one negative to check whether there is sterile canal or not. So this is the advanced LED system for orthodontics, where you can clear from canine to canine in one shot. Recently, we are curing its tooth individually, but here in the system, you can cure all the tooth at one shot. Then curcumin gutta-percha points. This is the gutta-percha points, which is limited with the curcumin molecules. This is a herbal toothpaste tablet, so no need to go for the toothpaste. This is a tablet, full herbal content. You have to just put in the mouth, it will get made, and you have to brush. So easy for carrying and less contaminations. And the cover is the biodegradable. So this is herbal toothpaste tablet. The others are the thermal probe for orthodontic dental application. There is various thermal variations for different purposes. This is a spending sweat pads for the detection of the diabetics. This is the other innovations. This innovation we got patented in Australia. This is a magnetic visualizer. It's a novel device for bone distraction using the repulsive magnetic phenomena. So usually we have a screw that you have to activate in there to get it separated and got the disturbance, which is for the repulsive magnetic phenomena here we are using. And this is the wearable hand sanitizer dispenser device with the pulse oximeter that also got granted. This is the biodegradable disposable gloves. This got granted, and these gloves will be made from the biodegradable polymers of the polycarbonate, that is the PCL, and we operate it from the ring opening polymation of the E-carbolactam, starch and glycerol. So this is the biodegradable, and it can degrade in a month. So, but after getting the grant, then what is the purpose of doing the patent? First is the academic growth, and second is the commercialization. So where we can sell out our patents. So these are the free patent marketplaces. The patentauction.com, IP marketplace, infama.com. These are the free patent marketplaces, and these are the paid marketplaces. IM Market, IPNexus.com, Licentix. These are all the paid marketplaces where you can open the commercialization. So this is a search in the websites. Here you can see one has put up. This is dental pick container and dispenser. This is simple toothpick container, and they're selling out in North America. This price is, you can see here. Okay, and these are the price list. You can find out the items and how much they are getting in purchase prices. The conclusion is definitely patent has certain advantages. Patent is a good scientific paper publication plus IP with commercial value. So there is a need to increase the awareness regarding the importance of patents and knowledge regarding the filing of patent application. So these are I have the features in the India Book of Records in 2020. Thank you. So any queries? Thank you.
Thank you, sir, and it was a pleasure having you here with us for the lecture on patents and important information regarding it. Now, the next speaker for the morning is Dr. Rajat Mohanty, sir. A brief introduction for sir would be Professor Dr. Rajat Mohanty is the professor and HOD in the Department of Oral and Maxillofacial Surgery from Kalinga Institute of Dental Sciences, KIIT deemed to be University, Bhubaneswar. He has bagged a great amount of achievements in his life, and his students are blessed to have him as a guide in the department. Dr. Rajat Mohanty is going to deliver a lecture on orthognathic surgery and an overview of a case for all the delegates present here with CynoDent and KIIT in the physical and online mode. We welcome you, sir, and eagerly wait for your informative lecture. Please give a round of applause for sir.
And all of you can hear me. Yes or no? I think most of the students or delegates present here are our students. Yes. So I should take this as a class. Very हल्का फुल्का presentation करेंगे और ये नहीं करेंगे. तुम लोगों को देख के मेरे को critical करने का पसंद नहीं. So I will make it very simple and let's see. Slide how much is good? So today I will be presenting on orthognathic surgery, an overview. Basically, I will just show one case, how to go about a case, and what is orthognathic surgery. Though we will be teaching you in the final year clinical classes, but still I will look at this case. First of all, I want to say that we all belong to dentistry, or we all belong to face. So we are basically involved in making this part beautiful. Anything, any problem in this part we are dealing with. Maybe the jaws, maybe the tooth, maybe the tongue, and sometimes even the nose, eyes, and everything. But as the topic for today is orthognathic surgery, I will be telling you regarding the tooth and the associated jaw. So beauty. For beautification, everybody is interested. Maybe a old man, maybe a young man, maybe a boy, maybe a girl. Everyone is interested. So we are the main players, or one of the players for beautification in the market. So I don't know who has undergone orthognathic surgery or orthodontic surgery. Our PG has made this slide. So I really don't know, or I don't have any backup literature for this, that they have undergone orthodontics or they have undergone orthognathic. But I was also seeing at this slide and I can see that everybody face has a beautification after treatment of his teeth and the associated jaw structures. Do you all agree in that? Everybody, you see this teeth show is remarkably now less here. See this diastema and all this has been cured. See this, how the crooked teeth and everything here. See this. So they must have undergone either some form of orthodontic treatment or orthodontic surgery or some lip procedure and all that. So we will be today discussing about orthodontic surgery. So it is an art and science of diagnosis and treatment of facial disproportions. These disproportions may be congenital or acquired, and for this correction you need either to change the tooth position, the mandible, the maxilla, and for that you need to do corrective surgeries. So again, I will not, as I told you, halka phulka running a presentation, I will not go into much theory. I also know that you all are not interested. So this I will teach you in the classes. Okay. So what is orthodontic surgery? Basically, one line I will say that it it is the surgery related to the jaws, maybe the mandible, the maxilla, and all that. So steps in orthodontic surgeries are diagnosis and treatment planning. Orthodontics, it plays a very major role, especially the pre and the post-surgical orthodontics, and then our orthodontic surgery. Now this is a case presentation, our one of the recently concluded case in our department. And this person came with this type of deformity. As you all can see that this, in simple term, if I say his mandible is too much elongated, the maxilla is hypoplastic or growth is not there. And this patient came, what I believe from my orthodontic colleagues, that he came with a self-motivation that he wants to look beautiful or he wants to correct his profile like this. This profile he wants to correct. If you see from the side profile, see now you can appreciate much better that how his mandible looks, especially when we say there is a class 3 type of case or a concave profile case. So this patient came with a motivation for correction. And when all the proportions and all everything were seen, we came to a conclusion that there was an increased third lower face and facial asymmetry and all that. Whatever, all that theory part I will not do as I told. So these were the problems. In simple language, if I say he just wanted to look little beautiful, correct his very protuberant mandible and the hypoplastic or the deficient maxilla. So these are all the problems of file examination. This is the pre-treatment intraoral orthodontic photos. I am not going into this, but here you can just, I will say one line that these are the class 3 occlusion and it is bit crowded. Okay. So crowding and overlap. And these are the OPGs. We have extracted the third molars are not there. And this all has been done keeping in mind the orthodontic surgery, what has to be performed after the pre-surgical orthodontics. So this is the self, very clearly you can see how class 3 it is, the maxilla you can see how it is deficient and all that. And then whatever thing happens, that cephalometry, Cox, that is the tracing and everything. With that, Drummond's analysis for facial asymmetry, and as I told, I will not go into detail of all this. Okay, so our treatment plan was orthodontic decompensation followed by surgery, and this is what the decompensation has been done. And now coming to our part, the orthodontic surgery. After the patient was handed over to us, pre-surgical orthodontic was done and was handed to us. We had planned for a bilateral sagittal split osteotomy, that is BSSO, for a mandibular setback of around 7 mm. 7 mm mandibular setback was to be planned. And maxilla had to be advanced by around 8 mm. So I don't know, third year, final year, how many of you know what is a bilateral sagittal split osteotomy or a BSSO? It will not work from here. Many videos, 3-4 videos are there. So I will come to what is BSSO and what is report 1 osteotomy. So this is what I was saying about BSSO. This is nothing but we tend to split the mandible sagittally at this part, and we can either pull the mandible forward or we can move it back. So either a setback can be done or a front movement can be done. So this is basically a bilateral sagittal split osteotomy. Next slide. Yes. And then report 1 osteotomy. These two procedures we have done in this case, and this is the report 1 osteotomy where the maxilla is split or osteotomy cut is given at the report 1 level. This is the report 1 level of the skull. Can you see this? After the report 1 level is given, it is down fractured and the maxilla can either be brought forward or can be brought back. So this is and after getting the desired movement, either front or back, we tend to fix it with mini plates. So these are the two things. See, you can see here very clearly how the maxilla which was set back has been brought forward. Next slide. So now one important thing in our dentistry and in medical sciences as a common thing is that now we are not very much dependent on the cast and everything what we used to do, articulation and all. Why? Because that is a thing which has come in all sciences now regarding the 3D printing or the digital world. In this, what is happening? We are studying literature and getting to know that they can make hands, skull, and any organ with a 3D printed model. Nothing, they will scan it and they will give you a thing. So if you have lost a nose, somebody will come with a scanner, scan the thing, send a new nose will come and you will only fit. So things have become like this at present. When we were studying in our some 15 days back, these all things were and we can only dream of that thing. But now you must have seen even in our college, 3D printed implants, guide and everything has come into play. So for this case, what we have done, we have taken help of the virtual surgery or digital planet from Chennai. So for that, what we need to do was we had to take a CT scan of the patient's face, and this is the CT scan of the patient. Here, see the patient's mandible, the maxilla, whatever we saw in the self, that maxilla is deficient, the mandible is grown too much and all that, and a class 3 profile. Taking this CT scan image, we had sent it to the person who is doing the 3D virtual simulations. So virtual simulation, what they are doing, they are taking help of some software and making cuts on the computer model like this. And then they are giving a plan that how much the maxilla has to come front, how much the mandible has to go back and all this. So so this is their thing. We have just taken the video and we have put it here. So this is the 3D. See, the maxilla, they have tried to pull it forward. The mandible, they are setting it back. And this is the, I must say that this is a surgery on the laptop or the computer. Surgery done on the computer or virtual surgery. Okay. So after this is got, now you see how maxilla they are tilting, trying to put in place and all that. Next. And virtual planning, see how what they gave us is this one, what I was told front. This is the pre-op. The maxilla still deficient, the mandible protrudent. Now they have pulled the maxilla forward and the mandible back. Okay. So what they are giving us by this, they are making a splint. The splint which we will use in the surgery. So that the virtual and the real world comes together. What was planned virtually also is achieved on the OT table. Okay. So with this, they are giving us a splint. And see how again lateral view, maxilla is so back. Now they have pulled it forward and placed it here. Mandible is so forward. They have done a surgery here, sagittal split, and this is the known as the virtual surgery or 3D planned surgery. So in this, so this part, what we are all dealing or what we all have been trained is totally omitted. Nobody does these things if we are going that articulations, jaw relations, and everything. Actually, we have omitted this part. So now coming to the surgery, vestibular incisions are given. I will not go into detail of surgery and all. A vestibular incision was given, the maxilla and the thing were exposed, and then the cuts were given. Please play the video. See, this is the same patient whose maxilla has been down fractured. Can you see? We don't have the whole video, but maxilla has been down fractured at the Lefort 1 level. And this is how the maxilla will be brought forward. Okay. According to the virtual surgery plan in Chennai. Planned in Chennai, done in Bhubaneswar. So this is like this. Okay, next. And after we have achieved the desired movement of the maxilla, these are fixed by help of mini plates. These are the plates which will fix it. Okay. So Lefort 1 osteotomy fixation. Then coming to the next slide. And then we have a splint. What they have sent us from Chennai, we are putting the splint. This is known as the intermediate splint after the maxilla is in position. Then next slide. After this comes to the mandible. In mandible, you can again see that mandible is being split. As I have shown you in that animated video, this is how the mandible is being split here. Can you see the splitting of the mandible? See, this is the split. What is happening with Smith spreader? So then this is being video is there. One more. Finish that one. Okay, next slide. And then again, the mandible is fixed in its desired position by help of plates. Next. And this is the final splint in position with both the maxilla and the mandible in their respective positions. And this is the pre-surgical occlusal photo with the maxilla is back and all that classical thing. And now see the correction. How it has been corrected with a normal positive overjet. Next. And these are all the internal photos showing the correction of the teeth. Next. And this is the patient after surgery 3 months. See the maxilla and the mandible position and see the position here. Almost a straight profile. We are trying to get almost a straight profile. Lateral view, then this is the frontal view. This is the patient here. More, it needs little more remodeling and all for it to look more beautiful and nice. Now, little bit swelling and all. Almost after 3 months is also there, but he will look much better after that. Next. This is again the lateral profile. Next. This is our department celebrating the oral maxillofacial surgery day on 13th February. This 13th February. Our staffs and our postgraduate students. And this is our OT. And as I have mentioned, that curiosity is the very basis of education. Why I put this slide is that everybody, after studying for 7 hours, also are very curious. Nobody wants to remove their eyes from the patient's mouth. So this curiosity is very much needed for students to gain something. Thank you.
What better way to guide the delegates on orthognathic surgery and the cases that you have dealt with today, sir? Thank you, sir. Now, procurement survey, and the list is so big that it can be specifically divided into clinical and non-clinical achievements, and that is a big list indeed. For a brief introduction of ma'am, let me tell you all that she is none other than Dr. Sagarika Muni ma'am. She works as senior lecturer in High-Tech Dental College and Hospital, Bhubaneswar. She is the chief practicing dentist and owner of ABC Dental Clinic, Odisha. She is a professional endodontist with a good knowledge of rotary microendodontics and aesthetic dentistry. Along with this, she is a leading practitioner in facial aesthetics like Botox, fillers, mesotherapy, etc. She has completed her master course in facial aesthetics in 2016 from Ukraine. There is a lot more to this list, and apart from all this, she has also been invited to way too many places as a guest speaker and guide, and today we welcome you here as a guest speaker in our own CynoDent conference. Welcome, ma'am. Good morning, everyone. How many of our interns here? Please raise your hands. Interns? Final year? Second year? Okay, you know why I asked you all this? Just to make you alert. Okay, so next 30 minutes, no, we'll not just sit here, okay? Let's take something from here, okay? Next 30 minutes. So it will be completely an interacting session. I won't be going through the slides. I'll be reading. I'll make you more bored over there because I know in what state of mind you are. You will be waiting for your lunch, I guess. So let's start our session. See, basically, it will be about endo. Okay. Please raise your hands. How many of you like endo? Please raise your hands. Please, please, please. Any PGs over here? Hello. Good morning. Any PGs over here? No PGs? Okay, raise your hands. How many of you like endo? Okay, chalo, done. So, I'll be talking about some tools and techniques that are related to endodontics. Okay, so how many of have you tried to do an endo? Please raise your hands. Okay, great. So, suppose you are in your department. Patient comes to you with a pain. I have a pain. What you are going to do? What will be your first step? Patient comes to you with pain. What will be your first step? पहले क्या करना है आपको? As you are a student now, first you have to report to your staff. For as of now, right? But think that you are in clinic, and what is the first thing you are going to do? Huh? Please, come on guys, I won't leave you like this. You have to participate. What you are going to do? You know this is a live session, it is recording is going on, or I'll pick you and I'll ask you. So what you are going to do? If patient comes to you, case history, I think somebody told you, case history. Then please take an IOPA. Please take an IOPA to rule out what is there, what you are going to do, what will be your treatment plan, right?
Okay, so in the next 30 minutes, I will be discussing. Can we switch on the slides, please? Please. So next 30 minutes, we will be discussing what is the importance of pre-op diagnostic IOPA, right? So once you see your diagnostic IOPA, you will come to know whether you are going to restore the teeth, or whether you are going to do an endodontic therapy on the teeth, or whether you are going to do any pulpotomy, or what you are going to do. And for doing that procedure, what you need, what technique you need, what tools you need for performing that particular procedure. Everyone getting something, right? So once you see your diagnostic IOPA, if you want, you can click the slides, please. So once you see, you will come to know how many roots are there, what's the morphology of the root, how many roots are there, like if you have a radix anteromolaris or radix paramolaris, is there any curved canal, is there any calcified canal, is there any periapical pathology, is there any, whether it is an a pathologic lesion, is there any fractured instrument, is there any post, is there any faulty restoration, is there? So many clinical scenarios. So you are going to rule out, you are going to plan your treatment therapy. And once you come to clinic, definitely you will, once you plan your treatment, your diagnosis and your treatment planning, you will charge the patient accordingly. This is not a normal case, this is a calcified case. So I am going to do like this. I need some particular files or particular instrument to handle this. So your charges will be this. And for you, you are being student now, definitely you can plan with your staff what we are going to perform, right? Everyone. So coming to curved canal, have you heard about this? Okay, have you heard about this? So sometimes when we are going to perform an endodontic treatment in a curved canal, few important things should come to our mind. How much is the curvature? You cannot take your initial file and go till beyond and till the apex with the filing. You need to see how much is the curvature, what is the angulation of the curvature, and what particular file that you are going to use. So your first file that you are going to use, that will be your 8 or 10 number K file, right? So this is the basic file or the first file that you are going to use. You cannot skip this 8 or 10 number file. You can never skip this. And if you are doing this, then you are going to land up with some heterogenic errors. I mean, some kind of problems. It can be a ledge, or it can be a perforation, or it can be blockage of the apical area. There will be so many complications. So that's why we call it a game changer. Few important tips here. First thing, if the root is curved, take it like this. If the root is curved, so what you have to do? You have to pre-curve your file. You have to see the diagnostic IOPA. You have to see your diagnostic IOPA. You have to judge the angulation, whether it is mesial or it is distal. And the first initial 8 or 10 number K file, you are going to pre-curve the file. So what you are doing with that? You are reducing the amount of stress, right? If the curve is mesial and you are placing the file in the distal direction, obviously it is going to break. It may not break in the first file, but definitely the amount of stress that is created inside the canal, it increases. So if you pre-curve the file, it follows the glide path. It follows the path of the canal that is present inside the tooth. Okay? कुछ तो समझ आ रहा है ना? Second year, third year, थोड़ा pick कर सकते हैं. Once you go to more deep into cons and endo, you will come to, I mean, you can just correlate. Second is, do not skip the sequence. Like in endodontic file, we have number 6, number 8, number 10, number 15. So once you start with 10 number, do not jump to 20, right? So it is always 10, A-gate, I mean wash, then 15, then 20, right? You have to always follow the sequence, and not mainly, and every time you have to follow the sequence. But if it is a calcified canal or a curved canal, if you are not following the sequence, next you will be in trouble following a ledge. Recapitulation. Anyone knows what is recapitulation? Anyone? Okay. Recapitulation means, suppose I have started filing with 8 number file. So once I start with 8 number file, I wash it, I go to 10 number file, I wash it, I go to 15 number file. I have increased my file number. If somewhere I feel my 15 number file is not moving freely, free flow, it's not able to maintain the glide path, what do? I'll clean and I'll come back to again 8 or 10 number file. Once I go to the higher number file, I will come back to a smaller number file, I will clean and again I'll go back. Getting my point? Ye samajh mein aaya what is recapitulation? Can click whatever you are not understanding, no, just click it and you can go and just Google it. Okay, recapitulation. I mean, once I have shifted to higher number file, still I am facing some difficulty. I'll come back to my lower number file, I'll clean again and I'll go back. So just to make a free flow channel. This will be quite tough for you. Because there are no PGs over here, otherwise they can correlate what is glide path in endodontics. Okay, this is a very important term, very important concept that is there in endodontics. Glide path. Can you make out? I mean, it's a common term, it's a general term. Glide path, just to make a free glide. Okay, just to go smooth. So clipboard Ruddle. Everyone please take this pic and follow him on Facebook and YouTube. Okay, please follow this guy. Okay, Clifford Ruddle. He had given a very beautiful quote: whoever owns the glide path wins the game of endodontics. Right? Whoever owns the glide path wins the game of endodontics. So that means glide path is a smooth radicular tunnel. It is a, see, this is my tooth, this is my canal orifice, this is my apex, right? So glide path means it is a smooth radicular tunnel from the canal orifice till the apical foramen or the physiologic terminus. Everyone, dental anatomy, physiologic terminus, canal orifice, these terms you can make out now, right? Glide path means it is a smooth tunnel from the canal orifice till the apical foramen or the physiologic terminus, right? So how to maintain a glide path? How do we need to create it? So what did I say? What is the first file we are going to use? What is the first file we are going to use? 10 number K file, right? So basically we have two techniques. One is manual, other is rotary, right? Rotary that we do with the help of a motor, okay? And manual means what we do in our hands, okay? So 10 number K file is a manual file because we are going to do the filing manually. So what we are going to do, we will use the 10 number K file. Slowly we will do the watch finding motion and we will go till the physiologic terminus. I mean the apical foramen, right? So glide path. So what I am doing here, I am creating a free flow tunnel, a smooth tunnel from the canal orifice till the physiologic terminus. So how we are going to create a glide path? With the help of 10 number K file, right? See, whatever may be the situation, the initial file will always be a 10 number K file. Is it okay? Itna, just remember this point. Our first file should be a 10 number K file. Is it okay? Everyone? See, I already told you that we have two methods. One is manual and other is rotary. Rotary, that we do the filing with the help of an instrument. So this all are the rotary glide path file, and the manual what I showed you, that is the 8 or 10 number endodontic K file. That's the initial file that you are going to use. You just see the in the angle of curvature in the apical part. Okay, so it is completely a 45-degree angulated root. So the main aim or the main key to treat such type of tooth is just I have maintained the glide path here with the help of my glide path file. So glide path starts with manual file, then it comes to rotary file. So manual file we will use 8 or 10 number file, And rotary file, we have many companies that produce rotary file. Once you come up to the final year and once you finish your internship, you will be aware of this rotary part. Okay. Now, what is this? Anyone? What is this? Dental histology. It's there in second year, right? First year. Okay. When I was there in second year. So this is something called pulp stone. Okay. So once you start treating root canal for such teeth with pulp stone, you should know what is there once you open up the tooth, right? When you are trying to perform an endodontic therapy on such kind of tooth, if there is a pulp stone, you should know how to negotiate that stone, how you are going to approach your canal and orifices, and how you are going to prepare that tooth. So you need to remove the stone before entering into the canal. Before removing the stone, you need to know there is a stone in the tooth, right? How you will come to know? Importance of diagnostic IOPA. The patient comes to you, please immediately take an IOPA so that you can rule out all the problem that you are going to face or all the difficulties that you are going to encounter. So we have few important instruments that can help us. So once you open up the chamber, you can use your endodontic explorer, just like your diagnostic explorer. You have mouth mirror, explorer, tweezer, right? You have your diagnostic instrument. Same like it, there will be endodontic explorer that you are going to explore the stone. There will be slow speed carbide burrs. Whatever you are using, no, those are diamond burr. You will use a slow speed carbide burr to negotiate these stones, ultrasonics, and magnifications. See. Can you appreciate this? I have just I have started with the endodontic therapy for this case, and the kind of shiny thing you are seeing here on the center. So this is my pulp stone. Everyone, if you want, you can take it, click and just save it. Now you see periapical pathology. So once you come across such cases, the most important thing, take a complete IOPA of the lesion. What I mean to say, the periapical, the boundary of the periapical lesion should come completely so that you can rule out whether it is a cyst, whether it is a granuloma, whether it is an periodontal lesion, or what kind it is, or any kind of foreign substances, or any sealer has been extruded, any your calcium hydroxide has been extruded, what is exactly the lesion. At least you can send it for biopsy if you are finding something fishy. So for that, sometimes we take an IOPA, the apical part is not there properly. Here, the main tip I am giving you, you should take your diagnostic IOPA completely with the complete extent of the lesion so that your diagnosis will be on the correct way. See, so this is my first radiogram. Here I can see incomplete obturation or a poorly obturated tooth. So the patient comes to me with pain, so I need to retreat this. So before retreating this, when I have taken the complete IOPA, I have seen here, you see the extent of lesion here. Can you appreciate? It is already, I mean the overlapping, what is this? Inferior alveolar canal, right? So this extent of lesion, it's very important to record, because once patient comes for follow-up, you can appreciate whether the lesion is healing or not, right? So extent of lesion in a periapical pathology case is very important. See here the lesion, when patient came to me, tooth was obturated, it was normal, but still with a huge periapical pathology. This case was taken surgically later on. And once you find any kind of resorption inside the tooth, we have 3 biocompatible materials, MTA, biodentine, and bioceramic. See, this is a young boy who had come for this blackish central incisor. Okay. So when we saw this, we were like, okay, first thing is to take an IOPA. So this was the tooth. Can you appreciate this? Can you appreciate, everyone? So there is a complete internal resorption of the case. So now to see this, so this kind of case comes to you, being a clinician, what you are going to do? Chalo, being a student, if such kind of cases comes to you in the department, what are you going to do? Obviously, you will do what your staff will say. That is sure. Okay. So if you are a clinician and such type of cases comes, definitely extraction will be our first choice of treatment, right? Patient was 24 years old. He was going to get married in 7 days. Okay. His demand was, can you please do? He was not concerned about his internal resorption. He was concerned about this smile. कि मुझे अच्छा दिखना है, कुछ आप कर सकते हो क्या? उसको नहीं पता अंदर क्या है, because it is not vital, nothing is there, no pain, nothing, just the resorption is there, right? So just have, see, this was the initial case, so I have obturated completely with MTA because they are biocompatible material. You have heard the word MTA, mineral trioxide aggregate, everyone? So those are biocompatible materials. So I have obturated the tooth with MTA. Then I have, this is a 6 years follow-up of the case. Then I have done a composite layering on the coronal part because it was very fragile, very weak. We cannot give a crown, I mean a prosthetic on the tooth. So just layered it with composites. How many of you remember him? Come on, everyone, you know him, no? Huh? The author of Malgudi Days is R.K. Narayan. He has given a very beautiful quote, you know, life is all about making right things and going on. It's not that you will learn here, the moment you step out of here, you will forget everything and jo jaisa tha waisa chal raha hai. No, learn something new and adapt that new thing into your practice. And you have to be consistent. You have to be consistent practicing that change to make you a great clinician. Right? You will, आप हमेशा students नहीं रहोगे. You will one day you will pass out and you will be an individual dentist, right? And you will take your own responsibility. So upgrading yourself in terms of material, in terms of technology, everything goes side by side. ऐसा नहीं है कि आपने सीखा and you left it then and there on. You have to carry that legacy with you. Okay. Coming to the access cavity designs. See, one most important thing, very important, when patient is coming to you with pain, whenever you are planning a root canal therapy, it should be an caries-driven access. What I mean to say caries-driven access? That means you have to remove all the caries part of the tooth, everything. It's not the concept of restorative dentistry. You have no infected dentine, affected dentine, you will remove the infected dentine, you will leave the affected dentine for remineralization. This is second year, I guess. Conservative, infected dentine, affected dentine, right? It's not the concept. Whatever caries is there, you are going to remove that. Okay, it should be always an caries driven access. Okay, and at the same time, you are going to preserve the sound tooth structure. ऐसा नहीं है कि caries हटाने के चक्कर में पूरा दांत उड़ा दिया. No, it's not like that. It should be an caries-driven access. At the same time, you should preserve the sound tooth structure that is there. Why we need to preserve the sound tooth structure? Why? Because it acts as a core house for your post-endodontic restoration. I mean, you will give a prosthesis over after the endo, right? So, it's for that we need to have a good amount of sound tooth structure. If good amount of sound tooth structure is not there, then we can plan for post and core, right? Post and core. Everyone heard of the terms? So these are the few burrs, endo access burrs that basically we use when we perform an endodontic therapy or a root canal therapy. Okay, these are the round burrs and endo Z burr. Now you see the beauty of this burr is that it has a safe and cutting tip. Okay, so however you move the burr inside the chamber, it will not perforate because the tip is a non-cutting tip here. Now this is DG16 Pro, okay, and this is not your normal explorer that you practice on your diagnostic this thing. Your oral medicine department, you have no mouth mirror probe and tweezer, your diagnostic instrument. This is not that probe. This is called endo probe, and it is very sharp tip. You can see it is very sharp. It is used to explore the dentinal floor or the pulpal floor to locate the canals. Okay. Anyone knows what is the full form of DJ16? Please write it down. And anyone finds out, no, please let me know. You can find me out on my name, Dr. Sagarika. Please, please, please. DJ16 का full form क्या है? अभी कोई जानता है क्या? Anyone knows now? I'll give you 1 minute. You can search it out and let me know. Okay. Now, the next important thing is magnification. See, we treat a very small, tiny tooth, right? Sometimes we may not locate those extra canals, those extra anatomies, or any kind of hidden anatomies. So we need magnification as an important tool in our practice. Again, the ultrasonic tips. So to find the hidden anatomies, to smooth the floor, then we have the orifice scouting. For all these things, we need ultrasonic tips. These are quite advanced things for you, so I'm not going in detail. Now, access cavity shapes. Now you see, whenever you are treating anterior teeth, suppose this is my anterior teeth, what I'm going to do, I will take my endo-access burrs, I will directly go to the lingual surface, give a 45-degree ditch, then I will go exactly straight to the line angle of the tooth, straight line access to the tooth, right? Then, in case of premolar, it is an oval shape. The access cavity shape, in case of premolar, it is an oval shape, but no mouse hole preparation definitely. It's not like that premolar is there, I'll take my burr and I'll do a ditch. That is called as a mouse hole preparation. So this is my mesiobuccal canal, this is my maxillary molar, so this is my palatal, mesiobuccal, distrobuccal, and this is my MB2 canal. Okay. Some PG was there, right? No PG. Okay. How many of you know that in maxillary? Okay, tell me in maxillary molar how many canals are there? Come on, dental anatomy. Maxillary molars, how many canals are there? 4 canals. Who said? Please raise your hand. 4. Okay, perfect. Very good. So what are the canals? It's palatal, mesiobuccal, distrobuccal, and mesiobuccal 2. Now, in our routine practice, we encounter this. I think theoretically you must be knowing that we have 4 canals. In our routine practice, chalo, according to your textbook, how many percentage of MB2 canals are there in our population? 80 to 80. Any other guess? Any other guess? Come on, you can guess. No examination here. I'll go. I don't know you. You don't know me. I'll go. So just make a guess. According to IEJ, Indian Endodontic Journal, maxillary molar, there are chances of 92 to 94% of extra canal, that is MB2, right? And 40% incidence of MB3 canal. Did you hear me? The percentage? It is above 90%. It is above 90%. So when you come to 3rd year, when you come to final year, when you come to intern, whenever you are seeing a maxillary molar, please mark my word. You treat it, you don't treat, but you should find it. Where is MB2 canal? It is there or not? If it is there, you should know that okay, MB2 canal does exist. Then it's up to you. You are treating or you are not treating, right? Okay. At least find it out. Every molar 90%, there is a chance of MB2. So this is my maxillary molar. So this is a connecting isthmus. This is my palatal. This is distrobuccal, mesiobuccal 1, mesiobuccal 2. Can you appreciate this image, everyone? Right? दिख रहा है वहाँ पे dark दिख रहा है क्या? Or you can see it? Now, how to locate it? Okay. So you have found out your main canal. You have found out palatal. You have found out mesiobuccal and distrobuccal. How you are gonna locate mesiobuccal 2 canals? 2-3 simple tips I'll give you. You can easily find out. You just need 1 minute of extra effort to find out, and one important tool to find MB2. Can you guess what is that instrument? What is one main important instrument or tool that you need to find out MB2 canal. You just need one good mouth mirror. You just need one good mouth mirror. जो आपको दिखेगा नहीं वो आप कैसे treat करोगे? Whatever your mind doesn't know, your hand will not treat. You just need one good mouth mirror to see the canal properly, to see the chamber properly. So once you are done with your main 3 canal, just flush the chamber area, take a small cotton gauze piece, dry the area, blot the area. That field will be very clean. It is a simple, this image, it is a simple access cavity design under a normal, it is my case, no hard and fast, no rocket science tools or techniques I have used, just a simple mobile and a simple mouth mirror. If you can't see, if you can't remember or you're confused, just take pictures and when you go back to home, just analyze. It was supposed to be here. Maybe I would have gone here. Maybe little mesial, maybe little. That's all. You don't need any fancy or expensive tool to locate that MB2. Now I will tell you exactly what is the location. You see, this is my palatal, this is my mesiobuccal, this is my distobuccal, this is my MB2. What you are going to do? The first golden rule, MB2 is never located distobuccally. You will never find it here. It is always directed palatal. Is it right? Everyone? Clear? MB2 is never directed distobuccally. It is always directed palatally. Okay? So once you have found out your MB1 canal, main canal, if you see it clearly, there will be a thin connecting isthmus from MB1. Just take your endodontic probe, try to explore that. You will get a catch point within a distance of 1 to 1.5 millimeter. You will get the catch, take your 10 number K5 and proceed. Then you are done. Right? Okay. Just remember MB2 exists. You need to find it. Right? So these are the few instruments that you need. You can take a clip of this. This will help you in your clinical practice. Done? So there are few good mouth mirrors. You can switch over. They are not expensive also, hardly some 100 rupees or something like that. Instead of using your stainless steel mirror that get rust, you can see this mirror. Or what you can do, being a student, you buy one mirror of this. All these expos will be coming and conferences you are going, no? When you come to intern, just buy one good mirror. This comes from Relax. This comes from Zip. One good mirror. Keep that mirror just to see. Okay? Don't use that mirror in your routine practice. Once you autoclave, once you put it in the sterilization, definitely it will get rust. Just buy one good mirror. It will hardly cost you 100, 200 rupees, something like that. Keep that mirror just to see the cavity, right? Okay. So this is my mirror. Okay. Then another concept is that once you have opened up your access cavity, there should not be any undercuts, any dentinal triangle. The wall should be blended properly. Why do we need this? Why do we need to blend the walls? Once we are done with our root canal therapy, we need to put some endodontic restoration, post-endodontic restoration, be it your composites, your amalgam, whatever you are using. So it should go on to the floor properly. If there are any undercuts or any dentinal chips or any hangings present on the chamber, it will hamper with the post-endodontic restoration. It will not bond properly. Okay, so for that we need to blend our wall. The concept of blending comes from there. How many of you know about she-shaped canals? Dental anatomy and histology. Perfect. Okay. So she-shaped canal, like you have your mesial, mandibular molar, you have your mesial, you have your distal, you have a lingual, you have buccal, and accordingly your canals are divided. Okay. But here you will completely find the canal shape in the form of a C from the orifice till the physiologic termination. It will be completely in the form of C. Just see the form of the canal, right? See the apical part, it is completely in the form of this C. Okay. Now you can see the access cavity preparation. Exactly, it is in the form of a C. There is no mesiobuccal, no distobuccal, mesiolingual or discolingual. All these canals are there, no? So this won't be there. There will be, it will be completely in the form of a C from the orifice till the apex. So this is my C-shaped canal, mandibular molar. Can you appreciate? See the IOPA, how it looks. Can you find any particular individual canal? No. So this is my observation. And definitely all your rotary file, they are not the appropriate tool to prepare these kind of canal. H file play an important role here. Why it plays an important role? To remove the interradicular dentine. To remove the interradicular dentine. So how to locate your canal orifice? Now you are inside the chamber. How to locate your canal orifice? So I told you endo-access burr, I have showed you. Then DG16 probe, canal detector dye, ultrasonics and magnification. Anybody found out the full form of DG16? Come on. Yeah, somebody told, I can hear. David Green. Perfect. Okay, please remember his name. It's invented by David Green. The instrument is named DG16 according to the inventor. Okay. So first file to be used on access cavity, 8 or 10 number K file. Okay. So how we are going to use the file? Okay. As I told you, if you are seeing a curved canal, okay, and if the curve is there mesially and you are trying to go straight to the canal, definitely you will land up to creating a ledge. So something called as balance force technique. The movements are given here. It's like you take the file and do a passive insertion. Never try to insert the file forcefully. Do not give any kind of pressure. It should be a passive insertion according to the angle of the root that is there on the IOPA. So to determine this, you need to see your preoperative IOPA, right? So the next important file is your orifice enlarger. Okay, first important file, it will be your 8 or 10 number K file to maintain the glide path. Second is your orifice opener. Now this comes under rotary endodontics. As I told you, there will be manual, there will be rotary. In rotary endodontics, this is the first file. Why we are using this? To remove any all the coronal pulpal tissue that is present inside the canal. See. Now this is the importance of orifice opener. Can you see this undercut area, this dentine overhanging? So definitely if we use in such cases, so the file, a kind of stress is created there and your second instrument will be also go and stuck there. Your gutta percha will go and stuck there. So we need to remove this hindrance. So we need to remove this hindrance and this is what called the concept of blending. As I said you, just remove any kind of undercuts or dentinal triangle or dentinal chips that is there on the area. Importance of orifice opener, it will remove your pulpal tissue, it will remove any kind of dentinal debris, any kind of undercuts, and it will clear the pulpal tissue that is there in the coronal part. Anyone heard about this apical patency? Actually, this is too tough for you, but let me just, I'll just clear it in within a minute. Apical patency. Have you heard it? Okay, great. You know it. Heard about it. Very good. See. Suppose this is my tooth. Okay. I have the apical foramen over here or here something. Okay. Everyone, apical foramen, right? I have the apical foramen. See, I'll not go with the definition. Just listen to me what I'm saying. You can make out. What is the first file I'm supposed to use? 10 number K file, right? Apical patency means I am going to make the apical foramen patent with the help of 10 number K file. I'll repeat. Apical patency means I am going to make the apical foramen patent with the help of 10 number K file. That means I am only allowed to take my 10 number K file beyond the apical foramen. To make it patent means to make it open, means to make it debris free. See, this line is nowhere written in any of the textbook, mark my words. It took me 8 years to understand this concept. I am a conservative PG. ये समझ में आया? Can you make out? Apical patency means you are going to make the apical foramen patent with the help of a 10 number K file. That means only the 10 number K file is allowed to go beyond the apical foramen. Apart from 10 number K file, if you are taking any file beyond the foramen, that is called as apical perforation. Getting my point? Everyone? You want me to repeat it? You want me to repeat it? Okay. See, what is apical patency? Apical patency means we are going to make the apical foramen patent. Means free of debris. There is debris on the foramen. See, it is closed like this. Okay, apical foramen is closed like this. I am not supposed to instrument beyond the canal. I am supposed to keep my filing inside the canal. But what about the debris that is present on the apical foramen, right? This is my apical foramen. I am supposed to make it free of debris. How? So only the 10 number K file is supposed to pass the apical foramen. So apical patency means we are going to make the apical foramen patent with the help of 10 number K file. Make patent means make free of debris. But I am not supposed to perforate the apical foramen. That means if I am using any larger number file, and I mean 15, 20 or your rotary file, you are perforating the apical foramen. Okay? Whenever you are having any doubt, no, after this class, you can reach out to me anytime. Okay? So once we maintain the apical patency, then we are supposed, we got our working length. Till that we are going to make our preparation. Now, once you are done with your filing, please, suppose you have one kit of new rotary file in your practice or in your department, you are advised by your staff to buy the system. Do not overuse the file. You have the file, that doesn't mean you can do in your extracted teeth, but not obviously in patient. Do not over prepare the canal. Do not, because once we are done with our endodontic therapy, we are going to plan for an post-endodontic restoration. We are going to give a prosthesis on that code. So we are giving so much of stress with removing so much of the pericervical, periradicular dentin. So what is going to happen? It will fracture, right? So if you are after following all these protocols, you know, access cavity burrs, your tools, your glide path, your apical patency, your irrigation protocol, your good obturation thing, if you have over prepared your canal, then it is something like this. Got it? So here is the sequence. Start. What is my first file? Excellent. So my 10 number K file, it is 8 or 10 depending on the IOPA. So it is the first file, that is my manual glide path. If it is a curved canal, I need to put some rotary glide path. Then I will use my orifice opener. Then I will prepare with my rotary file till the apical foramen. So this is my sequence of filing. Irrigation. How many of you, what we use in irrigation? क्या use करते हैं? So you are a dentist, no? कुछ तो सुना होगा. Anyone? See, once you come to root canal therapy, once you start practicing, I know it will sound very odd. You will think, no, this doesn't happen in reality. Yes, it doesn't happen in reality. This is the one thing that you are going to use in irrigation. No normal saline. It is a big no. Please go back to Indian Endodontic Journal. You will see the effect of saline in irrigation. So basically, it is an end wash that we maintain, that we do to maintain the acidic pH that is created by sodium hypochlorite. Irrigation means sodium hypochlorite. You know, that's why I have named this, because antibacterial, it will dissolve the organic tissue, it will dissolve the non-organic tissue, it will just clean everything. It will clean the main canal, If you activate your hypo, it will clean the accessory canal, it will clean the apical delta, it will clean your percussion canal, everything. See, all the third year, final year intern, what you will do now? Go to department, ask your PG 1 drop of hypo, put it on a cloth. Okay, and see the change, right? Start from this. So everything is done by sodium hypochlorite. Okay, that's why I have given this term, but it has one disadvantage. Sorry, two disadvantages. For you, it is two. First thing, it does not remove the smear layer. It does not remove the smear layer. Because of this reason, we are dependent on EDTA, right? So the second important is we are not supposed to use sodium hypochlorite without rubber dam. Everyone know what is rubber dam? Third years? Second years? Second years, you know, I guess you would have started, no? Theory, it is rubber dam, right? No? Third years? Yeah. Rubber dam, you are not supposed to use sodium hypochlorite. One important thing I forgot to tell you, the concentration of sodium hypochlorite that we need to use in dentistry, it is above 5%. To make it standardized, they have kept it 5.25%. Below 5%, there is no antimicrobial actions, right? So key points on irrigation. First thing, once you start your preparation, our endodontic practice should always be under rubber dam to avoid heterogenic events and for the proper irrigation and activation. So once you start preparing your canal, just flood the chamber with sodium hypochlorite. There is no role of EDTA, absolutely. Prepare all your canal, then wash with normal saline. Your last irrigating solution will be EDTA. Why? Because sodium hypochlorite does not remove the smear layer. See, we have prepared our canal. If we are unable to remove the smear layer, my gutta-percha or my sealer won't be going into the lateral canal or the root canal system. So there is no point of using all these things. We need to remove the smear layer. And at the end, we will just wash it with normal saline or distilled water to maintain the acidic pH that has been created inside the chamber, right? Now, what is activation? See, sodium hypochlorite, the chemical formula is NaOCl. So when we activate that, no, we irrigate inside the canal and we activate that. Activation, what it causes, it breaks down into NaCl plus O minus. O minus is your nascent oxygen. It is quite a reactive chemical, O minus. Okay, it's a radical, free radical. It causes your antimicrobial activity. It will potently dissolve your pulp tissue into those areas where your file will not reach. Suppose you have a main canal and you have one accessory canal. None of the file company that is there in the current scenario will go into the canal. If at all if you are able to take that, you won't be able to retrieve that. If at all you are going there, your gutta-percha won't go there, right? It is very difficult. So in that cases, what you are going to do, you are going to activate your sodium hypochlorite, right? So this activation, it will break the sodium hypochlorite into sodium chloride and nascent oxygen. This nascent oxygen will invade the lateral or the accessory canal and it will clean the lateral canals. Okay. So this is a sonic activator. These two are ultrasonic activators. See, there are many companies. I have shown all these three because these are currently in trend and these are the three that I have used. Okay. Now, what is vapor lock effect? See, this is something quite normal physics. You see, I have my root canal chamber, root canal. So I have done the activation of my irrigation, okay, irrigating solution. Now, as I said that sodium hypochlorite, it breaks down. So there can be, if you don't do the activation properly, sometimes some amount of bubbles, tiny bubbles, this looks big because this is a microscopic image. Some tiny bubbles that are created inside the canal, if you don't flush out properly or you don't break it properly, you don't agitate it properly, it will be there in the apical area. And once you obturate in such cases, patient will have a huge post-operative pain, right? Your sealer will not dissolve that, your gutta-percha will not go there, and obviously you can see that, but not with your normal IOP. You have to go for a CBCT or something advanced to detect this issue. So summary, 5.25% sodium hypochlorite throughout the cleaning and shaping under rubber dam. This is important. Do not touch sodium hypochlorite if you are not into rubber dam. You will burn the patient mouth, you will burn your hands and the soft tissue around it. Now the important part, root canal sealer. See, I'll summarize. We have basically 4 types of sealer. We have calcium hydroxide sealers. We have resin sealers. We have biocompatible sealers. Yeah, we have ZOE sealers. Okay. Oldest one, go to old concept. I think when you will come to third year, final year, you will start with your ZOE sealers. Okay. Most of the time, patients who are irritating to eugenol, they complain of post-operative burning sensation. That won't be any pain. They will complain, I am having some kind of burning sensation around the apical part of the tooth. They will figure out, मुझे इस दांत पे अंदर दर्द हो रहा है. Okay, these are noted, documented cases of eugenol non-perseverance. You have your calcium hydroxide sealer, very good sealer. The only problem is that they resolve very fast. So if you are having your pathological periapical pathological cases, in such cases, or your lateral canal has been filled somewhere, they resolve very fast. Most of the time, if any kind of spaces are there, no, if our GP is falling short, we just have in our mind that we will fill that content with sealer. We have done a root canal treatment. During the time of obturation, we find some amount of space, extra space. We can see it our naked eyes. Okay, we think okay, sealer to jayega, ye compensate kar lega. Please make in mind your sealer is not a filling material. Your sealer, the job of your sealer is to make an attachment or a bond between the root canal dentin and the gutta percha. That's it, right? It is a sealing material. It is not a restorative material or a filling material. Okay, so here comes the resin sealer, and then we have my MTA and bioceramic sealer. These are called biocompatible sealers. Why? What is biocompatible? Second years, biocompatible materials. You must have heard, no, MTA, bioceramic. This comes in dental material. First year, right? First year में होता है ना dental material. Second year में. Okay, I studied in first year actually. I'm old, so it's okay. So then your biocompatible material, we have MTA, we have biodentic, we have bioceramic. You are supposed to use the biocompatible materials. Okay. Now you see, this is your calcium hydroxide sealer, very good material, excellent flow, and you have very good radio opacity. What does mean by radio opacity? I won't leave you second year, third years. What is radio opacity? You can see it on the X-ray. You can see it in your IOPA. You should see it, because if I am using a root canal sealer and I am not able to see it in my IOPA, then what's the use? How I will come to know the bonding is there or not? Okay, so it has a very good radio opacity, and this is my resin sealer, this is my MTA sealer, this is my bioceramic sealer. So currently, because of all these innovation in the last few years, we are considering bioceramic sealer the gold standard one. Many companies have come up with bioceramic sealers. We have a good range from minimum to maximum range of bioceramic sealer. One important golden tip here: if your apical foramen size is more than 25 number K5, please obturate with a bioceramic sealer, because they are biocompatible. Right? What do you mean by biocompatible? They are friendly with your periapical surrounding tissue. If at all it oozes out, it won't cause you any problem. Now, this is the last step, obturation. See, basically, we will be dealing with two obturation techniques. One is the warm vertical condensation, one is the lateral condensation. I have prepared my main canal, then after that, I will take my GP corresponding the last master apical file. I mean, what is my last file? So, suppose my file is F1. So, I will take the F1 corresponding GP, I will put it inside the canal. Now, I'll take an IOPA. Now, I'll see whether any lateral spaces are there or not. Or I'll take my spreader, I'll check any lateral spaces. I mean, there is more space or not. If more space is there, I will come to the 2% gutta percha. I will do lateral condensation over in that area. See, this is my warm vertical condensation. I have taken my master cone. My master cone will be corresponding to my master apical file, right? Then after that, I have cut it from here. I have condensed it. Now you see the lateral spaces that is there beside the master cone. That I am going to use 2% of my gutta percha, 2% gutta percha. determine more spaces are there or not? Definitely you have to check with your spreaders. Okay, so check with spreader according to the sequence and add the 2% gutta percha. Now this warm vertical condensation, no, it is done with, there are many down pack devices are there, and this is your down pack device, you can use it. And these are your 3D obturating system. I won't be discussing because none of you are PGs here. Definitely, I don't want to trouble with this new concept. If you want, you can take a picture of it. Okay. So here comes a very important thing, very important concept. You need to give 1 minute of your time for after obturation. After you obturate your teeth, no, please clean the chamber properly. See, you have cut down your gutta percha, right? Once you have cut down your gutta percha, there will be your level of gutta percha should be below the canal orifice. This is my teeth, no? Okay. Here it is my cervical area. I have my canal orifice here. Your gutta percha level should be below the canal orifice. It should never be above the canal orifice. Why? I already told you. It will hamper the bonding of your post-endodontic restoration. Suppose you are going to do a composite on top of the root canal. Where will you put your bonding agent? It will hamper. So you have to chop all your gutta percha, excess gutta percha that is present on the floor. Getting my point? Okay. So after you clean it, after you remove excess gutta percha, clean it with normal alcohol. You can clean it with hypo. You can clean it with your hand sanitizer. Anything that has alcohol in that. You take a cotton swab, just clean it. Make the chamber look beautiful. I told you, for a good endodontic therapy, you need one important thing. You need a good mouth. Right? So just see that once it is clean, apply your agent, apply your bonding agent, then you can move on with your restoration. How many of you heard this? This is my truly last part. How many of you heard this? Apical puff. You must be using Facebook, no? You must have seen all those things. देखा है ना? Right? हाँ? कितने लोगों को लगता है ये सही है? I mean, is it yes or no? Apical puff should be there or no? No. Okay. Anyone? Apical puff is something our sealer have extruded beyond the canal orifice, and it looks very beautiful in the IOP, right? That is apical puff. Sealer have extruded beyond the apical foramen. Okay. It is something like this. Okay. See? अच्छा लग रहा है ना कितना endo? I mean, that lot of effort has been done to keep to make such kind of this thing, right? See, this is my apical foramen, right? This is the end part. There were a lot of concepts in the old days. If there is a periapical pathology, put your metapex, put your calcium hydroxide beyond the canal. Please, a big no. I'll tell you one simple quotation. Please remember by that. Nothing beyond the canal. No GP, no sealer, no metapex, no file. Nothing beyond the canal. Your limit is your apical foramen. That is your Lakshman Rekha. You are not supposed to cross the apical foramen. वो बोलता है ना घर की बातें घर में ही रहनी चाहिए. Right? Nothing beyond the canal. Nothing beyond the canal. Please mark my words. No apical puff. So what does this happen whenever you? These are documented cases from Journal of Clinical Dentistry. These are documented cases. Why I have shown you this? After this case, just see the inferior alveolar canal. Okay. Here the sealer is sitting on the inferior alveolar canal. Patient undergone a quite long time of paresthesia. Right? Because it is there on the inferior alveolar canal. So no fancy IOPs. Whenever you see those IOPs in the social media, don't get tempted. You are going to turn into third year, final year interns. Never try to create an apical foramen. Our aim is not to make our IOP beautiful. Our aim is to make the patient pain free and do a good endo. Good endo doesn't mean a beautiful endo. Remember that. Okay. So no apical puff. Nothing beyond the apical foramen. Everything should be confined to within the apical foramen, right? So significance of apical puff. One big significance. Patient will go. He will call you after 24 hours. Doctor साहब मुझे बहुत pain हो रहा है. You are going to give post-operative pain to the patient. And if you are not working under rubber dam or you are not working under sterile condition, that acts like a foreign body because it beyond, it is in the bone. So that your filler will act as a foreign body and it will cause periapical pathology. Right? So this is the significance. So this is my last slide. Hope you got something from this lecture. And anytime you have anything, definitely you can reach out to me. I am easily available on my name. And you are quite, I mean, you are just second year, third year. Once you come to internship, you will know there is whoever are interested in endo can reach out to me. You can ask me your queries or you can mail me. And thanks. So this was the lecture.
First of all those who are present here, please wake up and give a round of applause for ma'am. Whichever year you are, all those who are sitting here, please keep in mind that these speakers have traveled a long way and they are here in front of us and they are presenting their lecture and presentation with a lot of pain. So let's give a round of applause properly, pay attention to this properly, right? And it is a free platform for everyone. If you have any doubts, if you want to interact with the speaker themselves, or if you want to ask about any topic, you are free to ask them. So please stay awake for a little bit of time and attend the lecture. You and we all are truly blessed to attend your lecture. So now it's time to invite our next spokesperson for the day, and she is Dr. Nivedita Sahu ma'am. Dr. Nivedita Sahu ma'am is going to deliver a lecture today on the topic Panorama of Orthodontics. A little bit of introduction before she comes here to deliver the lecture. She is presently working as a professor, postgraduate and PhD guide in Kalinga Institute of Dental Sciences, KIIT University, Bhubaneswar. She completed her BDS from Government Dental College, Cuttack, and her Masters from Institute of Dental Sciences, Sri Ramachandra University, Chennai. She has served as the convener of Bhubaneswar Orthodontic Study Group for the term 2018-19. She has been an invited guest speaker to various national and state level conferences, and she has many research papers in various reputed national and international journals to her credit. Along with all this, she is a big name in the ortho department of the college, and I would request you all to welcome ma'am with a huge round of applause. Thank you, everyone. So, starting with my presentation, I have kept the topic very simple as the crowd is all about students. So, basically, all the students believe that orthodontics is all about brackets. It's all about various types of brackets, metal brackets, ceramic brackets, lingual brackets, clear brackets. So, I just want to deny this thing and go a little step ahead in stating that it's all about faces. Okay, it's all about beautiful faces. You can see these beautiful faces, and we are the masters of these beautiful faces. We create these beautiful faces. Why is this face not pleasant? The face is not pleasant because there is certain form of disharmony. Disharmony in the jaw, disharmony in the smile, disharmony in the symmetry. So these faces are not at all appealing to each and every one of us. So coming to just a definition, facial aesthetics, it has definitely got a very important role on social and behavior perception in our society. Smile is a person's ability to express a range of emotions with structure and movement of the teeth and lips
and can often determine how well a person can function in society. Smile, that is why, is a very important thing in our life. Why is this face a very appealing face? This face is appealing because it is a well proportionate face, proportionate in symmetry, proportionate in smile. So it's very appealing to all of us. So we are the makers of this face. So just a simple classification. I don't want to get into detail of this. The appearance and aesthetics can be categorized into macro, micro, and mini aesthetics. Macro basically involves the profile, which is the face, etc. And mini aesthetics basically involves the excisor display, the transverse smile, the smile symmetry, and micro aesthetics involves the gingival shape, the triangular holes, and the tooth shapes, to name a few. So, coming to what is the acceptable range of the width of each of the tooth. An acceptable starting point for central incisor is 11 millimeters. So when we are creating a smile, we should know that acceptable width of central incisor has to be around 11 mm, and the lateral should be 1 mm to maximum 2 mm shorter than the central incisor. Canines should be around 10 to 11 mm, but slightly shorter than the central. So whenever we are trying to build a beautiful smile, we are trying to design a smile, we have to take these things into consideration. Similarly, a general rule for achieving a proportionate smile design is that the lateral should measure 2/3 of the central and the canine should be around 4/5 of the lateral. So these are the two slides which I felt was very important in every aspect, maybe in prosto, maybe when we are trying to place our bracket position. So these two slides are basically the very important concept of smile design. So coming to few of my cases, what we have treated in our department, which is like we would like to share to all of you. So before that, I would like to state that orthodontics involves around the envelope of discrepancy. Okay, so this envelope basically tells us, as you can see, there are 3 envelopes. The inner envelope basically tells us about the corrective form of orthodontics, which means the corrections which we can achieve with fixed orthodontic appliances. That means with braces. As you can see, a purple color envelope is there, that is called as the inner envelope, middle envelope, which tells us the amount of correction which can be achieved with growth modification. Growth modification means which we do to children in a growing stage. Okay, here we can alter the growth of the jaws. So definitely the middle envelope has got certain more corrections what we can achieve with braces alone. The final envelope, which is the outermost envelope, is with surgical correction. Surgical correction, why? Certain patients are there which we can't treat with orthodontics alone. That means with braces. So there we have to take the option of orthognathic surgery. As you can see, the wide range of corrections which you can achieve with the outermost envelope. So starting from braces, which is the innermost envelope, the amount of correction is very limited. The middle envelope is the corrections which we are doing with growth modification, which is a little bit more better than what we are achieving with braces. And the outermost envelope is with orthognathic surgery. Definitely, orthognathic surgery gives us the most amount of correction. So, coming to few of the cases which were treated in our department, the first case which I would like to share is about the functional appliances. Okay, so functional appliances basically are delivered to patients in a growing age. Okay, so as you can see, this patient is a small girl which is reported to our department with a mandible which is placed behind, which we call it as a retrognathic mandible posteriorly placed. And if such cases are reporting to us in a growing stage, that means the child has not completed the pubertal growth peak, we can give certain appliances which are called as you can see, this pre-treatment intraoral fix. There's a huge overjet. Okay, and you can see there's a lot of the bites. The bite is deep. There's a huge overjet. So we give appliances which are called as myofunctional appliances in growing stage. These are called as myofunctional appliances. So what will happen when I'm giving a myofunctional appliances? Myofunctional means it has lot of influence on the muscles. Okay, so it helps in supplementary lengthening of the mandible. Finally, what result we are getting? As you can see here, the lips. As you can see, the lips of the patient, the lips are becoming competent. The profile is the side view of the patient. The profile has become straight. If you have a look at the comparison photographs of the overjet has reduced. So this is called as a phase 1 treatment where we have given a myofunctional appliance to a patient which has done all these corrections. This can be followed by phase 2 where we put braces and align the rest of the other dental things. This is what I'm talking about is the jaw. So that is why orthodontics is called as orthodontics and dentofacial orthopedics as we are addressing the jaws. Okay. So one more case I would like to share. Simple case of midline diastema reporting to a department. You see how beautiful we have closed the space and she's got a confident smile. That is what I want to say. It's not only about the teeth. Please consider the patient as a whole. Look at the confidence and a smile. Okay, normal metal brackets and we have got a wonderful result. Case 3, it's a case of bimaxillary protrusion with increase in sizal exposure. Normal cases, bunny teeth appearance. Okay, patient has got a bunny teeth and you see post-orthodontic treatment. He has got a competent lips, and if you are comparing the smile, you see how wonderful he looks. The bunny teeth has disappeared. Sorry. The bunny teeth has disappeared and he has got a beautiful smile arch. The incisal edges of the upper anteriors follow the lower lip curvature. So beautiful smile arch. One more case. This is a simple case of crowding which reported to our department. As you can see, the upper centrals, how crooked they look. They look full crooked. And post treatment, if you can see, she has got competent lips. And when I'm comparing the smile, you see the confidence, see the face, and see the smile. Case of generalized spacing. So normally we don't do treatment with metal brackets only. We also treat with lingual brackets. Okay, so these are lingual brackets, and as you can see, simple case of spacing, midline diastema. See the arch form. The arch form was completely crooked here. The premolars were in, the molar was in, and you see this is a post treatment. Beautiful arch form. The spaces closed. The premolars all out. Okay, so with lingual brackets also we get beautiful results, but patient has to really cooperate with us because in lingual orthodontics even a small ligature wire can be irritating factor for the patient. Okay, but many patients opt for it and we give them wonderful results. Now coming to, as I told, the outermost envelope. Okay, the outermost envelope which is regarding orthodontic surgery. We do a lot of cases in our department. So this is a case of vertical maxillary excess. What is called as a vertical maxillary excess? A vertical maxillary excess is a problem in which the maxilla has grown vertically more as compared to the mandible. Okay, the maxilla has grown in a vertical plane. So few of my students who have already attended my class will be knowing regarding this patient which I have already shared. So this is a case. This is a patient named Tilakavati. Okay, this patient had increased incisal show. The patient is a vertical maxillary excess because the maxilla has grown vertically downwards. Okay, the patient has got a retrognathic chin. See the chin. The patient looks like a bird. Okay, the maxilla has grown vertically in more vertically direction. The mandible is retrognathic. The maxilla is also prognathic. That means the maxilla has grown in anteroposterior direction also. The maxilla has grown more. So prognathic maxilla because maxilla has grown more in anteroposterior direction. Vertical maxillary excess because maxilla has grown more in vertical plane. Mandible is retrognathic. That means mandible is posteriorly placed and a retrusive chin. Retrusive chin means backwardly placed chin. Okay. So this is a very severe form of malocclusion. This type of cases cannot be treated with orthodontics alone. We have to take the help of orthognathic surgery, which I described it as the outermost envelope. where we are getting the maximum amount of corrections. Okay. So now please have a look at the changes. How it is. This is the intraoral pics. Lot many crowding and lot many things are there. Okay, crowding and all these things. So we have done pre-surgical orthodontics and aligned it. This is a Leaford 1 impaction, Leaford 1 osteotomy cut, as you can see. And we normally do a mock surgery and we fabricate a splint. The splint acts as a guide for the final occlusion. Okay, post surgery, the splint is acting like a guide. So if you have a look at the post picture, you see the gummy smile. See the amount of gummy smile. The normal gum show for a patient is 2 mm. Now you can see this patient pre-treatment was having around 10 to 12 mm of gummy smile. Post-treatment, you see, because of the Leaford 1 superior impaction, which means the maxilla was positioned in the superior direction. So the gummy smile has disappeared. Okay. And if I show you the look of the patient, you see the mandible, we are able to see a proper chin and the mandible. Okay. One more case. This is a case of prognathic maxilla. This was done in a department. Again, similar type of case. Vertical maxillary axis. The full show of incisors at rest with gummy smile. If you see the profile view also, patient has got a retrognathic mandible. Okay. So this is the Leaford 1 osteotomy cut which was done, which was given. See compare the results post surgery. So full incisal show has got disappeared. Okay. So this case, never try to attempt with orthodontics alone, because when you are seeing a patient at rest, patient is having a complete 10 mm of incisal show. These cases should not be touched with orthodontics alone. Brackets लगा के treatment नहीं करना है इस patient को. It's better you leave the patient, don't treat the patients. We are getting so many cases in a department which come to us. They have extracted the tooth, they have placed brackets, trying to convince the patient that we'll give you results. This will never fetch you results, because this is completely a vertical maxillary axis, full show of incisors. Patient जब normally बात कर रहा है, normally आप लोग उसको देख रहे हो, आपका full show of incisors दिख रहा है. So this cases only should be treated with orthognathic surgery. So post orthognathic surgery, this is the profile what we are able to give nice competency of the lips. This case was treated with Leaford 1 superior impaction. See the profile view. Nice competency. अभी patient का incisor exposure भी disappear हो गया. इसका mandible भी, you can see the mandible has come forward. Patient has got a straight profile. Okay. So we change really the life of the patient. She was a 22-year-old, not able to get married and all. So post surgery, they get a lot of confidence. They get a new life. They get a new face. It's like giving them a new face. So another case. So it's a huge. I just want to tell why have I chosen the title as panorama? Because orthodontics is a wide. It has got a wide range of applications, wide range of treatment modalities. Okay, so I just want to show you what we can do with orthodontics. Unilateral cleft lip and palate extending to the soft palate. This again is a case which was treated in our department with Leaford 1 advancement. See this patient. Cleft cases normally have a maxilla which is placed behind. Because of the cleft repair, maxilla is not able to grow. That is why maxilla is normally retrognathic, retrusive. Maxilla जो scar बन जाता है post cleft lip and repair, the scar doesn't allow the maxilla to grow. Mandible continues its normal growth. So patients normally have a class 3. Class 3 का मतलब क्या है? Maxilla is retrognathic, which means maxilla is placed behind, mostly because of the scar, which happens because of the cleft lip repair. Okay. So similarly, as you can appreciate, this patient has got a deficient maxilla. कुछ भी malaprominence नहीं है. Face is deficient, mid-face deficient, maxilla is deficient, and mandible has grown normally. So this case, we did a Leaford 1 maxillary advancement. Maxilla को आगे लाए. Okay. So keep the post. See how she looks. The fullness of the maxilla, the mid-face fullness has come. Okay. There is fullness of the maxilla, and I will show you the profile. See the way she looks. So nice. Now she has got a confident smile, like face looks beautiful. We have achieved the proper occlusion. Patient normally, such cases, the patients have a reverse overjet. Okay. This is the way we take it. And she is so confident. She sent us a selfie. Her life is changed. She got married now. So we were able to give her a new life post-surgery. Okay. Now, this case has already been discussed, but still I wanted to highlight because some part of it is with us and some part of it is with the oral surgeon. So I thought that we should also discuss some part of it. This is a recently treated case. Like one of my PG students did it, Dr. Shishti, she's sitting here. So this is a case which is his name is Deepak. He reported to our department. It's like within a year only, and this is one of the recent cases which we did. Again, a case of class 3. You can see the patient is having mostly patient का problem ज़्यादातर mandible में है. Mandible is very much ahead. Okay, mandible is prognathic. Mandible is ahead, and some form of maxillar deficiency was also there. We treated this patient bijaw. That means we moved the maxilla forward and we moved the mandible backward. Okay, patient was very shy. Patient never removed his mask. Patient never interacted with anybody before treatment. Okay. And this is how his occlusion was. Severe crossbite, skeletal crossbite. See the reverse overjet almost amounting to 15 mm reverse overjet. Very difficult case to treat. And this is the way we bonded, we placed brackets, and there were pre-surgical few things which we had to do just to gain some amount of reverse overjet. And what we did new in this case is that we started our 3D surgical planning. Okay, the 3D surgical planning helps us to give accurate result of what we are planning in surgery. Okay, so as you can see here, the maxilla has been advanced. I'll show you the profile view. Here you see, this is the pre and this is the post. So pre mein patient ka maxilla aisa tha. Now you see how the maxilla has been advanced. You can see this cut. So we have advanced the maxilla. The mandible, if you can see mandible, and this is the post treatment what we planned. And after this 3D surgical planning, we were able to generate a virtual splint, 3D printed splint, okay, which was used during the time of surgery. This is a virtual splint. The virtual splint was really helpful for the surgeons. Okay, this virtual splint helped and guided them to get a perfect occlusion. This is the occlusion which we achieved. This is on table, the photograph which has been recorded on table during the time of surgery. And this is the splint which really helped the surgeons in getting the proper occlusion. Okay. And this is how he looks. He's got a new face. We see the, like, I could feel that there is a tremendous change in age. He is only 19 years. And see the face change. Actually, now he looks 19 after this surgical correction. So this is the way we were able to change this. And this is the occlusion. Severely, like he was not able to bite. There was no contact at all. Nowhere to bite. Where to bite? Nothing. No contact point. And now he has got a stable occlusion to bite. So it's not only that we are changing the face. Sometimes functionally also we are giving the patient a good functional occlusion so that the patient is able to bite. Right. Okay. Okay. Last case. This is a case number 10. After so much of orthodontic, I would like to tell you now we are doing a lot of aligners in our department. So this is a simple case. What are aligners? Aligners are removable appliances, okay, which are mostly which we call it as clear braces, nothing to be seen, but we have few things which are called as attachments. Okay, so aligners basically work on two principles: shape molding effect and with the help of attachments. Okay, so attachments sometimes are force generating elements. Okay, so we need to fix certain attachments so that we are able to generate these forces. Okay. So this is a simple case which is being treated in our department. As you can see, this is just the 7th aligner the patient is wearing. The patient is submit. Okay, if you can see, have a look at the canine, have a look at the space. This is just after the 7th tray. Okay, in aligners, the trays have to be changed every 7 to 14 days. Okay, it's a removable piece of appliance. The greatest advantage is it doesn't look like it's not, patients are not very conscious. They can remove it. And but we are also getting wonderful results. But the case selection is important. We have to treat very simple cases, not to complicate. And here, this patient had the major complaint of upper anterior spacing and lower anterior crowding. So for upper anterior spacing, just in the 7th stage, little bit of space closure has happened. But for lower anterior crowding, you can see the massive change in canine position. Lower canine, if you can see, appreciate the lower canine. This canine has come into the arch. Have a look at the arch form. Okay. So 7th grade itself, we were able to get all the premolars in the line. The arch form has improved. Lower arch form has also comparatively improved. Still, the case is going on, but I just wanted to show you that with aligners also treatment is possible and good results we are getting, but with the help of the patients. Unless the patient is cooperating, patient is wearing, patient is sincere, we are not going to get result with aligners. So with this, I would like to end my presentation with a meaningful quote. Beauty is more than just shining to others. You don't need to have the perfect face to be beautiful. Being ugly or beautiful is a matter of energy, and true beauty comes from the heart. Thank you one and all for a patient hearing. Thank you.
Thank you, ma'am. It was a really amazing lecture and we had fun listening to you. So the next guest lecture for today is Dr. Prashant Gupta, sir. He's from the Department of OMDR. A brief info before you come to the stage and present, sir. Sir has finished his BDS and MDS in the field of oral medicine and radiology from the renowned Bapuji Dental College and Hospital, affiliated to Rajiv Gandhi University of Health Sciences, Bangalore. He has been associated with research for the last 12 years, and that is a big achievement for someone of our fraternity from OMDR department. He also holds a fellowship in forensic odontology. His research for fellowship was awarded the best research at National Conference on Forensic Odontology held at Chandigarh. He was also awarded the A.K. Bhovir Award for the best research paper by Indian Academy of Oral Medicine and Radiology. During the last 13 years, he has engaged in several clinical cases and their treatment, mostly the red and white lesions, the diagnosis of oral cancer, and potentially malignant disorders. He has tried different treatment modalities for potentially malignant disorders and also the red and white lesions, acute and chronic ulcers, and vesicubulous lesions. His research has been widely published and recognized and followed in treatment protocols. Today, Sir is going to deliver a lecture on the topic differential diagnosis and management of oral potential malignant disorder, which holds importance for our daily lives. It is a pleasure for everyone present here to have you here, sir, and we all are eagerly waiting to attend your lecture. Welcome, sir.
Good afternoon, all of you. With this beautiful thought, I would like to start my presentation. Before I introduce myself, I would like everyone to know where I have graduated, where I have post-graduated, the temple where I have learned. And the reason why I'm standing here is because of my teacher, my mentor, my guide, and everyone, Dr. Ashok Hill. I will pray for him before I start my presentation.
I would like to tell myself, Dr. Prashant Gupta, Associate Professor and in charge in Oral Medicine at Dental College, RIMS. And topic for my presentation is differential diagnosis and management of oral potentially malignant disorders. I'll not be telling you the definitions and what are the clinical types, treatment plan, and all those things, because all those things you must have learned in your final year and in your internship. Now, my main focus of today's lecture is how to differentiate between various types of oral lesions, especially the white lesions and the red lesions, and what are the treatment strategies you have to follow. So I'll be covering my topic under following headings: introduction, followed by various terminologies that are used, then leukoplakia, lichen planus, and OSMF. These are the three topics which I'll be covering, and then followed by the conclusion. Because of the short time, these are the three important things that always comes to our mind when we see any white lesion or red lesion. Now we start with this, that why we want to discuss this red and white lesion. We need to discuss these red and white lesions because as an oral physician, our responsibility, our duty is to prevent all kinds of mishappenings that are happened in patients, because it's our duty to earlier diagnose, earlier the diagnosis, earlier the treatment. And if we have a good knowledge, then only we can diagnose. Without knowledge, we cannot diagnose, because at times it might happen that we must be having a normal variant in the oral mucosa, like linea alba, but we'll be thinking that it is a leukoplakia and we'll be treating it very aggressively. So we should know what are the normal variants such as linea alba bacalis, audacious granules. So if we know that there are certain normal variants which might show a color change, there are various types of red lesions, there are various types of white lesions, there are various types of pigmented lesions. Identification of in the oral mucosa. And good case history is very, very important once we are diagnosing any such condition. If we have a good case history, there is no need for any kind of investigation. Everybody can diagnose with investigation. Everybody can do a biopsy and tell, okay, this is a dysplasia, so in dysplasia, that means it must be a leukoplakia. Okay, this is a carcinoma in situ, so it might be going towards malignancy. If say that a well-differentiated squamous cell carcinoma, so it is a case of a cancer. But the art is, before doing biopsy or without doing biopsy, if you are able to diagnose, then you are actually a true oral physician. So biopsy is not every time that is important, especially in cases like OSMF and leukoplakia. If we are doing biopsy, आप पेशेंट्स को और ज्यादा ससेप्टेबल कर रहे हैं उसको एग्रेसिव डिसीज की तरफ ले जाने के लिए। इसलिए बायोप्सी करने के पहले आपको बहुत बारी सोचना चाहिए कि आपको एक्चुअली इस पेशेंट में बायोप्सी करने की जरूरत है या नहीं। बायोप्सी का रिपोर्ट आता है, सब लोग बता सकते हैं, इवन अ patient, even a person who has not done dentistry also can tell, okay, this is not looking like a good prognosis. That is why the good case history and clinical examination is very, very important. If you have done a good case history, you have done a good clinical examination, you should be in a position to diagnose. And if you are not able to diagnose, that means you have failed to take a good case history. You should be patient enough when you are taking the history. You should listen to the patient. You should think about that, okay, patient is very close to me, and then only you can be able to diagnose the disease. And if you are diagnosing without any biopsy or any kind of investigation procedures, that means you are actually a true oral physician. And if we are able to diagnose at the pre-malignancy stage, then probably we are able to treat them and save them from various sufferings. Earlier, you must have learned that there are some pre-malignant lesions, there are some pre-malignant conditions. But after 2005, WHO has recommended that better to call them as oral potentially malignant disorders. What are these oral potentially malignant disorders? These are certain systems and conditions, lesions and conditions, they are combined into one group, and those are called as, things are called as oral potentially malignant disorders. They are no more called as pre-malignant lesion or pre-malignant condition. Why do we need to know about these pre-malignant lesions and conditions? Because if we are able to diagnose them early, then probably we are able to treat them early. If we are able to treat them early, then we might save the patient from going into a stage of oral cancer, stage 2, stage 3, or probably stage 4 oral cancer. So, and if we are able to improve the prognosis, then the quality of the life of the patient also gets improved. Then you might giving you credit, and you start thinking that, okay, I have done a good job as a doctor. So coming to leukoplakia, the first of my condition, leukoplakia, all of you know, there are 4 various types of leukoplakia, but the most important part of leukoplakia is the fecal leukoplakia, and the third one is the proliferative verrucous and the verrucous leukoplakia. Probably if we are able to identify which type of leukoplakia is important to treat and which type of leukoplakia is not important to treat, then probably, okay, we are successful as a teacher and you are successful as a clinician. So one important thing I want to mention here about that, there are etiological factors. All of you know that there's a tobacco that is an etiological factor, tobacco in various forms such as smokeless and smoked form of tobacco. So what is the smoked form of tobacco and what is the smokeless form of tobacco? No need to tell, but one important thing I want to tell here is that smoking will cause more number of leukoplakias, but smokeless form of tobacco will cause leukoplakia that will have more advanced lesions or it will have more types of malignant transformation. Now, all of you must be thinking that why there is a idiopathic leukoplakia. There is idiopathic leukoplakia, and in India, approximately out of 100 patients, 1 to 2 patients will be having, without any habit, without any known cause, they'll be having leukoplakias. And those kind of leukoplakias are not really good because they'll have very aggressive behavior. So first, if you see any kind of white lesion in the oral cavity, and we are thinking in terms of leukoplakia, because leukoplakia is a white patch or flare that cannot be characterized clinically or pathologically as any other definable lesion. We have to rule out certain conditions to diagnose the case of leukoplakia. If we are able to diagnose the case of leukoplakia, then probably we have to establish the role of tobacco. What kind of tobacco has caused that leukoplakia? If you are thinking, okay, patient is told, and you are thinking that, okay, it is a case of leukoplakia, then probably we have to think of some predisposing factors that can cause aggressive nature of that leukoplakia, such as systemic predisposing factors and local predisposing factors. Local predisposing factors such as poor oral hygiene, sharp tooth, any kind of prolonged infection in the oral cavity. Then systemic predisposing factors like syphilis and sepsis and immunocompromised hosts, such as patient is suffering from any kind of immunocompromised disorders like diabetes or HIV infection. Then probably we have to establish the predisposing factors and we have to rule out any other predisposing factors. As I told you, there are 4 types, and the most common type is the homogeneous leukoplakia and least common is the verrucous leukoplakia. Coming to the pictures of leukoplakia, if you can see that the smoker's pouch keratosis or buccal pouch keratosis, we can say that it's a pre-leukoplakia. It's a first sign of leukoplakia which is there. After that, we come to cases like homogeneous leukoplakia. Homogeneous leukoplakia are cases where you see completely white lesion and there is a washed leather grayish green patch. White patch is there. It's not a macular lesion, it is a papular lesion. Okay. So remember this, it's a slightly elevated lesion. It will be purely white in color and it might be having some areas of scrapability. Although leukoplakias are non-scrapable lesions, but if they'll have superadded candidal infection, you might find some scrapability. So don't forget that if it's a scrapable lesion, it is a candidiasis. There might be superadded candidiasis over that leukoplakia. So these are some of the pictures of homogeneous leukoplakia, plain white lesion. Cracked bud appearance, that is the classical presentation of homogeneous leukoplakia. जैसे कि मिट्टी गीली मिट्टी है उस पर टूट पड़ जाने से, जैसे कोई अगर उसके ऊपर चल पड़ता है तो उसके टूट पड़ जाती है, तो दैट इज अ क्रैक बड अपीयरेंस. क्रैक बड अपीयरेंस उसमें दिखेगा आपको, तो इसका मतलब है कि वो एक ल्यूकोप्लेकिया का केस है, होमोजेनियस ल्यूकोप्लेकिया का केस. उसके बाद जो ल्यूकोप्लेकिया अगर उसके बाद आगे बढ़ता है तो होमोजेनियस से स्पेकल्ड या फिर स्पेकल्ड ल्यूकोप्लेकिया बनता है, या फिर उसको नोडुलर ल्यूकोप्लेकिया भी बोलते हैं. इस केस में क्या रहता है कि ये लीजन्स जो है ज्यादातर मैलिग्नेंट ट्रांसफॉर्मेशन की तरफ तेजी से बढ़ते हैं. इसमें हमको हमेशा व्हाइट लीजन के साथ साथ एक जरूरी रेड कंपोनेंट भी दिखेगा. रेट्रोकमिशनल एरिया जो लिप्स के पीछे का एरिया होता है, दैट इज द मोस्ट कॉमन साइट फॉर नोडुलर और स्पेकल्ड ल्यूकोप्लेकिया. These are some of the cases of speckled leukoplakia. Always remember, they'll have a mixed red and white lesion. Homogeneous leukoplakias are pure white lesions, but nodular or speckled leukoplakias are mixed red and white lesions. These are some more cases of speckled leukoplakia. Coming to verrucous leukoplakia, the more aggressive variant again, they'll have finger-like projections or small pinpoint finger-like projections will be present. Then you start calling it as a verrucous leukoplakia. If it shows more and more of proliferation, then you call it as proliferative verrucous leukoplakia, or short form is PVL. Now coming to my topic, differential diagnosis. So differential diagnosis will go one by one. First one is the frictional keratosis. You have to see that whether there is any kind of trauma from the sharp tooth or any kind of object which is present at the denture or anything else which is causing trauma to the soft tissues where there you have seen the white lesion. If you have seen that, then probably frictional keratosis should come to your mind. Lichen planus is one of the, again, a very common differential diagnosis used in case of leukoplakia, because lichen planus is also a mixed red and white lesion. But lichen planus will have a strong white lines. It will not be in the form of a patch. If it is in the form of a line, then probably you think of lichen planus. If it is in the form of a patch, you start thinking as leukoplakia. Then candidal leukoplakia or chronic hyperplastic candidiasis is also another form of differential diagnosis. So candidiasis is a disease of the deceased. It will not happen alone. There has to be some kind of predisposing factor, local or systemic predisposing factors that has to be present. Then you only can diagnose it as a candidiasis. Other things are like white sponge nevus, lupus erythematosus. They'll have systemic manifestations. Discoid lupus erythematosus is present only on the sun-exposed areas and on the lip. Verrucous carcinoma and squamous cell carcinomas are always considered, because if you see any kind of ulceration, if you think that there is an ulceration also in the leukoplakia, then you start thinking in terms of carcinoma. You start thinking of verrucous carcinoma or squamous cell carcinoma. So if we see the progress of the disease, habit initiation, that is in the form of any form of tobacco, smoked or smokeless form of tobacco, will cause leukoplakia, and it will take around 5 years to develop full-blown leukoplakia, and from leukoplakia it will take almost 5 to 15 years to develop into a full-blown cancer. So our duty at the first stage is very important. At the second stage, it is very important. If we are able to identify and treat at the earlier stage, probably then we are successful as an oral physician. Coming to the treatment, for different types of leukoplegia, treatment varies. If you are thinking of a homogeneous leukoplakia, because most of the time homogeneous leukoplakia, you will be accidental finding. Patient will not be aware of that white lesion. Probably if he is not seeing that white lesion, then there is no need for any treatment. Just you have to give patient with antifungal treatment, and probably you can go for antioxidants and keep the patient under follow-up. For every kind of red and white lesions, don't think that you have treated the patient successfully after 2 months, so don't call the patient. That is a big mistake what everyone does, that after 2 months or 3 months, doctors start thinking that they have treated the case, so they stop calling the patient. It is not like that. They'll reappear, especially cases of lichen planus. You are giving intralesional injection, you have given steroids, you think that you have treated? No. After 3 months, again the lesions will appear. Then you have to recall the patient after every 3 months. So periodic follow-up is very important. There is no need for any kind of biopsy in case of homogeneous leukoplakia. Don't send the patient for unnecessary investigation. Please don't send the patients, because homogeneous leukoplakia will not cause any kind of burning sensations. It will be diagnosed on the routine examination only. Patients will not be aware of it. Slightly burning sensation, okay, you can give them slight advanced form of treatment. You can give them antioxidants. You can give them vitamin A therapy. But don't do biopsy unnecessarily. You are seeding the cells deep into the tissues. You are seeding these plastic cells deeper into the tissues. Coming to treatment of spectral leukoplakia, patient's education and motivation is everywhere important, because if the patient is not able to quit the habit, probably you are not able to treat the case successfully. So quitting the habit is very, very important in all kinds of pre-malignant lesions and conditions or oral potentially malignant disorders. So quitting the habit is very, very important. After 6 months, if you see that the lesion is advancing, then go for biopsy, because in this case, you need to establish the degree of dysplasia or whether it is carcinoma. That time, biopsy is mandatory. Otherwise, if the lesion is stable, is not advancing or aggressive behavior by what I mean to say is that patient is having severe burning sensation. First time patient reported to you, patient had burning sensation on eating normal food. Second time patient had burning on spicy food. Second time patient reported to you, he's telling I cannot eat anything because I am having burning sensation on eating normal food also. In that case, probably lesion is advancing, lesion has become very aggressive. That time you need to establish the biopsy, because if it has converted into carcinoma, probably you need to refer the patient to higher centers for treatment. That time biopsy is important, but as long as the lesion is not aggressive or advancing, probably you can treat it on your own. No need to do any kind of biopsy as long as there is no severe ulceration or the lymph node examination, there is no fixity of the lymph nodes. So what do you need to do in cases of what are the kinds of antioxidants you have to give? Lycopene is a very good antioxidant. You can always give natural antioxidant, that is tomato extract, very good. Then vitamin A supplements in the form of isotretinoin, and there is a very capsule available that is known as Aquasol. It is very cheap and very effective. Also, you can do it in two ways. Either you can tell the patient to eat it directly, or you can tell the patient to crush the capsule in the local area, because it's a localized area where there is leukoplakia. So it's always good to crush that capsule in the oral cavity and tell the patient to apply it for few months, actually rather minimum 3 months I should recommend. Then topical bleomycin is something, it is an anti-neoplastic drug. It is only given in patients with severe dysplasia or advancing cases of leukoplakia. Once the patient refuses to go for biopsy and you think that patient is going into a stage of carcinoma in situ or probably verrucous carcinoma, that time the role of bleomycin becomes very important. Surgery, small cases of leukoplakia, it's better to go for surgery, remove the entire lesion. That is probably the surgery is ideally the treatment of choice in smaller cases of leukoplakia when the lesion has started showing aggressive behavior, just the start of aggressive behavior. And radiotherapy is also one treatment modality that is given in cases of intermediate cases when you think that it is going above leukoplakia and converting into carcinoma. Then radiotherapy is also one of the treatment modalities. To summarize my things on leukoplakia, remember you have to establish the etiology. Tobacco, any form of tobacco. Remember one thing, tobacco, there are two forms. The smokeless form of tobacco is more dangerous because it shows higher rate of malignant transformation as compared to the smoke form. And if you think that leukoplakia is idiopathic, which is there in 1 to 2% of the cases, treat it aggressively. By meaning treat it aggressively, that means you have to think of verrucous leukoplakia or proliferative verrucous leukoplakia if it is showing proliferative projections. Coming to second disease, oral submucous fibrosis. All of you know what is oral submucous fibrosis, but one thing is very important to know about oral submucous fibrosis is it is a condition which is very easy to diagnose. Fibrous bands, blanching, marble-like appearance, difficulty in opening the mouth, burning sensation. Classical presentation of oral submucous fibrosis. If you have seen 5 to 6 cases of oral submucous fibrosis, probably you will be easily able to diagnose. So diagnosis is not a problem in oral submucous fibrosis, but treatment is a big problem in oral submucous fibrosis. If you see the Indian context, there is quite high because it is the principal etiological factor of oral submucous fibrosis is gutka chewing, which is very well prevalent in the Southeastern Asia. There are multiple etiological factors apart from areca nut because there are very few cases although, but there are cases which have been reported in the literature which shows that patient does not have any habit, but still the patient has developed oral submucous fibrosis. There was a patient during my post-graduation, a 6-year-old child has developed oral submucous fibrosis and he didn't have any habit of gutka chewing. He doesn't know what is gutka, but the patient had oral submucous fibrosis. So we have seen some cases of oral submucous fibrosis without any kind of gutka chewing also. That is why genetic susceptibility is there. Small, just a single slide on pathogenesis because why it happens, because there is a lot of microtrauma from the areca nut chewing and that microtrauma causes hemorrhage and that hemorrhage causes a laying down of fibroblast and collagen bundles. And these collagen bundles act as a nidus where fibrosis happens repeatedly. I've told you about genetic susceptibility. Now, a lot of people ask the doubt whether there is any dryness in the oral submucous fibrosis or patient will have increased salivation I want to answer the question here is, with my clinical experience, I have seen when the patient starts chewing areca nut, initially for a year, they'll have increase in the salivary secretion, and later on, once the fibrosis sets in and there is constriction of the opening of the salivary glands, then probably there is dryness. So remember, if somebody asks you about this, initially for 1 year, because there is a foreign body, there is continuous irritation of the salivary glands, there is continuous stimulation of the salivary glands, there will be more and more of salivation, that is stylism, more and more of salivary secretion. But once the oral submucous fibrosis has set in and there is fibrosis everywhere in the oral cavity, then probably there is constriction of the openings of the salivary glands, and because of the constriction, you'll have xerostomia. So remember, xerostomia again act as a precipitating factor for patients with burning sensation. One more thing I want to stress is oral submucous fibrosis starts from the posterior part of oral cavity and progress towards the anterior part of the oral cavity. Remember one thing, don't forget to examine uvula. Uvula is the starting point in a lot of cases of oral submucous fibrosis. Uvula will either be constricted or it will be classical J-shaped uvula, you will see. So fibrosis starts from the soft palate, buccal mucosa, progresses towards the anterior part of oral cavity and involves the entire oral cavity. So this is one of the case, marble-like appearance. Tell the patient to blow the cheek. Patient is not able to blow the cheek properly. Patient is having oral submucous fibrosis because if the patient is having history of gutka chewing. That is why I tell, if the patient is having ankylosis, doesn't mean that patient is having oral submucous fibrosis. History becomes very important because patient might be having any trauma, patient might be having ankylosis, and patient might be having space infection also. But students are sometimes, I've seen patients are in a little bit of hurry. Students, especially the interns, they're always in a hurry to diagnose. They don't want to take the history properly. They will come to me, sir, patient का मुंह नहीं खुल रहा लगता हो ऐसे में. जाके देखते हैं वहाँ पे थर्ड मोलर इंपैक्टेड है, पेरिकोर्नल एब्सेस है वहाँ पे, उस वजह से पेशेंट का मुंह नहीं खुल रहा है. बोलते नहीं सर हम इंजेक्शन देके देख लें क्या. They are in a hurry to learn. They want to learn because they have a plan that they want to open up a clinic. So that's why every patient with a reduced mouth opening, they want to see that okay, this is a AOSMF. I want to give the patient with intralesional injection. Please don't hurry towards the diagnosis. Give at least 10 minutes when you are seeing any special case of that sort. See the blanching, see the fibrosis. There are a lot of staging systems that have been proposed. Khanna has proposed, Andrade madam has proposed, then Chandramani B. More has proposed. So which cases to treat, which cases to you have to send for surgery, this is very, very important. I personally take precaution that if I have a confidence in patient that patient is not stopping the habit, patient has not stopped the habit, I tell the patient go and spend on the gutka only, don't come to me for any treatment. Because unless and until patient has stopped the habit of gutka chewing, we are not able to treat the patient. Remember this, if we are not able to educate and motivate the patient to stop the habit, we are not helping the patient anyway. By whatever treatment you do, you will not be able to help the patient. So first and foremost thing is, you should educate and motivate the patient to stop the habit. Patient should be convinced, you should be convinced that patient has stopped the habit of gutka. If you are not convinced, please don't treat that patient. Please do not treat that patient of oral submucous fibrosis. We have some list of differential diagnosis, but scleroderma, amyloidosis, and anemia, because these patients will have some kind of fibrosis, but they are very rare. If we compare them with the prevalence of oral submucous fibrosis, anemia will not have a fibrosis. Anemia patients will have burning sensations, but they will not have fibrosis. This is one of the most unsatisfactorily treated disease. My personal experience is that patient has not stopped the habit. That is why it is remained unsatisfactorily treated disease. If we see across a lot of patients who have stopped the habit, we have successfully managed those patients. And there are a lot of patients, out of 10 patients, I feel that 8 patients do not stop the habit or quit the habit. Only 2 or 3 patients maximum, they quit the habit. Rest of the patients, they are not stopped the habit. They are just fooling around. I told them, please don't come for treatment. Go for gutka chewing because that is also expensive. Spend money on one thing, either treatment or on gutka. Don't spend money on both the things because you will not be benefited either way. So first is counseling, although you have to tell the patient that stop the habit. You should be convinced, patient should be convinced, patient relatives should be convinced that they have to stop the habit. Then there are a lot of medical modes of treatment. Then physiotherapy becomes very, very important once you are giving intralesional injections. Always remember, physiotherapy is very, very important once you are treating those patients. Then surgical mode of treatment is also there. Among the medical management, we have good course of antioxidants is important. Vitamin B12 is very important. Vitamin A is very important. Lycopene again is very important. Same as the dose of leukoplakia, whatever I have recommended for leukoplakia. Then after antioxidants, steroids remains the mainstay of treatment for oral mucous fibrosis. I personally follow the clinical practice. If the patient's mouth opening is less than 20 mm, I refer the patients to Department of Oral Surgery. I do not treat them with medical management. And if the patient's mouth opening is 20 mm or more, and I am convinced that he has stopped the habit, then only I treat the such patient, because you will not be able to get the results, very good results, if the patient's mouth opening is in stage 4, as per Khanna and Rade staging system. So hyaluronidase is a very good anticollagen enzyme that is being used in the treatment. What we recommend is the mixture of, earlier it was practiced that there was placental extract that was also given, but later on placental extract has shown some kind of carcinogenic potential. So please don't use placental extract, it has been completely banned. Only use a mixture of dexamethasone 4 mg per ml or triamcinolone acetonide along with hyaluronidase. Give weekly once injections along with antioxidants. It will give you good results. I have seen patients with 24 mm mouth opening coming to 34 mm in 4 to 6 months. If the patient has stopped the habit, 10 mm of mouth opening has been achieved in 6 months. If the patient has stopped the habit, there is an always big if. Corticosteroids, I have told you, dexamethasone and triamcinolone acetonide are good intralesional injections. If 20 mm less than and patient is apprehensive for surgery, then you can give systemic steroids for 2 months. Probably tapering is very, very important again to avoid acute adrenal insufficiency. There are some immunomodulators also that have been tried, but not very good results have been obtained from immunomodulators. We are working a lot on alternative course of medicine also, such as turmeric, ginger, garlic, tulsi extracts. Some articles also have been published. Although initial results were very encouraging, but on long-term follow-ups, they have not given very good results. Hyaluronidase, I have already told you. Then some enzymes that are chymotrypsin and physiotherapy. Physiotherapy, simple physiotherapy exercise that you have to tell the patient is ice cream sticks. Use ice cream sticks, how much ever you can put it, and try to put it for half an hour, twice a day for 15 days, and then report to you. And daily you have to increase the width of the mouth by 1 ice cream stick at least. If you can put 2, but don't forcefully trouble the patient by telling how much ever extra don't put. You should not trouble the patient by giving the physiotherapy. It should be comfortable. Lukewarm water also has been helpful at times. Surgical excision, always good, but initial results will be good, but later on there will be a lot of scarring. And if you have used the full thickness skin graft, then probably there will be hair follicles and it will not be a good experience for the patient. Malignant transformation is little high as compared to leukoplegia when we talk of oral mucous fibrosis. It ranges from 2.3% to 7.6%. It was 2 to 3% in case of leukoplegia, but in case of oral mucous fibrosis, it is slightly higher. So always treat it carefully. But again, I'll repeat, always make sure that the patient has stopped the habit, because either by educating, motivating or डराने से आप अगर रोक सकते हैं तो रोकिए, क्योंकि जब तक हैबिट नहीं बंद होगी आपका ट्रीटमेंट पॉसिबल नहीं है कि अच्छा रिजल्ट दे आप. Coming to oral lichen planus, it has got a very high prevalence. It's 1% of the general population that is being affected by the oral lichen planus. Now, apart from the habit, this disease is it is related to stress also. So I again would like to tell all of you that always Monitor the stress level of patients when you're diagnosing a case. If you're thinking that it might be a case of a lichen planus. Lichen planus, if we compare with leukoplakia, has got a very chronic course. Now, leukoplakia and OSMF will not show any kind of skin involvement, but lichen planus always will have skin involvement. Almost 2/3 of the cases of lichen planus will have skin involvement. If we talk of leukoplakia, homogeneous leukoplakia does not have any kind of burning sensation in the initial stage, but a lot of cases of lichen planus, almost 2/3 of the cases of lichen planus will have burning sensation. Classical presentation of lichen planus, a middle-aged female patient in the range of 35 to 50 years with lot of stress will be having burning sensation in the oral cavity. You will find mixed red and white lesion in the oral cavity. Very easy. You can always, after amount of stress estimation, you can always say that this is a patient of lichen planus. There is an autoimmune reaction in the body. There will be apoptosis of keratinocytes that will cause this. There will be degeneration of the cells at the basement membrane, and it will cause this lichen planus. So it is an autoimmune reaction also that plays a role. So if we are talking of lichen planus, we should always examine the skin also. So there are 4 P's. It will be purplish colored lesion. It will have itching sensation, that is pruritic. It will be polygonal in shape, and these are the 4 P's that are present in case of lichen planus. So the classical manifestation when we talk of lichen planus is there will be Wickham's stripe. Wickham's stripe is linear pattern of lichen planus that is always seen in the red erythematous background. That is the classical presentation of lichen planus. Again, only the white and red lesion doesn't mean that it is a lichen planus. You should always go for the clinical examination and assess the psychological status of the patient also, if you are thinking that it is a case of a lichen planus. So there are basically, if you broadly classify the lichen planus, there are 3 forms: hypertrophic form, atrophic form, and the bullous form. And these are the 2 reticular forms of lichen planus. Then this is again a case of reticular form of lichen planus. Linear pattern, zigzag pattern, linear pattern, that is a case of a lichen planus. Then you have round reticular, linear, then annular. Annular, you have round circle-like presentation, then you call it as an annular lichen planus. Then if in the form of a patch, then you call it as a plaque type of lichen planus. And then classical lichen planus on healing will show pigmentation. Then you call it as a pigmented lichen planus. It will come later. Pigmented lichen planus. Then atrophic form, you should be alert if you are thinking that it is an atrophic or erosive form of lichen planus. Then probably you should be alert and you should think that, okay, this has got very high chances of malignant transformation. This is atrophic and ulcerative or erosive forms of lichen planus, which I am showing these pictures. These pictures are very alarming because once you know that this is atrophic or erosive, linear form or hypertrophic form does not show malignant transformation early stage, but erosive form and ulcerative form show a lot of malignant transformation. This is again an atrophic form which has converted into cancer in probably 2.5 years. And very rarely you will see a bullous form of lichen planus also. It has been reported, but very few cases. Lot of cases will come to you either in the atrophic form or in the reticular pattern. Most common are the reticular and the erosive form of lichen planus that are very important. Now, once you are seeing a lichen planus in the buccal mucosa, and if you think that there is a buccal extended restoration, silver amalgam restoration, always remove that restoration and place a composite restoration, because there is a good chance that amalgam might have caused that kind of reaction. Then you don't call it as a lichen planus, you call it as a lichenoid reaction. Remember this, if the amalgam restoration is continuously coming in contact with that buccal mucosa, then there is a localized response, it will be called as lichenoid reaction. Then pemphigus vulgaris is again, you'll have vesicular eruptions which will rupture, and later will have a mixed red and white presentation. But patient will initially tell you that there are vesicular lesions, vesiculobullous lesions that are present. Then erythema multiforme. Erythema multiforme is an acute allergic reaction present in the anterior part of the oral cavity, and it will either will have a herpes virus infection. There will be an episode of herpes virus infection, always called as HAEM, herpes associated erythema multiforme, or otherwise maybe because of some certain common drugs such as penicillin group of drugs and paracetamol. These are the common drugs which are being prescribed and that can cause these kind of lesions. Management becomes very, very important. Why management of lichen planus is very important? All the cases of lichen planus has to be treated aggressively. Homogeneous leukoplakia, you can avoid the treatment, but not in case of lichen planus. Because it has got a very chronic course. It's a chronic inflammatory disorder. It will have a long duration. Lot of cases of lichen planus we have seen and we have thought that we have successfully treated because patient has stopped coming to us after 4 months. And once we thought that, patient returned back to us after 4 months saying that full-blown infection, the chronic lesion that has appeared again. So probably don't think that you have successfully treated that lichen planus. It will have a recalcitrant course. It will keep coming, and it will have lot of seasonal variations also. It will have lot of seasonal variations. Sometimes I've seen patients coming only in the months of January and December. Sometimes patients will report to you only in the month of July and June. So extremely winters and extremely summer seasons, the lesions will exacerbate. Then malignant transformation is very high and stress, very important. I always see that our interns and our final students always don't evaluate the stress in these patients. They want to think that, okay, this is a lichen planus, but very important, you need to evaluate the stress of the patient because that is the most important factor because the stress causes heat shock proteins regulation. Heat shock protein regulation is monitored by the stress, and if the heat shock proteins are altered, then there is a mutation that happens that causes degeneration of keratinocytes. So remember, stress is very, very important. That has to be evaluated in lichen planus. Assessment of stress, I've told you severity of the disease process. Skin involvement, you can always take a dermatological opinion once you are seeing those multiple pulpal-pleuritic polygonal lesions. Then always take a dermatological opinion, and systemic diseases are very, very important because there are certain syndromes. Always you people have learned about that Greenspan syndrome. Some people tell that it is just a myth. Some people tell that it is not a myth. But diabetes and hypertension, these are the two things that are associated. But diabetes and hypertension, those are the drugs that causes lichen planus, not it is associated with this lichen planus. Corticosteroids, if it's localized, then probably you can give intralesional injection. And if it is widespread, then probably go for systemic steroids, at least for 3 weeks or 4 weeks. Systemic steroids are very, very important. Intralesional steroids, if the lesion is confined to a small location, go for intralesional steroids. If the patient is looking to be under a lot of stress, there is no harm in giving sedatives like diazepam. Go for 5 mg diazepam at bedtime for 2 to 3 weeks. I have seen in my personal experience that patient has got good relief from symptoms if the patient was given supplemental dose of diazepam along with the steroids. Some immunomodulators like dapsone 300 mg once a day, then doxycycline 100 mg once a day, then levamisole. Levamisole is a very good immunomodulator. What is the dosage of levamisole that has to be given is 150 mg once in a day for 3 days in a week for 3 weeks. Remember, dosage of levamisole 150 mg OD for 3 days in a week for 3 consecutive weeks. That is the dosage of levamisole that has to be followed. Complications, 0.5 to 20 years rapid malignant transformation has been reported. Just now, I have seen a case of lichen planus in the palate that we were able to treat initially has converted into malignancy. The biopsy report is showing that it is a well-differentiated squamous cell carcinoma. Patient doesn't have any signs and symptoms. Patient came to us 2 years back. Now the patient has reported to us saying that there is an ulceration in the palate. Initially, it was only mixed red and white lesion. Now, after 2 years, patient has again come to us. There is an ulceration. We advised biopsy because we thought that why there is an ulceration, because lichen planus doesn't have any ulceration. They have just erosion. If there is an ulceration, probably you need to treat it aggressively by an oncologist. One of my last slides of my presentation, I have talked a lot about the non-scrapable lesions or the keratotic white lesions of the oral cavity. There are some non-scrapable or non-keratotic lesions. Scrapable lesions are non-keratotic lesions. Most common scrapable non-keratotic white lesion is the pseudomembranous candidiasis, very commonly seen. If you are seeing a candidiasis, probably other things that should come to your mind is the secondary syphilis, that is the mucus patch of secondary syphilis. Then a lot of patients apply a lot of chemicals in the oral cavity like amrutanjan and Vicks. They will have burning sensation, there will be white patch. Then chemical burn has to be ruled out. If the necrotic pseudomembrane is present on the interdental gingiva and the marginal gingiva, then you have to rule out acute necrotizing ulcerative gingivitis also. Then diphtheria infection, it will be present in the posterior part of the oral cavity, that is in the pharynx, anterior part of pharynx and the soft palate. Apart from this, there is one more condition that is commonly seen with pseudomembranous. If the patient has puffiness of face, you check for pedal edema if there is pedal edema, and if the patient is telling that he is having acute renal or chronic renal disease, then probably it might be because of uremic stomatitis also. That is a systemic condition that may cause scrapable white lesion. To conclude my presentation, be patient enough, take a good case history and good clinical examination. If you do a good case history and a good clinical examination, probably you are going to diagnose it very good diagnosis you can make. If you are able to make a good diagnosis, then probably you will be able to treat successfully. Don't hurry up. Don't lose patience when you are talking to the patient. Just take some time, advise good. Don't rush behind the investigation. Don't rush for the biopsy result. Everyone can read the biopsy result. If you are a good oral physician, if you are able to treat them or you are able to diagnose them without doing biopsy. Because biopsy has got a lot of side effects also, remember this. So don't blindly advise biopsy every red and white lesion. I would like to acknowledge these dignitaries, Professor Ajju Samanta, who has just created this environment for all of us. Then Dr. Practitioner, who is the director for the dental college. Then Dr. Virendra Kumar Singh, who is the organizing chairman for this conference, Dr. Sangesh Sir and the CynoDent group for allowing me to present for this conference. Thank you so much.
Thank you so much, sir. It really was a very informative, helpful, and guiding lecture for all of us who are present here and also for the online delegates. One thing I would like to say is that we people, the doctors or the would-be doctors, why we are considered a crucial part of our society, the society that we live in, is because of such diagnosis. The diagnosis of oral lesions, the red lesions and white lesions, which is guided from the Department of OMTR. As said by Sir, the right and timely diagnosis of a person can change our patient's life forever. Also, one more thing that we have learned from Sir is we should never hurry for a diagnosis. If we are giving 10 minutes to our patient, those 10 minutes can save our patient's life forever. And that, my friend, is a very big thing. And this is why we feel proud and grateful by the end of the day. So thank you so much, sir, for the lecture. And now it's time for felicitation of the guest speakers that delivered the lecture today. So I would like to invite Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir, Dr. Dhirendra sir, Dr. Sankamesh sir on stage for the felicitation of the speakers. Please give a round of applause for them. I would like the volunteers to the first speaker to be felicitated is Dr. Abhishek Dubey sir. He was the first one to deliver the lecture today morning. Please give a round of applause to sir. Thank you, sir. The next speaker to be felicitated is Dr. Sagrika ma'am, and she has delivered a wonderful lecture on tools and techniques for predictable orthodontics. Thank you, ma'am. Thank you, ma'am. The next speaker to be felicitated is Dr. Prashant Gupta, sir, and he has delivered a lecture on oral lesions from the Department of OMDR. Thank you, sir. I would also like to invite another speaker who is yet to deliver the lecture, but we would like to felicitate ma'am first. So I would like to invite Dr. Shantana ma'am on stage for a felicitation. Please give a round of applause for ma'am. Thank you so much, sir and ma'am. Now we'll proceed with the further lectures. So moving forward with the lectures, now it's time for the lecture by Dr. Shantana ma'am. But before the lecture, I would like to give a brief introduction about you, ma'am. Dr. Shantana R. Nayak has finished her BDS from SDM College of Dental Science and MDS in the field of oral medicine and radiology from the renowned Bapuji Dental College and Hospital affiliated to Rajiv Gandhi University, Bangalore. She has been in the field of research for the last 12 years and she has been involved in several research programs, especially in oral potentially malignant disorders, oral cancer, alternative Ayurvedic medicines, and their treatment. She has also several publications representing her research work. The topic that ma'am is going to cover today is diagnostic dilemma, which will be followed by an illustration of case reports. Eagerly waiting for your presentation, ma'am. Welcome.
Good afternoon, everyone. I can hardly see anybody, but no issues. My job is only to deliver a lecture. That's okay. No, that's okay. Anyway, it's hardly anybody. I think everybody is audible. If I can just have the presentation. Yeah. So I'm here to just discuss few cases with all of you. These are the routine cases which we have encountered during our clinical hours. Like this is the first case. This is the photograph of a middle-aged female patient who came to us with a history of ulcerative lesions on her lips, oral mucosa, like oral mucosa parts on the ventral surface of the tongue, buccal mucosa, the floor of the mouth, palatal mucosa since 1.5 months. And she gave a history of increase in the or exacerbations of the lesions once she has been exposed to sunlight. Since she is an farmer by occupation, whenever she is exposed to harsh sunlight, the lesions increases. If you see clinically, you saw this, also use this pointer. Clinically, you see this is the photograph of the lip, the mucocutaneous part of the lip. You can see some bloody encrustations or the encrusted lesions on the lower lip and even the upper lip. You can see there are ulcerative lesions, encrusted lesions. There's scabbing because since it's a long-standing lesion, there's some amount of scabbing also. Yeah. Then again, you can see the lesions on this ventral surface of the tongue. This is the left ventral surface of the tongue. The soft palate, ula mucosa, then the oropharyngeal area. You can see there are vesicular bullous lesions on the oropharyngeal area, the soft palate mucosa, then the ula. The ventral surface of the tongue, both on the right and left side. Even the floor of the mouth is involved. Because of these lights, actually, you can't see the clinical photographs so well. Since patient gave a history of these vesicular bullous lesions or encrusted lesions on the mucocutaneous part of the lower lip, upper lip, that's the vermilion border of the upper lip and lower lip, and the exacerbation of the lesions once exposed to sunlight. And these lesions were persistent since for a period of 1.5 months. So, depending on the clinical pictures and the age of the patient, the clinical presentation, we gave a diagnosis of erythema multiforme major. Like erythema multiforme, you would have learned in your theoretical classes saying that it's an autoimmune disorder, vesicular bullous lesion. So how do we carry out with further things? Since it's an acute lesion and so much of bleeding is already present, we usually don't do a biopsy for such cases because patient is already in so much of pain. So clinical diagnosis itself is enough to treat these cases. So what do we do is, first of all, once you get to know the diagnosis, we decide a treatment plan for this particular patient. We put her on steroids, that is systemic steroids. Since it was an acute lesion and many mucosal surfaces were involved, we gave her systemic steroids. Like we started with 40 milligrams in 4 divided doses. That is 10 milligrams in the morning, afternoon, evening, and at night. That becomes like 40 milligrams for a period of 7 days. Once after 7 days, you taper the dose like 3 times, 30 milligrams in 3 divided doses for the next 7 days, then 20 milligrams in 2 divided doses for the next 7 days. For the mucocutaneous part of the lower lip, we had asked patient to apply gentian violet. You can see this purple colored dye here, that's the gentian violet. So patient had applied gentian violet on the mucocutaneous part of the lower lip, which itself healed the lesions. It basically acts as an astringent which reduces the inflammation of the lip or any part of the skin or oral mucosa. Intraorally, we have not asked to apply gentian violet to her. Only the mucocutaneous part, the vermilion part of the lower lip, upper lip, we had asked her to apply topical gentian violet. Other than systemic steroids, we also put the patient on mouthwashes like benzidamine mouthwashes and even immunomodulators. Since it's an autoimmune disorder, we also ask the patient to take levomazole for a period of 3 months. And why did we diagnose a case as erythema multiforme major? All of you would have read erythema multiforme minor with target-like lesions. Intraorally, you usually do not get a typical target, but when it occurs on the skin surface, you usually get a target-like lesions. But in this case, there was no typical targets. There were only scabbing present on the lower lip, and even the skin part were also like part of the neck also she had lesions. All the photographs have not been included. So this was a case of erythema multiforme major, which we treated with systemic steroids, systemic immunomodulators, topical gentian violet, and even multivitamins were prescribed. So why do we highlight the cases? Because I want just to highlight the treatment part of these lesions. So many of you would have been like passing out and putting up a practice, and whenever you get a case of erythema multiforme, major, minor, you should be knowing how to proceed with the case. Just rather than advising a biopsy, cutting a part of tissue and just referring it to oral pathology, saying that diagnosis are got treatment shuru karenge nahi. Till that time, at least you have to give some form of treatment to the patient. Why does the patient come to you is because he is in so much of pain. So unless and until you prescribe some treatment, obviously the patient is not happy. So you treat such cases with systemic steroids, systemic immunomodulators, topical gentian violet, then benzidamine mouthwashes, and multivitamins as well. So let's move on to the second case. That is the post-operative photographs of the first case. You can see she was applying gentian violet. She came to us after a period of 1 month. There was quite some remission in the lesions here, lower lip, and upper lip lesions have almost vanished. You can see the ventral surface of the tongue is also healed by the time she came to us after a period of a month, that is 4 weeks. After a period of 2 months again, you can see that the complete resolution in the lower lip. Lower lip, it's almost healed, completely healed rather. So that was the beauty of this case, wherein we treated it so effectively. Then this is the second case. Although we haven't treated this case, but I'll just highlight the importance of this particular case. So this was a middle-aged man again who came to us with a history of generalized gingival enlargement for a period of 15 days. Just remember, it was an acute onset, 15 days of history of generalized gingival enlargement. If you clinically see the case, there's so much of lobulated enlargement of the gingiva, lobulated enlargement of the gingiva, almost reaching till the incisal third of the teeth. Incisal third of the teeth it has reached, even with the molars and the upper and the lower incisors, the enlargement has reached till the incisal third of the teeth. See, there is lobulated enlargement of the gingiva. Along with that, you can see some published discoloration, probably because of the underlying vessels. You can see this discoloration here. And considering the local factors matlab stains, calculus, okay, hardly any stains are there, hardly any calculus is there. So if you just look into this case, you will see, arey to ek gingival enlargement ka case hai, probably inflammatory hai. But once the patient gave us the past history, there was a significant history of fever, recurrent on and off fever, a very significant history of weight loss and fever. That was enough for a diagnosis of this case. So immediately we referred the patient for a complete blood picture and more importantly, a peripheral blood smear. Peripheral blood smear was like working like a wonder in this case because it almost completely diagnosed the case as acute myeloid leukemia. It was not a case of inflammatory gingival enlargement because there was no local factors whatsoever, no stains, no calculus. If in case there were stains and calculus, the first diagnosis would be an inflammatory gingival enlargement, but there were no stains and calculus, so we ruled out the diagnosis of inflammatory gingival enlargement. So we could later refer the patient for a peripheral blood smear, which diagnosed it as acute myeloid leukemia. Since acute myeloid leukemia is not our territory, we referred the patient to higher centers. But higher center, the patient went. He went to a government hospital wherein some of his relatives said, "दांत साफ कराओगे तो सूजन जो है मसूड़े का कम हो जाएगा." That's how. From there, once he was already in inpatient department, patient already he was admitted into the particular department, but patient, because taking the opinion of his relatives, he went to a private dentist. He got his oral prophylaxis also done. So once the patient gets his oral prophylaxis done, you incite some amount of bleeding, the lesion exacerbates. It results in a systemic circulation of that particular myeloid cells or the leukemic cells. There is a rapid increase in the metastasis of these lesions. So within a period of 15 days, we had already lost the patient. So what is the significance of this case is, this is another the palatal or the lingual gingiva also. It is enlarged here, lingual gingiva. अगर inflammatory gingivitis होता है या फिर inflammatory gingival enlargement होता है, then usually the lingual and the palatal gingiva are spared. Very rarely, very mild amount of inflammation you could see. But this case has got so much of enlargement of the gingiva here, even the lingual gingiva, the lobulation of the lingual gingiva here. And this is the peripheral blood smear photograph, which is showing immature myeloid cells. Immature myeloid cells or the neoplastic myeloid cells with larger nucleus, reduced nucleus cytoplasmic ratio. You can see here. So why do we read about this particular cases? If in case you encounter a case of generalized gingival enlargement, please look into the local factors, that is the stains and the calculus, then jump upon a diagnosis. If in case you don't see any local factors, that is no stains, no calculus, just advise a simple blood smear and a complete blood picture to rule out any myeloid leukemia or lymphoid leukemia. So coming to the third case, this is again a male patient who was in his 50s, who came to us with the history of this scarring here, and intraorally he had these lesions which used to bleed and a foul smell. So he had complained of scarring on his right lower third of the face and these lesions intraorally which used to bleed. When we asked about the past history, patient said that he had vesicular lesions in his right lower third of the face about 1.5 months ago, associated with fever. But when we saw clinically, the lesions or the scarring stopped just at the midline. It was not crossing the midline. It was only unilaterally present. Can you see the scarring? It is not crossing the midline here. It is just stopping at the midline. The scarring, this particular part of the scarring, that is part of the skin over the chin and on the body of the mandible. And intraorally, we saw there was a bare bone or a naked bone which was visible with those sockets or the empty sockets of all the teeth of the fourth quadrant. The entire fourth quadrant teeth were missing in this case. Can you see the
पूरा टेढ़ा हो गया, कोई इस पे लात मार के गया है.
3-1 से लेके 3-2, 3-3, the rest of the teeth are present, but right from 4-1 to 4-8, none of the teeth are present. When we asked about the history of tooth loss, patient said tooth loss was like gradual, not like immediately एक के बाद घट गया. Initially there was mobility of the tooth, and gradually he lost one by one tooth. All the tooth of the fourth quadrant he lost. Immediate, that was like post he developed fever, losing the teeth on this part. So radiographically, when we took an OPG, we saw there was this sequestration here. Can you see this part of the bone? That is the entire alveolar part of the bone of the fourth quadrant. It has been separated from the underlying bone by this gutter. Can you see that radiolucent line? It is separated because this part of the bone is infected bone, and under it you have the viable bone or the healthy bone. This is the sequestrated part of the infectious bone. So looking at the clinical pictures, the radiographic pictures, and the history, we gave a diagnosis of herpes zoster. Herpes zoster, not simplex. Why zoster? Because the lesions are not crossing the midline. And the bony lesions, whatever you could see, it was classified as zoster-induced osteonecrosis. That is zoster-induced osteonecrosis. So how did we manage this particular patient? Because since he had already got those bony lesions, we referred the case to oral surgery for treatment. That is, you do a curettage for that particular part of the bone. You remove the sequestrum, you suture it, or you clean that, debride that particular area. The patient was put on antiviral drugs. He was put on a course of antibiotics, analgesics. But ultimately, the patient didn't turn up for any post-op photographs. So I don't have the post-op photographs of this case. But this clinical presentation itself is enough for you people to just learn. If in case you encounter a case of vesicular bullous lesions, which is unilateral, not crossing the midline. Even when it is occurring intraorally, the lesions usually don't cross the midline. Like you would see palatal lesions unilaterally. You would see labial lesions only unilaterally. It will just stop at the midline. That's because zoster runs around the course of the nerve. So whichever nerve, that particular area is supplied by that nerve will only get affected. So that is the reason you find a unilateral distribution of these lesions.
एक bottle लेता हूँ,
So
ऊपर
then this
दूसरा
is the
bottle
another case
एक
wherein
bottle
we
दूसरा
had this
bottle
middle again female patient in her 50s who came to us with a history of diffuse swelling in her face since 4 years. She had this swelling since 4 years. There was no history of increase or decrease in the size. This particular diffuse swelling was persistent since 4 years. And if you see her lip, it is like pouting. It is hanging, the lower lip is hanging, pouting. And there are these pigmentations on the lower lip. Can you see her upper lip? Can you see the philtrum, which has been like almost obliterated? There is an exacerbation of the nasolabial fold here. Even the cheeks, it looks hanging. Even the mental, this region, the fold here, it has been exacerbated here or accentuated. When we asked into the past history, there was no history of fever, no history of cough, no history of any kind of contact allergy, no history of any kind of allergy to food, no history of fever whatsoever. So depending on the clinical presentation, on the long-standing duration of the lesion, we came to a diagnosis of what you call a delayed type of hypersensitivity. Delayed type of hypersensitivity. Since the lesion was present in 4 years, patient had not given any significant history of allergy to any kind of food or contact allergy, no history of fever, no history of gastrointestinal disturbances. So we gave a diagnosis of delayed type of hypersensitivity, and that too with delayed type of hypersensitivity, we gave a diagnosis of orofacial granulomatosis. Orofacial granulomatosis is another what you call granulomatous lesion which is occurring in the orofacial region. So depending on the history and all, we gave a diagnosis of that, and we later advised the patient to undergo certain investigations like chest radiography, endoscopy, then the lip biopsy, and some blood investigations like complete blood picture. All those investigations were normal. So ultimately, we continued with our treatment, saying that considering the case as orofacial granulomatosis, and we put the patient on steroids, systemic steroids again, immunomodulators, systemic steroids and immunomodulators. Since there were no ulcerations, so there is no need of any mouthwashes or topical gels or anything. So only two things we had advised her, that was systemic steroids and systemic immunomodulators. She has visited to us after a period of 4 months, and you can see the regression in the sides of the swelling here. See her lip, which was like pouting and hanging, it was almost reduced to almost say 75% to 80% here. See, this is the first baseline photograph, and this is the post-op photograph. Can you see some differences here? So this was a case of orofacial granulomatosis, which we had managed successfully in our department with systemic steroids. Initially, we started with systemic steroids for a period of 15 days. Then once, since we didn't achieve so much of good results, we started giving her intralesional steroids. Intralesional steroids is like you give Dexona 4 milligrams within the labial mucosa, buccal mucosa, you directly inject that particular steroid within the mucosa. So that is intralesional steroids. We managed this patient successfully with intralesional steroids for a period of around 1.5 months. So the patient used to come to us like every week for us intralesional steroid. Then this is another case. Can you see there's a calculi here or a stone or radiopacity here? Can you see this radiopacity? Then this case is only hold if in case you see this radiopacity. This was a female patient in her 20s, like 25-year-old female patient who came to us with a history of enlargement in her left submandibular region since 1.5 months. So the swelling was recurrent. Like what was the significance with the swelling was, the swelling used to occur only when the patient used to eat some food. After 30 minutes post the patient stops eating food, the swelling used to reduce. So that was a significant history with this female patient. wherein the patient gave a history of swelling which increased and decreased during the meal hours. That is, only while chewing some food, the swelling used to increase, and after the patient stopped chewing, the swelling used to decrease. That was a very significant history. So when, depending on the history of the patient, we could understand this was a case of cylolith, that is submandibular gland cylolithiasis. Cylolith is like something like a rhinolith or a phlebolith, a stone, basically a stone within the salivary gland that is referred to as cylolith. We took a occlusal radiograph, that is mandibular occlusal radiograph, and because of these lights, you can't see the radiopacity here. Probably the next slide. See here, can you see this here? There was a radiopaque shadow here. So that confirms the diagnosis of submandibular gland cylolith. This is a post-op mandibular occlusal radiograph wherein you can't see any cylolith here. So the patient was, this particular patient was then referred to surgery for removal of the calculi within the salivary gland. And how will you proceed with these cases is like, if in case you encounter with a case of cylolithiasis, like patient gives a significant history of increase and decrease in the size of the swelling only during the meal hours, it is surely going to be a cylolith. You advise a sonography, that is ultrasonography of that particular gland, either the parotid gland or submandibular gland. You can do a conventional radiograph like OPG, or OPG usually submandibular gland calculi gets overlapped with the mandible, so you can't see the calculi, so you advise a occlusal radiograph. The best would be an sonography, that is ultrasonography for these cases. Then once you can diagnose the case, you can accordingly call an oral surgeon and then manage the case. Then this is another case of a male patient who was in his 25 years of age, who came to us with a history of these ulcerative lesions at the posterior right and left buccal mucosa. Can you see these white lesions here? These white lesions, there was restricted mouth opening. That's the reason you can't see the entire lesion, because the patient was not able to open the mouth. That's why we couldn't take good photographs, clinical photographs. Patient was in a lot of pain. See, we could see some white lesions at the right and left posterior buccal mucosa here. And what was the significant finding with this case was this patient had a history of pedal edema. Like when we examined his general physical status, he had a pedal edema in both the legs. So we asked him, like, since how many months or days is this particular pedal edema existing? He said only since 15 days. Pedal edema itself strikes us that we should refer him to a general physician for further opinion. So we referred him to a general physician for this particular pedal edema. So he had advised some renal function test, liver function test, and a complete blood picture. On renal function test, his serum urea creatinine were increased. So that particular case we diagnosed as uremic stomatitis, or oral manifestations of renal failure. That is termed as uremic stomatitis. The stomatitis or the inflammation of the oral mucosa occurred in secondary to increase in the serum urea. Once there is increase in the serum urea, obviously you know that urea can get secreted to the GCF, that is gingival clavicular fluid, and then into the saliva, and then into the oral cavity. The increased urea could actually cause kind of chemical burn within the oral mucosa, and that is what has caused the lesions in this patient. The white lesions, there is burning of this particular part of the mucosa that has resulted in the white lesions, and these lesions were not scrapable. They were non-scrapable lesions, and they were very painful. Patients had trismus or inability to open the mouth only because the lesions were present in the retromolar pad area. That's the reason there was inflammation of that particular mucosa and patient couldn't open the mouth. Once patient was diagnosed as renal failure, he was further treated under that particular general physician. And he came to us after a period of 1.5 months. So the uremic stomatitis lesions, even after 1.5 months, this ester was still present on the palatal mucosa. By this time, patient was able to open the mouth. That's why you can see the palatal lesions here, and these white lesions in the posterior part of the buccal mucosa. The ester lesions present on the palate. This was 1.5 months after the treatment. Then after almost like 4 to 5 months of treatment, he didn't have any lesions, white lesions. Mouth opening was perfect. He had a normal mouth opening. You can see there was no clinical lesions, oral lesions here, no white lesions. Retromolar pad area is all clear. The balcony mucosa is all clear. See here, it's all clear. If you want to just go back to the previous photographs, see this is the same patient. You can see there's a fill restoration here. And the same restoration is existing here as well. It is the same patient, not another patient. So what is the importance of this particular case is, like if in case you encounter such lesions, non-scrapable white lesions in your general practice, and if in case you just have to just make an attempt to just look, like since patient would be lying in a supine position on your dental chair, you can around look at his feet. And if you see any kind of pedal edema on his either of the feet, you just ask a history, like since how many days. You make an effort to refer him to a general physician. General physician will later advise necessary treatment, like investigative procedure, either related to cardiological manifestations or nephrological manifestations or hepatology manifestations. So accordingly, you can diagnose the case and we successfully managed. Probably we saved his life because he was diagnosed with acute renal failure by the general physician. So almost it took 6 months for that patient to just recover from that renal failure. It could be you who could have saved the patient. So just keep these things in mind whenever you are practicing in your clinics. That if in case you see such lesions wherein you can't trace any etiology, you just don't know like how can you just relate these cases to oral manifestation. Just make an attempt to refer him to a general physician and take an opinion from that particular physician. Either like a renal function test, a liver function test, and even a cardiac examination also is necessary. So that is what is the importance of this particular case. This is the same case of uremic stomatitis, so won't be dealing with it again. And the last case for today's presentation would be, like, can you see this ulcer here? And there's a sharp linear fissuring kind of ulcer surrounded by keratinization in and around. And if you closely observe, there is a sharp cusp here. Because of the fractured tooth, there's a sharp cusp here. This female patient came to us with the presence of this ulcer since 15 days. So when we examined her, there was like induration around this particular ulcer. Although there is keratinization, no malignant changes were present with this. But why am I highlighting this case is, you can see there is a sharp cusp. This sharp cusp itself is the causative factor for this ulceration here. Anyways, the patient has given us a history of 15 days. You leave it for another 15 days, the patient might develop some malignant changes within the ulcer. So what do we do with such cases is, there should be an immediate extraction or immediate trimming of that particular tooth. You either advise an extraction of this particular tooth which is causing the ulcer. If you don't advise an extraction or enameloplasty, that is referred to as enameloplasty of that particular tooth, there could be malignant changes within this ulcer. And you know those 6 S's of oral cancer, in which you have a sharp tooth. S stands for sharp tooth. So this particular sharp tooth needs to be treated immediately. And other palliative form of treatment is like topical steroid could be advised in this case. So the purpose for including this case was, like, since all of you are just going to finish with your BDS, you just remember, like, if in case you encounter an oral ulcer which is present for a period of 15 days, or even if it is present for a period of around 1 month, which is not healing, you kindly look into the local factors like any sharp tooth or any cause. And if in case the patient has come to you with a history of long-standing ulcer which is not healing even after treatment, then you advise a biopsy of that particular lesion. And if in case you find some malignant changes, obviously you will have to either refer him to oral surgery or to a higher center for the treatment of the cancer. So that's all for today's presentation. I would like to thank the organizers for the opportunity and of course the KIIT KIIT has given me a lot of opportunities right from the year 2017. And special thanks to Dr. Sangamesh sir, who had called us for this presentation. Thank you so much.
Thank you, ma'am, for the lecture. And now it's time for lunch. So I would request you all to proceed for lunch. But do not forget to join us after lunch for the valedictory function. So everyone can proceed for lunch.
क्या हो गया बाबू? सर गुस्सा हो गया आपकी बहुत अच्छे हैं चलो चॉकलेट चॉकलेट
हम क्या आते हैं चलो बस वेरी गुड चलो चलो
प्लग आउट एंड प्लग इन
नहीं प्लग आउट प्लग इन नहीं यहाँ पे कितना सब चल रहा है देखना कितना सब ये दिखाई नहीं देता कैमरा को बॉटल पे क्लिक करके एटा को पूरा कैमरा को बॉटल पे क्लिक अब टिके सब को टेढ़ा होने का नहीं है बस सब पूरा आना चाहिए रूफ ज्यादा नहीं आना चाहिए इतना
Can you please allow me to share my screen?
Hello. Good afternoon, sir.
Hi, good afternoon. Can you please allow me to share the screen?
Just a second, sir. Manish Kumar, Dr. Manish Kumar. Am I audible, sir?
Yeah, you are audible. Am I audible?
Yes, sir, you're audible right now. Just a second, sir. Give us 5 minutes. We'll be starting.
Sure. Okay.
Okay, so we'll be starting now. We'll first introduce you, then you can go ahead with the lecture.
But you can connect.
Yeah. Thank you.
There is the project.
एक काम करो.
So after lunch, we are again going to proceed with the lecture. There will be 2 more lectures, and after that, there will be valedictory function, which will end the evening. So the first speaker now for the lecture is Dr. Manish Kumar sir. He'll be taking an online lecture for all of you because he's not physically present here today with us. So a brief introduction about Dr. Manish Kumar sir is that he is a professor and head Department of Public Health and Dentistry from Geetham Dental College and Hospital, Visakhapatnam. He has completed his BDS in 2002 from Bapuji Dental College and Hospital. He cracked KCET and secured 33rd rank and completed MDS in 2006 from CODS Davangir. He is currently working as an academician from the past 17 years, and he has been presenting guest lectures at various national forums. He has around 20 publications to his credit, and he is also associated with coaching for the students pursuing NEET MDS entrance exam from 17 years. So now we'll start with the lecture, and sir is connected via Zoom meeting, and he'll be taking an online lecture for us.
Am I audible now?
Just a second, so we're connecting the audio. Just give us 2 minutes.
Okay, let me know to start.
Yes, sir, yes.
नहीं ये ठीक है ये ठीक है
Continue.
Yeah, can I start now?
Yes, sir.
Good afternoon, all. I'm really very sorry for. I was supposed to take it 2 o'clock. The reason is I have to pick up my daughter, so my own personal problem. So I'm really very sorry. So at the outset, I would like to thank Dr. Sangamesh, Vice Principal, Kalinga Institute of Dental Sciences, for giving an opportunity. Of course, I'll be thanking him at the end also. So today's topic is study designs in scientific research. Please understand that this is a huge topic. Generally, I conduct a workshop on this, but since Dr. Sangamesh told me that he just wants a brief outline of how research is conducted in our dental side. So what I've done is I have tried to give you a brief outline how the main research will take place. So you can call it as a trailer or a teaser of a film. Picture bhi baki hai mere dost. So for this, actually it takes a couple of days workshop. That's what we do it for our BGs here. So I have tried to make it as simple as possible in the language that I was told. Again, the target audience is undergraduate students. So I've tried to make it in a very simplified way. If it is oversimplified for postgraduates, then I'm really very sorry for it. But otherwise, yeah. Okay, so please bear with me for half an hour. I'll not take more than that. So yeah, what exactly is research? Now, as you all know that I was introduced as public health dentist. So wherever public health dentists go, first of all, we have to give a definition for it. So what is a research? It's a quest for knowledge through diligent search or investigation or an experimentation aimed at discovery of interpretation of new knowledge. So basically, if you split the word research, you are searching back again certain things, which might have been missed by somebody. So, one person would have done a study with respect to age, how age will influence leukoplakia. The other person wants to find out how does gender will change for leukoplakia. So basically, you are trying to search a new information. Okay, so that is what is called research. What is the need for conducting? So why should we conduct research? First of all, to identify new diseases or syndromes or problems. Okay, so research will help you do that. It helps us in developing new preventive or treatment techniques or protocols. Helps us in identifying patients' needs and satisfaction level. You can keep getting better at what you do. So implants, for example, if you take it, why so many new techniques are coming up? You already are an implantologist, but why should you know? So you are getting better at what you are currently doing. So keep up with the changing technologies. So technology will not stop. 20 years back, 25 years back, if somebody would have told me, I joined my undergraduate 1997, I had never, for the first time in my life, I had seen a mobile that time. If somebody would have told me that mobile is going to change the whole world, the way we see it, for which you can do everything, okay, I would have never believed it. Okay, so this is just one example in our day-to-day life, keeping up with the change. You can sit at your home, you can do everything from your mobile, everything. You can pay your bills, free tickets, resorts, restaurants, plan a trip, everything you can do it. Now, how do you apply the same thing in our dentistry? Again, 15 years back, we talk about intraoral scanners and all, nobody would have believed it. Now they are main thing, isn't it? So what I'm saying is, with continuous research, you do get to know that how the latest technologies can be implemented. Okay. So what is a research for? Now, before you start a research, you need to know why you need to conduct research, why you need to conduct a research. So you have to come up with a question or a problem. So research always starts with a question. Now, for example, you are doing a patient and it's a new case. You have never seen such kind of a case, however experienced you are. So you want to find out more about it. So you start researching through internet. Okay, so research begins with a question or a problem. The purpose of a research problem is to find answers or solve a problem to questions through application of systematic and scientific method. So you are using internet for all your queries. Let us say you don't find an answer for it. Then you decide, okay, since I'm not finding an answer for this problem, I'll conduct my own research and try to see what I'm getting, isn't it? So what do you need for conducting research? This is again a very important thing. So everybody in every place cannot be done research. Okay. So you need, first of all, for yourself, a critical thinking mind. Okay? You need to be a good planner. You need to have determination, because when you're doing research, there are going to be roadblocks. Okay, for example, finance can be a roadblock, funding, time can be a roadblock. So when you're following it up, 3 years back when 2019, when 2020, sorry, when COVID came to India, approximately at the same time, okay, March 3rd, when March 22nd, we went to lockdown. Before the lockdown, the work on the vaccine started. So my father was just asking me, how will we get the vaccine? Mr. Modi is very particular about it. He is going to get it within 6 months or 1 year. And I was telling him that when you're doing a typical randomized control trial, there are going to be a lot of failures, and it generally takes more time. So the scientists who are working on it, or you yourself in their shoes, let us say you're a researcher, you need to have a strong determination, because you are bound to have failures. You are bound to have, disagreements with your colleagues with whom you are developing something new. So you need to have a determination that what you're doing is correct or not. You need to have access to literature. Very, very important. That is what I was showing you. Now, everything is at the tip of your fingers. Okay, you can just search everything. Infrastructure. Not every college will have a good infrastructure. Not every work setup will have a good infrastructure. And of course, if you're a student, you need to have good guides, what we call it as mentors in some places, we also call them as teachers in some places. You need, as a student, you need a good guide to guide you the pathway of the research. If you see it, look at these images. What exactly are these images representing? It is how to get an idea. How you get an idea. Where should you start? Okay. So for that, as I said, you're working on a patient and you realize that you have never seen such case. Needs to be done something new. Why don't I do research on this new problem? Research while you can do while treating a patient. On systematic field observation. I go to a lot of camps. In the camps, I come across certain mindset of the people, which is a hindrance for their oral health improvement. So in the field setup also I can get an idea. Out of the box thinking. You're brilliant. Some of you are actually. So it's an out of box thinking from your side. Information from a journal or a book. So you are going through your articles or your textbooks and you get a doubt in your mind. You try to find the answer to the literature which is available in the Google, but it is not apt to the answer that you're looking for. So gives you an idea. Okay, why don't I connect my own research? Being skeptical to prevailing beliefs and paradigm. You are skeptical. For example, the current norm is according to DCI, we have to place amalgam restorations in. That rule has not changed yet. So I don't want to do it. What is wrong if I use composite for my patients? So you are skeptical to the prevailing beliefs. Creative ideas arise during informal conversations and brainstorming sessions. That's why the previous image was I had given you. So you're talking with somebody informally or formally, and you get a creative idea by attending conference. What you're attending here is a webinar. Okay, because I am sitting in Visakhapatnam, my department, and you are in Bhubaneswar. You're attending a webinar. You attend conference, you attend conventions or CDs or cutting edge research. Sometimes it's your gut feeling, your hunch, what we call it as, which says that yes, this needs to have been, we should do a research on this. For example, recently I attended a meeting with Science College, and it opened my mind for so many possibilities. One example I'll give you. One of the researcher whom I met on Saturday recently, last week, and he is doing a research PhD on trying to find the link between the microorganisms present in the gut with Alzheimer's. It is just we had never thought it. So we thought that there is degeneration of the nerves that will lead for a person to become Alzheimer's. Now he is trying to link with the organisms. Now, why organisms are important? Tell me, gut organisms, because microorganisms will survive based on the food that we eat. So he's trying to correlate what is the relationship between the organisms, food that we eat, as well as Alzheimer's. So he had that feeling. So it's called as a hunch. Okay, so you can get the idea from so many sources. Now, when you're doing a research, it's like juggling multiple balls, which you would have seen in a circus. A joker will be there; he juggles so many things. Research is something like that. Doing research is not a linear process. Understand that. You have to be more proactive. You'll always be doing so many things at the same time. And it needs multitasking. You have to develop multitasking skills. You have to understand that each task will affect others and is affected by the other. That means your introduction is interlinked with methodology. It is linked to the results column, linked to the discussion column, the conclusion. It is something like, very simple. In your case history, when you record a case history, you record patient's chief complaint. That is the first thing that you will do examination. Yes, and that is the first thing you will write diagnosis for. That is the first thing you write in your treatment plan. They are all linked. Your history taking, examination, diagnosis, and treatment plan. Each task is affected by that. So one of them goes wrong, the whole case history falls down. The same thing is even research also. All stages are interlinked to each other. Okay, you cannot say that, oh, I am good at statistics, I'll manage only results, I'll forget about the methodology. You can't do that. You will say that I'm good at methodology, let me forget about the background or introduction. No, you can't. You have to have a flow chart like that. So you need to understand that everything is linked. Okay. So there are various study designs. This is what is my main topic for in research when you do. So when you broadly classify them, there are two types: descriptive as well as analytical. Now, descriptive, as the name says, that you are only describing the condition. Okay. For example, I give this example very commonly to my students also. What do you see on your screen? Hope you are able to see. It's a pen in my hand. So what is this? How do you describe this pen? Pen is black in color. It has a TikTok button at the top. It writes blue in color and it is used to write on the paper. So I'm basically describing this particular pen. Now apply this same English when you go to a field survey or in your own clinic. You have got a patient. For example, what is the case report? You've got a patient. Completely unusual finding you've never seen. You are just describing the condition. You are not trying to find out what might have led. If you want to find out the cause, then you need to conduct analytical activity. Descriptive means you are just describing the condition as it is there in the patient or in the field. That is what is called as descriptive. Then comes analytical. Now, I want to find out what is the cause of this particular disease. What is the cause? Why some people are behaving like this? Why only some people are turning from leukopenia to oral cancer? Why not everybody? So for that, I need to conduct analytical activity. And in analytical, again, we have got two types: observation and experimental. As the name again says, observation. I will just observe. I will just observe. I will not do any experiment. Then comes experiment. Means in experimental study, as a researcher, I will myself put some new drug in the patient. Like for example, I want to develop a vaccine. So for some people, I will give vaccine. For some, I will not give. And see whether a vaccine, by giving vaccine, is protecting against the disease or not. So that my efficacy of vaccine is increased, isn't it? So observation means you just observe. As the name says, case control, cohort, and cross-sectional. Now cross-sectional can also be descriptive. So when it is here, surveys are also called as cross-sectional. As a researcher, I will say I want to conduct a cross-sectional survey. That means I am just going to tell the information what is there. Cross-sectional study means apart from finding out what is there, I am also trying to give you the reasoning also. Okay, I'm analyzing the results also. Okay. We will go one by one now. Before I go to each type of study, one thing you have to remember: in every research that we do, we have something called as a word which very commonly used is called as the variable. Okay, what is a variable? It is something that we are measuring. It is something that we are measuring. For example, simple. For example, I want to find out how sugar will influence dental caries. Okay, so here sugar is a variable. I can measure sugar. Yes or no? Caries. I can measure caries also. So they are both are variables. Okay, they both are variables. Now, the most common variables that we use in our studies are age, gender, weight, height, health status, alive, dead, diseased, healthy, annual income, smoking, non. Yes or no? Now, I gave you an example 30 seconds back. What is the influence of sugar on dental caries? So there are two different variables. Sugar is one of the risk factors for caries. Yes or no? And the effect that I'm seeing here is caries. So this is what is called as an independent variable and dependent. Sugar is the independent variable. Caries, the effect I'm seeing here is the dependent. You can give this example in other way also. Like for example, here I have given you, if you can see the screen, smoking. I want to find out how smoking is associated with oral cancer. Smoking here is the independent variable cause. Okay, and oral cancer is the effect, which is called as dependent variable. So basically, I'm trying to find out if a person smokes continuously, will he develop oral cancer, or a non-smoker will develop more oral cancer. Okay, so one is independent variable, one is dependent. You have to know when you are doing this research what will be the independent variable, what will be the dependent variable. You can apply for every single research. You will find these terminologies: dependent, independent variable. You have to understand when you're reading the research also. Okay. Now, what is a descriptive research? This study is designed to describe the distribution of one or more variables. As I said, without regard to any causal hypothesis. I am not going to give any positive. I am just describing. It is writing blue. My pen is writing blue. That is all I'm going to say. How does it write blue? Thin, thick? I am not going to. Why does it write blue only? Why does it not write red? I'm not going to be bothered. I'm just saying that it writes. That's all. Okay. Now, these do not try. These kind of studies, this research does not try to answer questions or establish relationship between the variables. Examples are case reports, case series, cross-section surveys, as I've already given them. So what are the examples for them? Example is to evaluate teachers' attitude using technology. So I want to find out in my college, the teachers have started using technology. Okay, I want to see whether they are able to understand the technology or not. That's all in my job. Are they understanding or are they not understanding? If they don't understand, why don't they understand? I'm not bothered about it. That will come as analytical. Okay, I am right now saying attitude is good, bad, or poor. That's all. I am not bothered. Why? Okay. So different types of things are there. What is a case report? In most of the clinical department, okay, that includes right from oral medicine it starts. Oral medicine, oral path also there will be. You see something new in your slide. Except the community, everywhere you will have case reports. Everywhere, all departments. Okay, they will have case report. It means description of a patient with an unusual disease. That is called reporting. Case, one case. Okay. If there are multiple cases like that, then I call it as cases. Case report means description of a patient with only one something abnormal like you've seen. You've never seen it before. Comes a report. Case series means multiple cases, unusual cases, which is then we call as a case series. Okay. Basically, the idea of case report and series is to bring forth the previously unrecognized diseases, and it plays a very important role in advancing medical science. Ideal example is HIV or AIDS was first recognized through a case report of a disseminated Kaposi sarcoma in a young homosexual man all the way in 70s, in the 70s or 80s. They had found out that one person came with a Kaposi sarcoma, which was a very rare case. Okay, and of course he was a homosexual man. So when it was reported, it was a positive organism was HIV and the syndrome was AIDS. Okay, so this was a case report. Okay. Then this is what I, as a public health dentist, depend. My whole maximum of the research that happens in my field, in public health industry, is called as a cross-sectional study. Okay, so what exactly is a cross-sectional study? Okay, so if you look at the image here, what are the features of it? You see, each one is from different races. The image, each one of them is a different races. So it takes place at a single point of time. So let us say these people belonging to different races, they are living in a community. I want to find out what is the caries status among all of them. Okay, then I will tell whether the caries is more in this black Negro or in a blonde woman. Okay, so it takes place at a single point in time. Does not involve manipulating variables. No, I am measuring caries. No, I am just measuring. I am not going to manipulate it, the variable. Okay. It considers several characteristics. As I said, race is one character, age is another, gender is another, diet is another. So I can consider all the variables at once. Okay. It analyzes the prevailing characteristics in a given population. What are the benefits? Very important. Again. What are the benefits of conducting a cross-section study? It's relatively quick to conduct. I am planning one next week. Hopefully, God's grace, I can plan one. So it is relatively quick to conduct. The researchers can collect all the variables at one time. Okay, all the, I just said age, gender, diet, race, smoking, income, socioeconomic status, education, everything, all variables put together. I would like to see how caries is influencing. So I can do with a cross-section study. So multiple outcomes can be reached. Okay, prevalence you can get. Prevalence means total number of population affected. That is what is called prevalence. Prevalence gives you proportion of population affected or the magnitude of the disease. There are different terms. Meaning is the same. Prevalence means whenever you hear in research, the researcher wants to find out proportion of population affected with one particular disease, your mind should go towards prevalence, or it's also called as a cross-sectional study. Okay, it is suitable for descriptive analysis. Researchers generally use the data that is collected through a cross-sectional study. They use it as a baseline. So prevalence studies will give you a baseline data. Okay. Now, example, how cross-sectional study, what will be their aims? I want to find out the total number of school children who are aged 20 years suffering from caries in Visakhapatnam. So I will conduct a study. And that total number is also called as magnitude of the disease or the proportion of population affected with the caries, age 12 years. As I said, total number when it comes, basically prevalence. That means it can also be asked or told to you in of magnitude or proportion. Okay. Second example, there are 3 villages which had an outbreak of cholera. As an investigator, I want to find out how many out of these 3 villages are suffering. So see here, group 1, village 1, village 2, village 3. Out of these 3 villages, how many are suffering? I will get to the percentage of the population who are suffering from the disease. Okay, that is a typical cross-sectional study. Okay, now comes the observation study. Now here, if you look at the image and what I have written here, lab studies are difficult or less useful. You can go into the nature. Just observe how people are behaving. Don't intervene. The typical 2 studies which an undergraduate would have heard are the case control and the cohort study. You would have heard about it. Okay. Apart from that, you have cross-sectional study also. As I said, you are just observing and then you are extending. You are trying to analyze also why only these particular people are also suffering. You are extending your descriptive to analyze the result also. Then it is called as cross-sectional analytical study. If you are not analyzing the cause, then it is only called as cross-sectional survey. Okay. As I said, a typical case control study. Now here, if you look at the synonyms, it's called as backward looking. That means disease already has happened. They are called as, so you take 2 groups here. Cases are those who are suffering from the disease. Controls are those who are not suffering from the disease. Okay. So you choose, I want to know, I'm the researcher. I want to find out, are my cancer patients because of smoking? So I will conduct a research. Retrospective, that means the disease has already happened. You are going back in time to find out. You are going back in time to find out why these particular people have got. So you see here, cancer patients are the case and the controls are those who do not have the disease. I will interview them both by picking histories. I will see in their history, do they have smoking? And I will find out that they don't have smoking. Then I will say, yes, these patients have developed oral cancer because most of them were smokers. Okay, most of them were smokers. Okay, so for my conclusion, this is what is called as a case control study. So here the directionality is from outcome to exposure. Okay, your timing is retrospective and sampling. Sampling is always on outcome of matching up. So how many cases are there? That many controls you have to. Okay. Now you have to match the cases and controls. So when you're matching cases and controls, you will come across a particular concept called as confounder. Come across a factor called as confounder. Okay. Now if you look at the image, people from my generation know this movie. This movie is the okay, so it's a triangle love story. If you look at Shah Rukh Khan, he's hugging Kajol here. He's also not leaving the Ani Mukherjee. In here, this one guy is putting his arm around this girl, but this girl is also having an arm. So this is exactly a confound. It's how a confounder will behave. It is present. Here Shah Rukh Khan is present with both exposure and the effect. Okay, I'll tell you. So what are the conditions necessary? Confounding factor must be associated with both risk factor and outcome. For example, you are doing a case control study on people with myocardial infarction and physical fitness. Okay, age becomes a confounder. If you take all young people in the control, okay, then definitely they will not develop myocardial infarction and they'll be physically more fit. If your cases have all old people, and they are physically not fit, chances of myocardial infarction will increase. Yes or no? So your age is associated with physical fitness. So as you grow old, your physical fitness goes down. Chances to develop myocardial infarction also increase. Age here is associated with both physical fitness, also associated with myocardial infarction. So when you're designing a study, you need to take care of that. Okay, you need to. Okay, so what will happen if you do not do it? It will lead to an apparent association. Probably physical fitness was never causing a problem there in myocardial infarction patient. But age which was causing. Probably. Okay. So hence confounder may overestimate the true association or it may underestimate the true. That's why when you are designing any research, whether it is randomized control trial, confounder will come even there also. Okay. Or you are designing a case control study, you have to be very mindful of the confounder. Okay. Even cross-section studies will have. Okay, mind. So then you have the reverse of case control, what we call it as a smart study. Forward looking. The whole design is in reverse of that. You're following a group of smokers and a group of non-smokers and trying to see in future will they develop cancer or not. So it becomes exactly reverse. Okay. Then this is the reason why I have given more emphasis on cross-section study and randomized control trial. Is that because most of us do only two types of study. Mainly, we generally do not do because to conduct a case control study and a call study, you need a lot of backup data. So most of us go for randomized control trial. Hence, I've gone little detail. Here the target population is patients. So already patients are there. Okay, people who are suffering from the disease. To one group, you are giving the new drug, that is treatment group, and to the one more group, you're giving the old drug, what we call it as a control group, and see compare whether the new drug group is better, what the experimental drug is better, or the control drug is better. For example, you want to find out whether Ketorol DT, which is the standard painkiller, is better to reduce dental pain, or the new painkiller which is coming in the market. So you pool in a group of patients who are suffering from dental pain. Half of them you give the new drug, to half of them you give Ketorol DT. Follow them after 1 week and see whether Ketorol DT is better in reducing the pain or the new drug is better. Okay, that is a typical randomized control trial. Understand one thing, that here the target population is patient. That means you start your study with patients only, okay, not with healthy individuals. Now, there are certain points you need to remember. A researcher will deliberately manipulate the independent variable. I told you here to find its influence on independent variable. How will I manipulate the independent variable? To the experimental drug, no, I'll reduce the dosage for one group. One group I'll increase the dosage. One group I'll keep the standard dosage. So I can manipulate the independent variable. It stands at a very higher level in the evidence-based hierarchy, which I'm sure each of you have heard about it. It helps to test the hypothesis. Amazing randomized control trial helps to test the effect of an invention by intervention or experiment. The new drug, no, you are intervening in the patient's health, isn't it? So these are the various phases of a clinical trial, which I'm sure I will not go in detail. I just want to tell you certain things here. Preclinical phase will be there. Phase 1, the dosage is very minimum, 24 hours that being monitored. So this is phase 1 is always done on patients who are volunteers and in a controlled environment. Okay. Say phase 2, then you give the standard drug dosage. Okay. Phase 3 is generally what we do it in our PG time. Okay, when we do in PG, our dissertation, most of the randomized control trial are on phase 3. Phase 4 is used by WHO or any other big organizations to find out the post-marketing surveillance, to find out after giving it to a large number of people across various parts of the world, there any major side effect or what. For example, many of them are now saying that, not now saying it, they're saying that COVID vaccine might be responsible for the increased incidence of heart diseases. How far it's true, we are not yet sure. Okay, because the marketing, still the long-term effects are being seen. There is COVID which is causing, or the COVID vaccine is causing. We are not yet sure. The researchers are not sure. Once it's known, it will be published, obviously. So there are steps. The first step is designing of protocol. This is what your guide will help you for. How to design a protocol. That means the steps that you're going to follow in your randomized control trial. The first is you need to write down the aim and objective of your study. Questions to be answered from your research. What are your inclusion and exclusion criteria? Whom are you going to include and whom are you not going to include? Sample size, sampling technique. What are the procedures for allocating people into the experimental group, that is the study group, or the control group. Treatment to be applied. Where will you apply the treatment? When will you apply? In which stage of the disease you'll apply? How will you apply? That's in vivo or in vitro. Standardization of the working procedure and schedules also you need to maintain. And you also need to conduct a pilot study. Pilot study means before any research, we conduct something called as pilot study. To check whether the study that we are going to do for a large number of population is it feasible or practical or not. Check the practicality and feasibility. We conduct something called as pilot study. Okay. Then selection of target and study and target population. Basically, this is the target population. In purple circle that you're seeing, this is the target population. From this target population, you will select a sampling frame. Okay, and from this sampling frame, you will select your sample. The results that you get from your sample, okay, that is your study population, you will generalize it to your target population. Okay, for that you need the help of a statistician. That is why a correct sample size sampling technique and a correct sample size is needed. Okay, and then you have randomization. The third step, participants, once they enter the study, they will be randomized. They'll be divided into two groups randomly. Help in prevention of selection bias. Okay, and make sure that all the participants are equal at the baseline. The participants should not be aware of the group allocation. Otherwise, they will try to influence the study result. Okay, so this is a typical randomized control flow chart. I have downloaded from the net. So if you can see, CONSORT is the guidelines which we have to follow. Okay, which we have to follow when we are conducting a randomized control trial. So they have given this. So as eligibility, people who are inclusion criteria have entered the study. Okay, and then they are randomized in two groups. Okay, and then their follow-up is done. There are some people who might not be interested, so they are lost to follow up. And then finally, you analyze what is the result. So the same works for the other arm of the study. Okay. Blinding is done, which I'm sure some of you have heard. We have three stages of blinding. The first one, if you're seeing single blind trial, where the participants are patients do not know that they belong to the new drug or the old drug. The second, even the researcher will not know whether they belong to the study group or the control group. In triple blind, if you see the purple one, even the person who analyzes the data, statistician should be blinded to the procedure. So the first stage is only the participants are blinded. In the second stage, participants and the researcher are blinded to the procedure. They do not, nobody knows who is going to which group. Okay, only the head of the department will be knowing it, and the data analyst, the statistician also should not know which group they belong to. Okay. Now the last thing is this is the EBD chart, evidence-based hierarchy of evidence. So if you see randomized control trial stands at the top, apart from meta-analysis and systematic, I have not included that under this for the only simple reason that I was told that my target audience is BDS students. So beyond your understanding, it's only for post-graduation. Okay. So randomized control trial is at the higher level, followed by cohort study. Means if you prove something through a randomized control trial, it is at the benchmark. If you cannot prove through randomized control, if you prove through cohort, it is second best. Case control is next best, and lastly, it is the case report or the case. Okay. I would like to conclude saying that research has to be done. It is an ongoing process. It's not that you do today and you leave it. The type of research that you would like to do depends on what you want to find out, and also your guide who will be there to always help you. Okay, but you have to follow a strict protocol when you're doing the research. Okay, any doubts are there, please feel free to ask. Thank you so much for the opportunity, Dr. Sangamesh, once again, and the Kalinga Institute of Dental Sciences College for thinking that I'll be able to do justice. Hope I have done the justice for the thing. Thank you. Hello.
So for the lecture. Now it's time for the last lecture of the day.
I can leave, madam.
I would like to invite the speaker, and that is Dr. M.D. Jalaluddin, sir. And before proceeding for the valedictory function, this is the last lecture. A brief intro of Sir. Sir is the professor and HOD, Department of Periodontology from Kalinga Institute of Dental Sciences. He is an executive committee member of Indian Society of Periodontology. And the lecture was actually scheduled for yesterday, but because of time shortage, we were not able to proceed with it. So sorry for that, sir, and hence I invite you for the lecture today.
Good afternoon, everyone. You have been sitting here from 9 o'clock onwards, so you will be hoping that I will be completing it very soon, and it is. Right? My topic is about peri-implantitis. You have listened about the implants by Ma'am Aurora ma'am yesterday. Everything what you do in clinical practice, you should know about the complication. How to manage the complication that leads to success in your dental life, dentistry. You do many things. Once you are not able to manage a complication, you are not at all a success in dentistry. Right? So today my topic is peri-implantitis. We place a lot of implants. As you all know, implants are placed for rehabilitation, whether it is for one teeth, two teeth, or full mouth rehabilitation. So once again, I welcome from KIIT University to one and all. Our institute, Kalinga Institute of Dental Sciences, one of the pioneer institute in dentistry. I would thank the CynoDent and Kalinga Institute of Dental Science for choosing me for this podium to deliver a lecture on peri-implantitis. What is peri-implantitis? When there is an inflammation in and around the implant that leads to the mobility by destruction of alveolar bone, that is called peri-implantitis. What are the causes? The causes may be ill-fitting, may be oral hygiene measures not done properly by the patient, systemic diseases, right? Many causes are there. The first and foremost is we should know where to place an implant, what are the indications for implant, how to place the prosthesis. The treatment plan has to be made before going for placement of implant. That is why in dentistry at present we call it prosthetically driven implants. Means first we take a impression, then we prepare the tooth so that we can know how much, what should be the height. We do CBCT, we do clinical examination, width of the bone, everything. It's not that the patient has come for replacement of a tooth and you go for implant. Proper planning, it's not for implant. If you are going for a minor extraction also, you should know the history of the patient. If you are going for a scaling, you should know that whether the patient is hemophilic or not hemophilic. So this is a evidence-based time, evidence-based dentistry. Everything should be evidence-based and it should be properly calculated. Dentistry is success only when it is controlled. Uncontrolled passion doesn't lead to success in dentistry. It leads to failure. Osseointegration, how the implant adheres to the bone, that is what we call functional and structural binding of the implant to the bone, that is called osseointegration, that was given by Bhubaneswar. So these are some of the classification of periodontal disease, peri-implant disease regarding the bone loss. I will go to the clinical cases. This is one more given by Atia et al. According to the 2017 workshop, recently 5 years back, they have classified under peri-implant health, peri-implant leukocytis, peri-implantitis, peri-implant soft and hard tissue deficiency. These are the wall defect of an implant. As you read in periodontics, 1 wall defect, 2 wall defect, 3 wall defect. You imagine implant in the place of a tooth, then you can imagine if there is bone loss, whether it is buccally or lingually or mesially or distally. It has been classified into 1, 2, 3, 4. That is what depicted in the picture. You can see in the first here there is a buccal loss. Surrounded buccal to the mesial and distal. This is total loss, right? So how you need to plan the treatment, whether you need to go for a GTR, whether you need to go for a bone graft, whether you need to go for a block graft. Okay. So classification is only made for the success of the treatment. Once you are not able to classify or come to the diagnosis of any failure, you cannot plan a treatment. The same thing is your first year, so better we should skip over all this. Yes, these are the clinical pictures of peri-implantitis. Once an implant is grade 3 mobile, it cannot be restored, right? Once there is little bit of mobility, grade 1 mobility, grade 2 mobility, it can be managed. Grade 3 mobility till the apex of the implant cannot be managed. It has to be taken out. These are the pathologic mechanism of the possible biofilm. As I told, inflammation process, establishment of peri-implantitis. There are hundreds of reasons for this. This is the diagnosis regarding the probing pocket depth. Bleeding on tooth, separation, probing depth, mobility. How you check a tooth, similarly you check an implant. Non-surgical, without surgery, surgical, resective, regenerative, regenerative. This is the CIST protocol given by Mumbai. Yes, here comes the case. Regenerative means you need to regenerate the bone, right? Resective means you need to cut short the bone, which there are some ledges where there is hindrance of the gingiva to adapt to the bone. There we remove the ledges, we make it smooth so that there will be proper attachment of the mucosa to the bone. There should not be any dead space that will lead to resorption of the bone. So this is the case number 1. You can very well appreciate where the implant has been placed. It is outside the alveolar bone, right? But there was attachment of the bone. That is why it was grade 2 mobility. But for a long-term success, we plan to remove this implant and place it into the bone. This is the implant you can see. So much of dehiscence. Not dehiscence because marginal bone is intact. It is fenestration of the bone, right? We have used the bone grafts to regenerate the bone. Put the GTR, the guided tissue membrane, and suture. 6 months follow-up. Here it is out of the socket. You can very well appreciate this after 12 months, after the placement. Here it is in the bone. If I go back, that has to be placed here. See, here the implant is out of the socket. So what we have done is, we have done a re-entry surgical placement. We have put the implant into its socket. After that, we have grafted with the bone grafts. And 6-month follow-up. Here there is no bone. Very well you can appreciate the thickness of the bone after 12 months. So coming to case number 2. This is a patient from Kolkata. He has placed the implant from last 6 years. There is no mobility in the teeth and the aesthetic is so good, so good. But when we took a CBCT, see, here also as in the case 1, the buccal side, this implant is only attached on the palatal side. Buccal side is not there, but the patient insists that as my tooth is, implant is non-mobile, I won't go for the re-entry surgery. Doctor, you manage it. Once it goes mobile, then I will go for re-entry. What we did is, we reflected the flap. We have put some gastric, bios, bone grafts. And we have sutured it. The next thing what we should do here is connective tissue grafting. Because the thickness of the gingiva, the biotype is very thin. To maintain a good bone, you need to have a very good thickness of the gingiva. This is case number 3. This is a dentistry. She was a dental student here 7 years back, Ankita. We went for the placement of dental implant. Nice reflection. You can see the width of the bone. Nice osteotomy. Very good osteotomy. You can appreciate the osteotomy and the implant is placed in the osteotomy. This is the radiograph, IOPAR. intraoral periapical 2-dimensional radiograph. After 2 months of implant placement, when we went for the prosthesis, she was on a Maryland bridge. When we went for the when we called the patient for the, in fact, the patient came only, sir, there is a swelling in my lips and there is a pus discharge, sir, where you have placed the implant. When we removed the granulation tissue and reflected the flap and removed the granulation tissue, this is the amount of bone loss. We did the bone grafting GTR, but the thing is, what could be the etiologic factor for this bone loss? No plaque, no occlusion interference, the status, periodontal status of 2-1 and 1-2 is good. What could be the etiology, the cause for this bone resorption? Extra torque. What I could find the reason for that in the mist. Osteotomy, when you do, there should be a passive flow of the implant. You should not rush or torque hard the implant. There should not be any pressure on the palatal bone. Absolutely not. It should be very, very passive. First point. Second point. According to the international team of implantology, ITI consensus, what they tell, what I heard from Daniel Boozer and Stephen Chen, whenever you are doing a case in the anteriors, whether you have a thick bone, thin bone, what they ask or advise is to, after the placement of the implant, cover it with the bone grafts. If at all this bone resolves, the bone grafts will be there. That will be forming the bone. If I go back, I will show you. Here it is not clear, but here you can see the U-shaped curvature. That means you have a very, very thin buccal bone, right? You have a very, very thin buccal bone, right? So we need to do, we didn't do, right? That is the result. This happened. Then we did a bone grafting and GTR, guided tissue regeneration. And we sutured it. You can appreciate here in the buccal part of the implant, there is no bone. After grafting, after 6 months, we could have a sigh of relief after seeing the buccal bone. Regeneration of the buccal bone. So when you place an implant, you should know about its complications. First of all, you should know the indications. You should know the possible mechanisms for the etiology of the complications. You should have good armamentarium, right? You should have good grafts. you should have a graft of having osteogenic potential, that is autograft. If not possible, you can have osteoconductive or osteoinductive bone grafts, which is what they have recommended in the systematic reviews. If they are at all, if they are taking an autograft, they are mixing with the genogenic bone graft. Why? Because the autogenous bone grafts tend to resolve very soon, but genogenic bone grafts stays there, right? Implant is a very good modality of rehabilitation of a tooth, but as yesterday Saha sir told, why every time we go for implant, what sir said, it is right. You should not force a patient to place an implant. With sir, I am telling that. When I am coming to the evidence-based, I will differ with the sir's opinion. If you want to replace one tooth with a bridge, right? In the, just below the pontic, there might be resorption of the alveolar bone because there is no active function of that bone. It is a proven fact. It is an evidence-based fact. Plus, we are cutting two teeth. We are compromising two teeth. So in that case, if a patient is able, because it's with a costlier treatment, if a patient has money to spend, then you should always go for an implant. There are studies where they have seen that where they have placed an implant, the bone is intact till the neck of the implant. The other places, suppose in case of a implant supported denture, two implants, these two areas you will be having very good bone, but subsequently the fag and bones tends to resolve. So implant is a very good modality for, and it is the need of the hour, but it's little bit costlier side. And management has to be done, and the patient has to take proper care for that implant. There should be no occlusal discrepancy. You can go to the studies and see there are 20 years of implant placement. Right? How? Regular checkup, right? Prosthetics should be clean, and the patient should maintain a very, very good reliability. Anyway, thank you all for all your patient hearing.
Kindly wait for 10 to 15 minutes. We shall start with the valedictory ceremony soon. Thank you.
So good afternoon, everybody. Before beginning the function, we have our speaker felicitation. So for doing the honors, I would request Principal Sir, Dr. Ashwini Kumarkar Sir, Dr. Jugajyoti Pathi Sir, Thirendra Sir to kindly do the honors, and Dr. Anmol and Dr. Ashish to kindly join on stage. Our first speaker is Dr. Nivedita Sahu ma'am. Huge round of applause, everybody. Dr. Preetham Mohanty sir. Dr. Rajat Mohanty sir.
Thank you, sir and ma'am. Now we'll start with the valedictory function. You may please proceed. Without further ado, I would like to eventually extend my warm greetings and welcome all our dignitaries, speakers, and our dear delegates for the final time.
So we both welcome you to the valedictory function of the 6th World Dental Sciences and the Oral Health Conference organized by Team CynoDent International and Indian Society of Dentistry in collaboration with Kalinga Institute of Dental Sciences, KIIT University, Bhubaneswar, University of Toronto, and University of Genoa.
We had a scheme of the conference in which on 25th and 26th February, we had pre-conference courses and online scientific presentation. On 27th and 28th, that is today, till afternoon before lunch, we had our keynote lectures, scientific paper and poster presentation, awards night followed by the cultural program. Until now, it is continuing with the valedictory function. For the valedictory function, I would like to invite Dr. Jugajyoti Pathi sir for a few words and for addressing the audience present here. Welcome, sir.
Good evening, all. So the 2 days conference is coming to an end now. I hope all the delegates has got some knowledge, sharing of knowledge, and they must have been gone through all the speakers who are there, either offline or online. I also thank to all the participants who are there online since last 2 days. And this conference is definitely a success, and whatever we do in KIIT, it always become a success. So from this time, we are getting associated with CynoDent, and we will be associated with you in future sense also. Because once we get associated with any of the organization, we always maintain that our founder sir has taught us that how to maintain relationship. So definitely we'll do that. And along with that, all our interns, all our students, first year, second year, third year, final year, जो भी students हैं यहाँ पे, I am really thankful to you all and all the organizers. Organizing a event with such a short notice. God bless you all. Jai Jagannath.
Thank you for those lovely words, sir. I would invite Dr. Ashish Chandra to kindly address the gathering.
Good evening, everyone. Thanks a lot, respected party sir, Ashwani sir, Dhiren sir, Sanmesh sir, and everyone of the team Kalinga, and from the team CynoDent. Special thanks to Dr. Anmol and all the team members, Pratishtha, Lakshmi, and everyone who are there and who supported us day and nights. And thanks a lot to all the delegates for making this event a very successful and a grand event. A special thanks to everyone. Thanks a lot. Thank you.
Thank you, sir, for your precious words. Now it's time for the felicitation of our guests, dignitaries, delegates, etc., that you all must be eagerly waiting for. And it is a ritual of the valedictory function which marks the end of the conference, but not our relation and connection with each other being a part of the same fraternity. So firstly, I would like to invite our respected dignitaries on the stage to start with the felicitation ceremony. Dr. Jugajyoti Pathi sir, Dr. Anmol Bagaria ma'am, and Dr. Ashish Chandra sir, along with our respected principal sir. So firstly, there is felicitation of Dr. Jugajyoti Pathi sir and Dr. Ashwini Kumarkar sir, our respective principal sir, by Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir. We would also like to present bouquet. Now it's time to felicitate the organizers and the backbone of CynoDent International and ISD, and that is the reason we all are present here today, together and connected. I personally would like to extend my heartfelt thanks on behalf of everyone present here to Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir, and uncle and auntie, that is Dr. Anmol Bagaria ma'am's parents. I would like to say that these are the people and this is the reason for such bewildering conferences each year, and the efforts by ma'am, sir, uncle, auntie are beyond words and are commendable. The reason CynoDent is what it is today is all because of their efforts and time, and most of all their behavior, because they have treated us all as their family and never compromised with us anyway. Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir, uncle, auntie, thank you for being the best mentors, the best guides, and our parents here in CynoDent. Thank you. I would request Pati sir and our respected principal sir to felicitate ma'am. Thank you, everyone. I would request our respected dignitaries to stay on stage to continue with the felicitation. So there are various categories that are up for felicitation today. The first one that is to be felicitated is the organizing committee of KIIT.
Dr. Sangamesh, sir. Very dear Dr. Dhirendra Singh, sir. Round of applause, everybody. Srishti Goyal.
Dr. MD Jalaluddin sir.
Goyal, ma'am. Dr. Ranjan. Dr. Subbalakshmi.
So now, after the organizing team from KIIT, now it's time for felicitation of the organizing committee of CynoDent. Dr. Abhishek Dubey sir.
Dr. Noman Sheikh. My co-host, Dr. Anam Siddiqui. Dr. Vinayaka.
Dr. Lakshmi Pandey ma'am. And the one and only Dr. Prateek Bam sir. Now it's time to felicitate the CR team of KIIT. And from first year, the felicitation is of Sambit Dash and Anisha Shamim Alam.
From third year, we have Radhe Shyam Singh and Sankeeta Mohapatra. Radhe Shyam Singh
and Sanketika Mohapatra.
from final years, Vishweshwar and Antula Kumari. Vishweshwar and Antula Kumari. From interns, Shankar Shubhra Chakrabarti and Payushini Ganguly.
Now it's time for the organizing team from KIIT. Richik Chakraborty, Pritesh Chanda, and Shweta Abhilakshmi. Madhushmita Mojumdar,
Vaishali Panda,
वो शुभमन को बुला लीजिए उनके लिए बुला रहे हैं नहीं शुभमन को बुला
Shrishti ma'am, we invite you for getting felicitated on stage. She's part of the organizing committee from KIIT. Now it's time to felicitate the volunteers of KIIT.
So are you हाँ last में आगे
So now it's the time for the volunteers from KIIT team. Shankar Shubhra Chakrabarti. Like everybody to join on stage. Richik Chakrabarti, Payushini Ganguly, Antara Bhattacharya, Anashwa Ghosh, Aditya Pandey, Madhushmita Majumdar, Shweta Bhanakshmi, Vaishali Panda, Shriyanshu.
Now the next group is Anisha Nandi, Radhe Shyam Singh, Shreya Mishra, Sambit Dash, Manisha, Pritish Chanda, Vishweshwar Mishra, Shaili Ghosh, Soumyadeep, Shubhashish Dash, Lakshya Raut, and Shubhajit. Please give a round of applause for them.
Now the cultural coordinators, Antara Bhattacharya, Anashwa Ghosh, Vasudha Mandal, Ayashini Ganguly, Debolina Ghosh, and Shankar Shubra Chakraborty.
I would request the cultural coordinator head to collect the memento on behalf of the whole team, and the rest of the people can collect their mementos from backstage later on. You all can join this, come on the stage, but please collect the mementos later on from backstage. Now the Rang team, Sukanya Biswas, Akansha Haldar, Mehli Matti, Molly Seth, Ishan Srivastav. Only the cultural coordinator head or the committee head is going to collect the memento on behalf of the whole team. Ishan Srivastav, B. Anurag, Swati Kumar, Komal Agrawal,
Anyone from Khwab team? Akash. The rest members from the team are Akash, Radhisham, Anisha, Avinash, Sambit, Shubham, Dr. Prasad, Shubhajit, Aditya, Soumya, Manisha, and Drishti. Big round of applause, everybody.
So from the music team, Sanchari, you can collect the memento on behalf of the whole team. And the rest of the names are Ankita Chakraborty, Ananya Ghosh, Diksha Swaroop, Pragya Shrestha, and Richard Chakraborty. Please give a huge round of applause for the music team, guys. Only the head is collecting the memento for now on stage, but rest of the team will also get the memento and certificates afterwards. So the next team is Khoe Panne team, and the memento goes to Shweta Samal.
One for the Rangoli team, Srishti Pandey, Manisha Mishra, Riddhi Ray.
From the dance team, Simran Ahmed can collect the memento on behalf of the whole team. Rest team members are Shrija Mrinal, Shabda Das Rakshit, Sakshi, Smarnika, Ritika, Sikha, and Rajshri. Now it's the time for the results that we have all been waiting for, the offline paper presentation category. So from slot 1, third position for the offline paper presentation in the UG category goes to Abhilasha Sharma and Devapriya Kundu.
Abhilasha Sharma and Devapriya Kundu. Third prize for slot 1. Second prize goes to Trinanjali Pera.
And the first position for the category of offline paper presentation UG level goes to Sanchari Bhaumik and Shweta Samal. Please give them a good round of applause.
Slot 2, the third prize is shared by Dr. Yagna Seni Mandal and Anushka Saxena, both graduates. Yagna Seni Mandal and Anushka Saxena.
The second prize is shared by Dr. Spandita Das and Dr. Asima Samal. Dr. Spandita and Dr. Asima.
And the first prize goes to Samiksha Jina. Coming to the poster presentations, the third prize goes to Spandan Barui and Sohadriya Roy. Spandan Barui, Sohadriya Roy.
The second prize for offline poster presentation, UG level, goes to Shrija Jha and Dr. Richik Chakraborty.
And the first prize goes to Dr. Radheshyam Singh.
We would also like to felicitate our caterers who had served us delicious food, and that is Indramani ji. From the organizing committee of KIIT, we have Dr. Shubhalakshmi with us. Please, ma'am, come on the stage.
So with this, we come an end to our valedictory function. It was a wonderful time, everybody. Thank you so much. I would now invite Dr. Anmol Pagadia for a vote of thanks. Thank you so much, sir.
Thank you, everyone. Thank you, sir. Thank you, ma'am.
Good evening, everyone. Firstly, I would extend my heartfelt gratitude to our dear founder, sir. Today also in morning, I met him and Patil sir was there along with us. His words of wisdom always inspire us every moment. And the university which he has made is inspiration to all other universities to build it at this extent and to work actually for the benefit of education. And it is true that education can eradicate poverty, which is his quote line, which the vision of building KIIT was also this. So I extend my heartfelt gratitude to our dear founder, sir, for giving us this platform. I extend my sincere thanks to our dear Patil sir and Virendra sir and Sandesh sir. Also, my thanks to our dear principal sir and all the students from UG to PGs and also our dear faculty members of Kalinga Institute of Dental Sciences. Thank you for treating us as a family and thank you for being there for us 24/7. And you were there, and I would also thank entire team of CynoDent, Dr. Abhishek Dubey, Dr. Pradeep Bam, Dr. Anam, Dr. Noman, Dr. Lakshmi, Dr. Vinayaka, and also Dr. Ashish Chandra. Without him, I don't think any conferences in CynoDent would be possible. And all the team to be there with us in whichever location we choose. You travel anyhow and you reach us. Thank you so much. And this collaboration of CynoDent and KIIT University, we would surely bring new and new things for you all. And we would work together to uplift our system of education and to cross all the boundaries to make something good for our society and to uplift our honorable professions. Thank you one and all for joining us. I also thank all the online delegates and offline. Obviously, offline are there here, but online also you were glued to your computer screens, you were watching us. Thank you for your patience and thank you everyone for giving us your valuable time. Thank you everyone for trusting us, supporting us always. Thank you.
Once again, thank you everyone for being a part of our journey here and this evening. And let us end this evening by national anthem.
Janagana Mana Adhinayaka Jayane Bharata Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Uttara Banga Vindhya Himachala Yamuna Ganga Ujjala Janadhitaranga शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
भारत माता की
Thank you everyone.
There's a short announcement to all the registered delegates. There's a complimentary aligner course from Team CynoDent for all of you all who have registered. So it is tomorrow 2 p.m. So to all the registered delegates in this hall only. So kindly be present. And this is not just an end, this is a beginning of a revolution with CynoDent for the KIIT team. Thank you so much.